gentlemen, and welcome to the Hepatitis Elimination Summit. My name is Paloma, and I will be your host for the day. Before we begin, may I please request everyone to double check that your mobile phones are on silent mode. Thank you so much. It's wonderful to have you all here today to a gathering of global minds committed to turning possibility into action. Today we unite science, policy, and community to accelerate the path to a hepatitis-free future. At the Hepatitis Elimination Summit, we're not just discussing change, we're driving it. So once again, ladies and gentlemen, thank you all so much, each and every one of you, for being here with us today. As you already know, we have a very power-packed day ahead. Some of the best minds will all be gathered here today under one roof, both physically and virtually. So we have a very, very special speaker to kickstart the day ahead. To do the honors and welcome him, I'd like to call upon the one and only Dr. Vivekanandan to join us on stage and give him a very special welcome. Dr. Vivek, over to you.
Morning, everyone, and it's not customary for me to come on stage and introduce someone before they speak, but I think I should introduce Dr. John Ward. Can we have him on the screen? Can we see him, please? Oh, there is John Ward, and a great friend of ours. He's going to speak to us from Atlanta, and it's 11 p.m. in the night. John, thank you very much. A few words about John Ward is he was one of the previous directors of HIV hepatitis in CDC Atlanta. Now he heads an organization called Coalition for Global Hepatitis Elimination, a passionate worker for or against hepatitis. He travels around the world for at least 15 days a month, educating people about viral hepatitis, changing policies, advising governments in various capacities. John has been a great supporter of Chennai Liver Foundation. We've been working together for very many years now together, and we work very, very closely. Apart from all this work, one interesting fact about John is that he bicycles. I think last calendar year, he rode about 40,000 miles. Is that right, John? Yeah.
5,000 miles.
Oh, 5,000, okay. 5,000 miles is still about 10,000, close to about 8,000, 9,000 kilometers in a calendar year, right? And John is 70 this year and is still going very, very strong. So John, thank you very much for your passion, your leadership, your support for all of us. And the stage is all yours, John. Thank you.
Well, thank you very much, Vivek. It's great to be a part of these zonal meetings to advance progress toward hepatitis elimination in India. Even though our goals for hepatitis elimination are global, the work to accomplish those goals are local. And so that's why it's so important for each and every one of you to step forward and join together locally to improve prevention of hepatitis B through vaccination, prevention of both hepatitis B and hepatitis C by improving the safety of healthcare, improving the safety in communities from blood exposures that can lead to transmission of these infections, and then importantly, screening and linkage to life-saving care and treatment. Let me see if I can get my slides to share here just for a few more comments, please. Let's see if they'll let me. I'm not able to share, but let me try one more time. Well, In any event, why is hepatitis elimination important? It's because we can save millions of lives from chronic liver disease, liver scarring known as liver cirrhosis, and liver cancer, which is caused by both hepatitis B and hepatitis C infection. You know, it's a big ambitious goal to reach these milestones in improving health. And that's why it's really important to have partnerships. And that's why after many years of directing the Division of Viral Hepatitis at the US CDC, I moved over to the Task Force for Global Health because of their experience in bringing together coalitions to eliminate diseases globally, such as polio and neglected tropical diseases. And building on that experience, I wanted to bring together the partners needed to achieve our goals for hepatitis B and hepatitis C elimination. And when I think of those partnerships, I'm thinking of civil society, such as the great work that the Shanghai Liver Foundation is doing and making possible this meeting today. Thinking about academic physicians who study and are experts in hepatitis. I'm thinking about health systems. I'm thinking about political leaders. I'm thinking about industry. And I'm thinking about key partnerships such as the World Health Organization and others. The coalition, works in many ways to bring those partnerships together. And over our 6 years of being in this business, we have expanded our partnerships globally and helping those partners be connected and sharing their expertise and their resources so that we can all do more together than we could individually. For example, we work with countries to develop profiles, bringing together the data that reveals their plans, their progress, and policies toward hepatitis B and hepatitis C elimination. Those are up on our website at globalhep.org. We are in the process of developing one for India to join with the ones for 38 countries that are already available. We have started at the United Nations, the first United Nations group of friends to eliminate hepatitis. So you may ask, well, what is a UN group of friends to eliminate hepatitis? It's a way traditionally for countries to come together at the United Nations on issues of common concern. And they're called group of friends because otherwise it would take a very complicated treaty for everybody to work out how they were going to work together. There had not been one for hepatitis elimination previously, so in 2022, we set about encouraging member states to come together for the first group of friends. We had 12 nations come together, led by the country of Egypt, that has been far along in their efforts to eliminate hepatitis C in the country. And so with those 12 countries and the leadership of Egypt, we started the group of friends. That group of friends has met every year at the time of the UN General Assembly, and it has grown from 12 countries to 64 countries. And it's influencing United Nations resolutions so that they include hepatitis elimination. It's influencing work at the World Health Assembly in Geneva that's met every year. And it's really provides another way for us to bring countries together. One key area that needs to be improved is testing and linkage to care and treatment. As of the 300 million people living with hepatitis around the world, most of those people remain undiagnosed and are slowly progressing toward, and many of whom are progressing toward end-stage liver disease and liver cancer. And that is a future that we can avert toward good health rather than premature mortality from liver disease. But we need to get those people tested and linkage to care and treatment. So we help countries evaluate their testing and linkage to care programs. We call them hepatitis evaluations to amplify testing and treatment, or HEAT assessments. We've done this now in about 6 countries around the world. They have led to the country of Ghana in Africa start their first national hepatitis C elimination program with the assistance of the country of Egypt in providing medications produced in Egypt that are very effective in curing hepatitis C. We have helped Nigeria develop new plans for hepatitis testing and linkage to care, as we have had from Malawi as well in Africa. We've helped Uruguay convince their Minister of Health to begin to provide testing and treatment for hepatitis at no charge to the people of Uruguay. In January of this year, we, in collaboration with the Chennai Liver Foundation, started the first India Hepatitis Summit that was held in Chennai that really brought people from all over India together, that has led us today to these first zonal meetings. These zonal meetings are very important because India is a very large country, differences in the patterns of hepatitis transmission, the number of people infected, and the different health systems and community organizations involved to improve prevention, testing, and treatment. We're going to continue to be involved in this and all the other zonal meetings to see how we can share lessons learned globally while also learning from you, because this is very much a coalition where we all learn from each other to achieve our shared commitment of eliminating hepatitis as a public health threat by 2030. Thank you again for the opportunity to speak with you. I wish you the best for your day together, and I look forward to working with you to eliminate hepatitis. Thank you. Thank you very much.
Thank you, John, for that very illustrative and very encouraging remarks at the beginning of this hepatitis summit, and your commitment to elimination over the years, right from your days at CDC and onwards now at the task force. I had the personal experience of interacting with a number of occasions. So it has been very encouraging, and it's a very positive message that you have conveyed, that we need to work together, and the importance of the partnership, which is the theme of this summit now. Thank you very much for your address.
Thank you. Thank you.
Can we have a big round of applause, ladies and gentlemen, for Dr. John Ward tuning in all the way from Atlanta just for us. So thank you so much, Doctor. We'll now move on to our next section. As I said, we have a power-packed day, ladies and gentlemen, so we're going to jump right in. Our next session is Global and Regional Hepatitis Burden, and I'd like to is the recent burden estimates of hepatitis and its complications, and our first session within that will be Global and Regional Hepatitis Burden. I'd like to invite our chairs to take the stage, so we request you to give a round of applause as they step forward, starting off with Dr. Gerard Maria Selvam, Additional Director, National Health Mission, Tamil Nadu, a senior epidemiologist with extensive experience in TB control, field epidemiology and public health system strengthening, former Deputy Director of the World Bank, supported the Tamil Nadu Health Systems Project, and a major contributor to national public health programs. Can we have a big round of applause for Dr. Gerard Maria Selvam? Next, I'd like to call upon Dr. P. Piramanayagam, Consultant, Medical Gastroenterology, Apollo Hospital, an expert in managing complex GI conditions including IBS, pancreatitis, cirrhosis, Crohn's disease, hepatitis C, and gallbladder stones. Thank you so much for joining us here, Doctor. Let's give him a big round of applause as he takes the stage, ladies and gentlemen. We'd like to invite Dr. Malarvili and welcome her on stage. She's a consulting gastroenterologist. Thank you so much, Doctor, for joining us here today for this session. Can we give her a big round of applause, ladies and gentlemen? We now hand over to our chairs for this session.
So, good morning, everybody. It's a great pleasure to be able to be present today to chair this very important session. It is a time of reflection for all of us to look at this very important problem we encounter in our health system. So, when it comes to your hepatitis and its complications, we need to have a clear understanding of its burden. The burden in terms of global, regional, national, and within our country at the state level. The estimates available, do they really reflect the actual burden? Are we far from the estimates which are brought out to our knowledge? That is one point we should think about. The other important point is where we are in terms of knowing our exact estimate and also taking the measures to address the gaps in addressing this problem. All of us are aware that we have a national program for this viral hepatitis control, and we know that a lot of measures are also being taken under the National Health Mission. While we carry on with our program activities, it is equally important to have scientific sessions like this, where we sit together and then look at our testing methodology, our testing capacity, our coverage, and if any shortcomings or gaps are there, how do we address? While we do that, we should also look at what are the evolving evidence in the testing methodology and whether we can catch up with the many other scientific evidence pouring in. I'm very sure that along with my co-chair, madam, we should be able to have a very insightful session today with wonderful resource persons, and they will definitely take us on the right path through the burden, through the overview of the program, and the heat, especially hepatitis evaluation to amplify testing, and what are the different kind of modeling available, economic modeling or economic evaluation of the type of point of care devices available in the market now. I'm sure this session will definitely be a good starting point for all of us. I pass this mic to my co-chair.
Regional hepatitis burden, may I invite Dr. Reshu Agarwal. Dr. Reshu Agarwal is a technical lead, HIV and hepatitis, WHO of India. She leads the diagnostic support program at ILBS. She has conducted national trainings for healthcare professionals under projects like Prakash, ECHO, and LEAD. Over to you, ma'am.
Hi, good morning. Good morning, everyone. Am I audible?
Yes, ma'am.
And are my slides visible?
Yes, ma'am.
Thanks so much for confirming. So at the outset, I would really want to compliment the organizers for organizing the summit and really thank them for having WHO in this summit. And as discussed, I would be talking about hepatitis B and C burden gaps and what are the priorities we need to have in terms of meeting the elimination targets. So as far as hepatitis is concerned, our strategy is actually guided by the Global Health Sector Strategies, which was announced in 2022 and is valid till 2030. The other component which we have as an add-on component to the hepatitis elimination is the triple elimination of vertical transmission of HIV, syphilis, and hepatitis B. And this initiative is actually influenced by the UN Secretary General's Global Strategy for Women's, Children, and Adolescent Health 2016 to 2030. And at the core, we really want to have like more of person-centered services where people are at the core and really are taken care. Just talking more about the triple elimination initiative. So there are very clear-cut guidelines, and we see this as an opportunity to pave way for the overall elimination of the disease infections, as well as a catalyst to actually improve the overall MCH services as well. So on hepatitis, the elimination targets are very clear, and what we are envisaging is that by 2030, we should be able to end hepatitis as a public health threat. Now, talking about the burden, I think why we are so much concerned about viral hepatitis is that it is the only communicable disease for which the mortality is actually increasing. So nowadays, what we are seeing is a demographic shift, and what we are seeing is like more of NCDs taking a center stage. But still, viral hepatitis, along with TB, is really a communicable disease, which is a cause of concern for us. And there are nearly 304 million people living with HBV and HCV together, 254 with HBV and 50 million with Hep C. There are 2.2 million infections happening every year for HBV and HCV, and nearly 1.3 million people died in 2022, and this mortality was actually up by almost 0.2 million. Just to give you the snapshot that every day, nearly 6,000 people really get infected and 3,500 people die because of the hepatitis. In terms of the distribution of the burden globally, 2/3 of the global burden is actually shared by 10 countries. And since we are talking about India here, so India is one of the high burden countries, both for hepatitis B as well as HCV. Now, talking about the global coverage for hepatitis testing and treatment, most of the people, they really remain undiagnosed and they are not linked to the treatment. For hepatitis B, only 15% of the people are aware of the status that they are infected with HBV globally, and only 3% were receiving treatment in 2022. For HCV, the situation is comparatively better. Nearly 40% of the people were aware of their status and 20% were receiving treatment. Now, talking about the CR region, so just to give you some background, that the CR actually constitutes of 10 countries, which has nearly 2 billion people. So for CR, the hepatitis B burden is around 61 million, and for hepatitis C, we have nearly 9 million people. Every year, normally 266,000 people get infected with HBV and 225 with HCV, and the deaths caused are nearly 218,000 for HBV and 42,000 for HCV. And this data includes Indonesia, which was part of the CR region earlier. Also, something which is very concerning for the region is that up to 30% of the new HCV infections are due to the unsafe medical injections in the CR region, and this is something which is really preventable and needs attention. Talking about the care cascade in the region, of course, I think as we saw for the global data, we also are really lagging behind in terms of reaching the people. So only 33% of, so we have nearly the 33% of the people who are diagnosed every year, and of those diagnosed, only 7% are actually receiving treatment. Similarly, for HCV, the cascade for 2015 to 24, it shows that only 12% people were diagnosed and 8% received treatment. So for the CR region, I think liver cancer is coming as a very important piece which is being highlighted now. It's an invisible epidemic, and we are seeing rising trends in terms of the liver cancers. And in the graphs which are shown here, you can, especially in the left below graph, you can see what we are seeing, that in males, the liver cancers are comparatively increasing. Even when on the right side, you see that liver cancers are taking center stage when we are talking about the top 10 cancers which are really impacting people. So talking about the impact of HBV in Southeast Asia, so what we are seeing is, for HBV, there is a gradual reduction in the overall prevalence. The new infections are going down, but what we are seeing is the increase in the hepatocellular carcinomas and liver-related deaths, and which means that the people who were infected maybe way back are now getting into their middle ages and coming out with the symptoms. For HCV, the viremic infection is almost static. The new chronic infections are almost static, and the cancer rates are actually increasing, and the liver-related deaths are also increasing. We really have some good news on the EMTCT for HIV, syphilis, and HPV in the CR region. So Thailand was actually validated for HIV and syphilis in 2016, Sri Lanka in 2019, and we had a new addition very recently that Maldives actually became the first country to be validated for triple elimination of all the 3 infections, HIV, syphilis, and hepatitis B, and it has become the first country globally to achieve this kind of goal. But what we are seeing is the high burden countries are really lagging behind, and perhaps what we need is a more tailorized approach for the high burden countries. So as I discussed earlier, I think the elimination goals for viral hepatitis are very clear, and the WHO guidelines, they give a very clear framework of the elimination goals and very well-defined targets, which include the incidence target, mortality target, and the program targets. And this is something which is doable. So in terms of the elimination target or the impact targets, what we are aiming is at a 95% reduction in incidence and 65% reduction in the mortality, both for HBV and HCV, as compared to the 2015 baseline. Also, in absolute terms, for HBV EMTCT, the rate of HBsAg prevalence should be less than 0.1% in the children who are less than 5 years. And the annual mortality should be less than 6 per 100,000 people. Similarly, for HCV, the annual incidence should be less than 5 people per 100,000 people. And for PWIDs, it should be less than 2 per 100. And the annual mortality should be less than per 1,000. And then there are program targets in terms of the coverage for vaccination for Hep B and for coverage of testing and treatment both for Hep B and Hep C. Also, I would want to mention here that in addition to these targets, there is a way of path to elimination. So obviously, I think these targets are really the benchmarks and really very high to achieve. But then countries can even think of the path to elimination, where they can even think of a bronze, silver, or a gold tier before they really achieve the actual validation for the elimination. So I think something which has come out very clearly, as is shown, is for the CR region, is that most cancers, the liver cancers, are because of the Hep B and Hep C, and it is very important to tackle this problem today so that our tomorrow is not impacted. And that's where I think active case finding for both for HPV and HCV, linkage to care and treatment is really critical. So some of the strategic priorities for the elimination of hepatitis for the CR region are basically advocacy and partnership for continued political and financial commitments, prevention, testing, and treatment, and which means that we really need to have like more of simplification and integration and decentralization of the services, especially to the primary care. Use of the innovations like digital technology, digital health, and also the multi-pronged or multiplex testing. Engagement with the community in a more meaningful way, and of course, the data use, because a lot of data is being produced in the region. What we need is to use this data in better way for decision making. So just to summarize, the elimination of hepatitis is based on the set of actions, which is basically preventing the new infections and treating those who are infected. Of course, liver cancer is preventable, and most of the cancer cases in CR are because of Hep B and C, and the early detection would really help us to really have better tomorrow. Concrete actions are needed to scale up in terms of the service delivery and reaching more and more people with blood safety, universal precautions, condom for key populations, harm reductions for PWIDs, and infection and prevention, and the safe injections. The triple elimination targets are really critical, and we need to test and treat everyone. Thanks. With this, I would end my talk, and I'm happy to take any questions. Thank you so much.
Thank you, ma'am. That was a very informative session, especially on the focus of prevention and the liver cancer. Thank you, ma'am. And we have a small change in the program. There is going to be an inaugural address after this program. I hand over the stage to the organizing team for the conduct of the inaugural program.
Thank you so much to our chairs. Can we give them a big round of applause, ladies and gentlemen? Requesting you to please have a seat, and we'll invite you back on stage shortly. Ladies and gentlemen, we will now proceed with the inaugural ceremony. Our chief guest has joined us and will be entering the hall in just a few moments. Thank you. So ladies and gentlemen, once again, we welcome one and all to the Hepatitis Elimination Summit, and we begin with a special video on the journey of the Chennai Liver Foundation, who have been promoting liver health for the past 25 years, founded by Dr. R.P. Shanmugam. Can we have the special video, please?
I started Chennai Liver Foundation way back in 1998. I decided to do something to my patients who are lying with the liver diseases. So if you know that you have got viral infection in the body in the initial stage itself, then you can prevent the liver disease. Chennai Liver Foundation is doing the same thing, going to villages, our state especially. We do test the hepatitis viral infections in the body and do whether you got a fatty liver, whether you got a diabetes, whether you got a hypertension, all go together, and which will affect the liver later stage. This is my ambition, that everybody should be checked up completely, and by 2030 we can eradicate the viral infection from the society at least by 90%. That is the WHO aim, and we too take part in this as an NGO.
My name is Srinivasan Swami. I've been associated with Chennai Liver Foundation for more than a decade now. I first met Dr. Vivekananda when my Acharyan, Aragya Singer, had to undergo liver transplant. Both Dr. Shanmugam and Vivekananda have been very passionate about sorting out the problem, and it is the most prevalent disease that detected early and then solution to be found but I think the journey has begun in the right earnest manner, and I'm sure Dr. Shanmugam and Dr. Vivekanandan would help many of us discover for ourselves the problem that is inherent. I wish them all success. Thank you.
The Chennai Liver Foundation, we are dedicated to improving lives through liver health awareness, prevention and care. And as a proud board member of the Chennai Liver Foundation, I'm here to support initiatives that bring hope to those affected by liver diseases. Join us in this journey, whether as a volunteer, a donor, or simply by spreading the word. Your support can make a huge difference. Together, let's build a community of health, hope, and healing.
At Chennai Liver Foundation, we believe that liver health is a responsibility that we all need to share, and we believe in equity of healthcare. Our mission is to educate the people and make sure that priority liver care is affordable and accessible to everyone who deserves it. We have patient support groups where the patients are a good advocate by themselves and tell the public as to how they've been cured of liver disease. Research is part of our core, and we do a lot of research these days along with multiple organizations, including the premier organization like the ICMR or the Indian Council for Medical Research. Funding is there for the foundation, and hence we request all of you to support us and join us in this movement of providing a liver disease-free society and making sure that no one dies in India of liver disease in the near future. Thank you.
I think that deserves a round of applause, ladies and gentlemen. Some truly amazing work by the Chennai Liver Foundation. And since we are talking about mega events and mega milestones, we should definitely talk about the International Hepatitis Summit, a first of its kind summit on viral hepatitis in India. The event in January was extremely well attended. I'm sure all of you read about it in multiple publications. We had some of the best minds and personalities in the industry here at the event, but I think we have a video that would depict it perfectly. So can we have the video, please? Turn your attention to the screens, ladies and gentlemen. All right, on that note, ladies and gentlemen, I'd like to invite our dignitaries to please take a seat on the dais, starting off with, of course, Dr. R.P. Shanmugam, founder of the Chennai Liver Foundation. As you all know, he's India's first certified gastroenterologist who's performed the country's first ever liver transplant in 1996, over 55 years of clinical experience, and he is a liver disease survivor who leads community awareness camps, advancing national efforts towards viral hepatitis elimination. This all would not be possible without him, so thank you so much, Doctor, for all of your efforts. Next, I'd like to call upon Dr. Vivekanandan, Managing Trustee of the Chennai Liver Foundation, also a leading liver transplant surgeon with 25+ years of experience. And we'd like to welcome our chief guest for this evening, Dr. Erilan Naganathan, member of the Legislative Assembly and member of State Planning Commission, Tamil Nadu. And he's the MLA of the Thousand Lights and member of the Tamil Nadu State Planning Commission, contributing to key areas such as health, urban planning, climate action, water, sanitation, and administrative reforms. Thank you so much for joining us here this morning, Doctor. And to further welcome you all, I'd like to call upon Dr. R.P. Shanmugam, Doctor calling you forward to officially deliver the welcome address.
Morning to everybody. It's my pleasure to invite you all for this summit, which is probably it has become a regular affair of our organization, so that the tempo is maintained all through, so that the aim of our eliminating the disease, that is preventable disease, from our society is achieved by 2030 as per the WHO's program. It's my pleasure to invite Dr. Erilan, who is known very well throughout our states, probably from other states also, by his dynamic activities through his legislature activities and through the health system also. I welcome Dr. Erilan for this meeting, and I am expecting him to support us throughout his career, so that he is also part of this team to eliminate this disease as a doctor and as a politician. I welcome Dr. Erilan and every one of you. I welcome especially Dr. Diwari from ILBS Delhi, who has traveled all the way from Delhi to our place to participate as usual. He is one of our strong supporters throughout, because he was in WHO earlier, throughout our career. This is for your kind information. Anyhow, I'll stop here. I'll welcome you all once again. Thank you.
Ladies and gentlemen, we now request everyone to kindly stand for the Tamil Thai Vartha. Thank you. I now request Dr. R.P. Shanmugam to please felicitate our chief guest, Dr. Erilan. I now invite our chief guest, Dr. Erilan Naganathan, member of the Legislative Assembly and member of State Planning Commission, Tamil Nadu, to please address the gathering.
Good morning to all. I congratulate Chennai Liver Foundation for this wonderful initiative of Hepatitis Elimination Summit. I really congratulate our founder, Shanmugam sir, to an inspirational personality in the medical fraternity, to initiate this particular drive, which is very vital. And as you know, hepatitis has been following this typical iceberg phenomenon, what we see in our SPM textbooks, where only a tip of the iceberg is visible and we are treating it. And what about the submerged portion? So this type of summits will play an anchor role to bring various stakeholders in this campaign of hepatitis elimination in one conclave or one shelter, so that transfers of ideas and success stories of various initiatives of various organizations can be implemented in this particular state. Actually, I want to cite one typical example of the role of similar type of summits, especially in government policy making. Way back in 1990s, in Madras University, there was a conference on health economics. Then cardiothoracic professor Dr. Victor Solomon presented a small paper in that particular department function, where there was a rising incidence of acute rheumatic fever and increased incidence of rheumatic heart disease due to that acute rheumatic fever. As various medical fraternity doctors, filaments would know that predominant our exam cases regarding cardiology will be a valvular heart disease, will be a rheumatic valvular heart disease. That's the amount of incidence it was. So the paper said we should have a community approach in handling acute rheumatic fever. So where's a felt need? They thought that school students were coming to government public schools as well as private schools. Whenever they were identified with fever, with migratory joint pain, the teachers have to identify those children and they have to refer them to a primary health center doctor. That's a simple approach program they gave. So that particular teacher will be trained to identify the cases with fever, with rash, with migratory joint pain, and refer to a primary health center doctor, where the primary health center doctor will enroll the particular kids in a school health program and will deliver penicillin shots or penicillin tablets. This was a scheme of things presented in a department function in Madras University. The HOD of that particular department was my father, Professor Nagarajan, who was a walking med for Kalangar, was then Chief Minister in 1996. They presented this initiative to the Chief Minister. What the Chief Minister did is, he called the entire health department, school health department, public health authorities, as well as the finance department in one shelter. He gave the name called Varvali Thittam for that particular program, so that every teachers will be trained in a mass phenomenon to identify the children with fever, with joint pain. Then each children will be given an yellow card. With this yellow card, which has the entire schedule of penicillin shots to be taken, or penicillin tablets will be taken, free accessible of those tablets as well as penicillin injections were made available in primary health center depending upon the caseload. So the program started in 96. It went on successfully for more than 10 to 15 years. The rheumatic heart disease incidence in Tamil Nadu, it was 24%, is reduced to 0.9% now. Now, our medical college students find it difficult to find a rheumatic heart disease cases for the examinations on the lighter side. What I'm trying to impress here is the contribution of knowledge minds outside the system who have a technical expertise. When it collaborates with the government machinery, the impact is surmountable. So that is what Chennai Liver Foundation is trying to do or replicate here, is to integrate various stakeholders from various areas, put them together, formulate a policy for this hepatitis elimination campaign. So that's what the fundamentals are same. You should have a bottom-up approach, yes. Understanding the disease burden, yes. Formulate screening protocols, yes. Proper financial allocation from the top order, yes. With the political will and synergy, will lead to a successful program. If any of this particular road network, a block is there, then it will be a theoretical exercise for every one of us. So the deliberations of this particular conference should chalk out a roadmap to identify what crux of the problem of the bottom submerged iceberg, how to improvise our screening protocols at various levels. We would say in a very proud fashion that Tamil Nadu has taken phenomenal strides in health sector, both in public and private health system. But only defect which I see as 4.5 years of a legislative member, as well as a practicing physician, we operate in silos. We need a proper orchestra to sync and synergize. Saying so, by default, a wonderful program we called Makkal Thediya Maruthum, which has got an UN award. I congratulate the Public Health Department for phenomenal functioning of screening NCD diseases. So around 2.5 crore people are being met by a dedicated health worker to screen for hypertension and diabetes. They measure capillary blood sugar strips, give monthly tablets of hypertension and diabetes so that the NCDs, the decreased incidence of NCD, detection rates have improved so that the drug compliance is established so that the tertiary delivery of end organ damage is prevented. Yes. Now we got a wonderful workforce. Now this workforce should be trained to identify various screening parameters of this particular hepatitis component. So since rapid spot test is surmountably available, all the pre-surgical cases, we get rapid spot detection for hepatitis C, as well as HIV, which has been available in pre-op status as a routine screening surgical procedure. So this type of mass screening program will able to detect the submerged phenomenon to identify that. For that, the financial logistics, ably aided and guided by NGOs and CSR activities, should be incorporated to identify the disease burden per se. That is one. And number two, Tamil Nadu did a phenomenal stride that early to start with hepatitis B vaccination into our vaccination schedules. And we do a wonderful prenatal screening program for all pregnant ladies or book cases for hepatitis B and hepatitis C and ELISA. Yes, phenomenally done. But regarding the treatment component for hepatitis B and treatment component for hepatitis C. See, coming to treatment component for hepatitis C is the directly acting antiviral drug with the sofosbuvir combination should be made available at the primary health center level, so that the screening of Makkal Thediya Maruthum loads of cases, as well as since after advent of COVID, we did a phenomenal approach in detection of viral diseases, especially in PCRs. So the PCR kits are very much available. Some startup should be collaborated out to channelize those PCR kits or PCR machines to detect hepatitis C, RNA assessment load, or viral hepatitis B DNA load should be identified, so that after assessment level, availability of medications kits, so that we can have an eradication campaign, should be decentralized at the primary health center level. That's one. And for hepatitis B, availability should be similar for hepatitis C with proper follow-up system in primary health center level, district hospital level. Our tertiary care institutions should collaborate more in research and R&D development. We have hepatology clinic, but our tertiary medical care institutions are dealing with secondary care health services and primary health care services. High time that we have to escalate our tertiary care institutions into research and R&D to manifest, to identify. So that integration should be done with an infectious disease department, microbiology department, as well as hepatology clinic, because it's just a clinical affair in an hepatology clinic. There's no much of communication in medical colleges with the microbiology department or the infectious disease department or the pathology department per se. So some type of integration network should be happening at the hepatology clinic per se. Friends, and a lasting note, see, after advent of this digital health component, right, we have huge amount of sensors after the diabetic load. Really, I'm worried. What about the pinned sensors for sugar monitoring in households. Every 3 or 4 patients in Chennai city, I see they have this patch. Where they are disposing the needles? It's a big question. We have huge amount of capillary sugar measurement with pricks. What happened to who's disposing those needles? It is being dumped into our normal sewage or dumped into the normal garbage clearance. So a huge amount of medical related blood and blood exposed products who are finished products of digital component of assessment has been thrown into the general dump. So the awareness has to begin there. We have to differentiate how to pack that particular capillary strips, or those needles, or the insulin syringes which has been used as a routine affair, all the digital devices which has a small pin which is pricked into the subcutaneous region of each and every one individual. And there's a huge entity called tattoo. So there's a tattoo culture in the city. We don't know how the tattoo clinics are being brought into surveillance, how they are screened for hepatitis B, are they doing proper instrumentation? Because Clinical Establishment Act covers a small clinic or a lab. What about this cosmetic tattoo clinics? Are they being brought into this particular ambit? So these are the fine areas where we have to collaborate with the Pollution Control Board as well as the environment health program, so that to incorporate these finer components or unknown, unexplored components which into our day-to-day usage, unless we have to cater or we have a 360-degree holistic approach, our campaign in this elimination will be a long-time warfare. With those notes, congratulate all the fellow members who participated in this campaign. And I am one of the campaigners, or I would say I'm here to help in this particular eradication and elimination campaign. Success to this particular conference. Good evening, good afternoon, and good morning to all. Have a very successful deliberations, and we'll be looking out the final points arriving out of this particular summit, so that it will be an action points in government policy making body. Thank you.
Thank you so much to our chief guest, Dr. Erilin. Thank you for being here. We appreciate all of your support. I would now like to call upon Dr. Vivekanandan to please deliver the closing remarks.
Morning. Hepatitis elimination is a possibility. It is a reality today. Why? Because we have the science, we have the technology, we have the amazing health infrastructure in Tamil Nadu. Of course, we have people like you who are working on the ground. And more than that, we have leadership like this, like our beloved chief guest, who's been prime and who's been helping us and willing to help us in this elimination. And so thank you very much for being here. Thank you very much for leading us, inspiring. And even when first time I went to him, we sat there and discussed, and he's talking about hepatitis B treatment, hepatitis C treatment. I was so surprised that he was really up to speed of what is happening. So thank you once again. Of course, I'm missing 2 other people on dais today. One is our most dynamic MD NHM, Dr. Arun Tamraj. He's again held up somewhere, and I would like to place on record that he's been instrumental and prime in this meeting. He was quite keen that this should happen. He will be here sometime during the daytime, and he's going to address all of you also. I would like to thank him very much for this meeting, and of course our most ever-friendly department of DPH. I've worked with about 3-4 DPHs till date, and they've been so friendly. Dr. Vinay, Dr. Sampath, everyone has been amazing and supporting all of us. So I hope you enjoy this day as much as I enjoyed putting this together, and help us all eliminate hepatitis. Thank you very much, and have a good day today. Thank you.
Once again, thank you so much to all of our dignitaries for joining us here today. As we come to the close of the inauguration, we'd like to end with a group photograph, and then we will carry on with the rest of today's proceedings. Doctor, if you would please join us with our chief guest for a photograph. Thank you. Thank you so much. Thank you. Can we have another round of applause, ladies and gentlemen, for our esteemed chief guest for joining us here and making this moment even more special. Thank you. Thank you, Doctor.
There are currently 325 million people worldwide living with a deadly disease in their blood. Are you one of them? 325 million. That's the equivalent of the entire population of the United States of America. What's worse is that 290 million of them are completely unaware of their infection. An infection which could destroy their liver and lead to life-threatening illness. Are you one of them? 9 in 10 people are totally unaware they are living with viral hepatitis. And since viral hepatitis has very few recognizable signs or symptoms, how would you know that you are one of the missing millions? You could have got it at childbirth, passed from your mother. You may have got it through unsafe injecting practices or by sharing a razor, or coming into contact with infected blood. It's likely that you won't know when you got it. If you don't get tested, you'll remain in the dark. Viral hepatitis is one of the leading causes of death worldwide, claiming 4,000 lives a day. But if you don't know your status, what chance do you have? However, this doesn't need to be your future. There is a cure available for hepatitis C, and vaccines and effective treatments against hepatitis B. So why not eliminate viral hepatitis for good? We need to find the missing millions. If we can find the people unaware of their status, we can save lives, and we can eliminate viral hepatitis from the planet by 2030.
Ladies and gentlemen, I now invite our chairs once again to take the stage, calling on Dr. Gerard Maria Selvam, Dr. Malarvili, and Dr. P. Pirumanayagam. Can we have you on stage, please? Thank you so much to our chairs, and I now hand over this session to you.
Good morning to all. I thank the organizers for inviting me for this wonderful summit. So we'll get going with the next topic. May I request Dr. P.B. Revari to give us overview on National Viral Hepatitis Control Program. May I invite sir. He is a visiting professor of epidemiology and clinical research at ILBS New Delhi. He's a former WHO regional advisor for viral hepatitis, HIV, and STIs in Southeast Asia. He led the India's first ART program to become the world's second largest program, and is a fellow of Royal College of Physicians, Ireland, and the Vice Dean of Association of Physicians of India. Over to you, sir. Thank you.
Ladies and gentlemen, I now invite our chairs once again to take the stage, calling on Dr. Gerard Maria Selvam, Dr. Malarvili, and Dr. P. Pirumanayagam. Can we have you on stage, please? Thank you so much to our chairs, and I now hand over this session to you.
Good morning to all. I thank the organizers for inviting me for this wonderful summit. So we'll get going with the next topic. May I request Dr. P.B. Revari to give us overview on National Viral Hepatitis Control Program. May I invite sir. He is a visiting professor of epidemiology and clinical research at ILBS New Delhi. He's a former WHO regional advisor for viral hepatitis, HIV, and STIs in Southeast Asia. He led India's first ART program to become the world's second largest program, and is a fellow of Royal College of Physicians, Ireland, and the Vice Dean of Association of Physicians of India. Over to you, sir. Thank you.
Respected chairpersons, thanks for this opportunity. Legendary Dr. R.P. Shanmugam, Dr. Vivek, dynamic secretary of this conference and the Chennai Liver Foundation. Delegates, participants, I bring you greetings from Institute of Liver and Biliary Sciences on behalf of Dr. S.K. Sarin. As you just heard from the chief guest that the incidence of rheumatic fever was brought down from 24% to 0.9%. So when we are talking of hepatitis elimination by 2030, just 5 years down the line, as a public health threat, it may be a dream, but it is possible, as Dr. Vivek also said. And it is possible if we work together as a team along with the national program, and this summit and the January 1st Hepatitis Summit is a step in that direction that all stakeholders need to contribute in raising awareness, bringing the science and bringing the things on the platform that we are working together as a one force. So you just heard basically in the previous session about the global prevalence. We have got 304 million people living with viral hepatitis B and C, but what was also pointed out that there are more than 6,000 new infections happening every day. So by the time we are through this summit, we will have more than 2,000 new hepatitis infection already happened, and that is a cause of concern, and more than 3,500 deaths every day. You already had overview of the global and regional burden in Southeast Asia, and it was also pointed out that India has got 11.7% of the total HBV infection and 11.2% of total hepatitis C infection. I know there's a lot of data that you had in the morning and again, but we need to know the burden. 3 crore people live with the hepatitis B and 55 lakhs with hepatitis C. It's a big number, though the prevalence is low, but we have a huge population, so our burden becomes very significant. So let us see what is the scenario in India, what is the burden, exact burden in different age groups. That was more of a overview. So this data basically comes from the surveillance, which is National Family Health Survey, round 4, and also the viral hepatitis control program took a decision in the beginning that we will not duplicate efforts and we will basically piggyback and work with the existing system. And NACO already had a HIV sentinel surveillance system already in place. So this data, additional hepatitis B, C surveillance was added to that. And as per the structure of the HHS, basically, various groups were covered, which included basically antenatal care clinics, prison inmates, high-risk groups, which included sex workers, intravenous drug users, MSM, transgender, and migrant populations also. Almost more than 5 lakh people were basically subjected to a questionnaire where we collected the information on socio-demographic information, what is the knowledge about hepatitis B and C, and just to give you an idea of the sample size, from each antenatal care clinic, about 400 samples were collected. When we say antenatal clinic, basically we are talking about the general population, and that gives you an estimate about the prevalence in the general population. And this is what basically came out from that. And the national seroprevalence of hepatitis B in India is 0.85%. That is well below the WHO classification, which says less than 2%, you are into low prevalence category, but then 0.85% for a large country like India becomes problematic in terms of number. But if what you see on the screen is basically that though the 0.85% is the national prevalence, you have a number of states which are above. At least 7, 8 states are above the national prevalence, and some of the states you may not even think of. States like Bihar, 1.4%, Mizoram people will understand, but Delhi again having 1.2%. So there is a significant variation between the different states. But what is more important to know, it is not about the general population only. There are risk groups which are high risk groups, and prevalence in them may be 4 to 5 times higher than the general population. That is the area of concern. And later in the day, we have a session whereby we'll be talking about how we focus on the high risk groups, how we have the screening in those groups and link them to the care and the treatment. Because B prevalence among intravenous drug users is 3%, among sex workers is 0.95%, among men having sex with them it is 1.36%, and transgender it is 0.97%. Point I'm trying to make is not to show you different figures, but yes, when we talk of the testing strategies, we need to know where we need to focus, where we need to get the maximum, because screening whole population of the country will not be an ideal scenario in terms of the cost, in terms of yield, in terms of operational issues. So we really need to have testing strategies which focus on specific populations. And of course, these are some population, but also other high-risk groups and people with the abnormal liver function tests, physicians, family members of the already hepatitis B positive people. Prisons is another group where the prevalence is significantly high. Similarly, if we see the data of hepatitis C in India, basically the prevalence is 0.29%. But again, if you see some of the states, almost again, 8 states have got prevalence which is higher than the national prevalence, and this includes Mizoram, Punjab, Haryana, Uttarakhand. What is significant here, we know that Mizoram has got a problem, huge problem of drug use. Punjab we know is a problem of drug use. There have been films like Udta Punjab and all, but why Haryana? Why Haryana has got such a high prevalence? And here it comes where you saw in the earlier presentation, almost in Southeast Asia, 30% of the hepatitis C are due to unsafe injections. So Haryana is one state where we don't have many of the people injecting drug user, and it is the unsafe practices. It is not only the doctors who are responsible, it is sometimes patients also because of lack of education. You know, it is a common practice in some of the villages that patient will not get satisfied unless he gets an injection and he gets a IV drip. That is a scenario, and that is where the infection comes from medical practices. But a very new point which even I never thought of was highlighted by our chief guest about the insulin testing kits. We are using the steroids, we are using those bits. I don't know how much of that is contributing, but that is one area I don't think which has received any attention, not in my knowledge. So it is very important that when we talk of hepatitis C, we have a broader approach to all possible causes where the bloodborne infections can happen. See, this is 33% hepatitis C prevalence among injecting drug users. And if you go to Mizoram, Meghalaya, and Arunachal, it is touching almost 80%, 70% of this. There has been decline in recent past in injecting drug use with the vast efforts by National AIDS Control Program, targeted intervention program, which has reached to people injecting drug users and moving them to opioid substitution therapies, providing needle syringe exchange program, but still we are having significant people who get hepatitis C. Similarly, among different high-risk groups, we have got very high prevalence among sex workers, men having sex with men, among prisons. We all know that prisons are one setting where you should not have any MSM activity, you should not have basically injecting drug use because you are in a closed setting, but still the prevalence is so high. So prisons is a very, very important area where we need to concentrate in terms of when we talk of hepatitis elimination. So when we talk of co-infection with B and C, basically co-infection with B and C is seen in intravenous drug users almost 2%, antenatal clinic attendance 0.01%. Again, prison inmates have got B and C co-infections. Similarly, when we talk of HIV and hepatitis B, hepatitis 3.5% of PL-HIV have got hepatitis B and 1.2%. And the NACO guidelines very clearly say that all people coming to HIV testing and registering at ART center should have got their hepatitis B and C testing done. But availability of kits in the past was a major issue, but now with the National Viral Hepatitis Control Program, coordinating very closely with National AIDS Control Program, that there is a synergy between two, and hepatitis B detection and management is improving. So moving a little bit to the National Viral Hepatitis Control Program, I think people in this audience are well aware of the program because we have got public health people from the Department of Public Health and NHM. So I'll just quickly glance through. The program was launched on 28th July 2018 on occasion of World Hepatitis Day by the Honorable Health Minister. And number of stakeholders played a key role both from the government organization, academic institutions, and NGOs played a role in designing and launch of this program, and which was expanded in 2019 to include hepatitis B also. The hepatitis control program basically aims to combat and hepatitis and achieve countrywide elimination, which is in line with the SDG target 3.3, that we combat and achieve elimination of hepatitis as a public health threat. And it has been shown in the previous, by the previous speaker, that this means basically we should have 90% reduction in new infections and 65% reduction in the mortality. That is the target we have. Also basically reduce the risk and morbidity. So objectives of programs are basically, in addition to increasing the testing and treatment facilities, which has been done on a wide scale over last 6 years or so, it is also to enhance the community awareness, also develop standard diagnostic and treatment protocols, strengthen the infrastructure within the existing health system, and also provide linkage with the other national programs. The program has been working on raising awareness among the general population through a number of activities, through immunization, focusing on increasing the bird dose particularly, and over the last few years, the bird dose coverage in India has increased significantly from 66% or so a few years back to almost 89 to 90%, which is a big achievement that bird dose coverage has increased. But we also need to focus on the bird dose coverage among, the hepatitis B vaccination among high-risk groups and healthcare workers. I'm not sure about the latest data, but when ILBS did a study in Delhi, in the capital of country, basically, among 3 medical colleges, less than 30% of the healthcare workers were immunized. I'm not saying vaccinated, immunized. So difference between vaccination and immunization is that you know your titer, whether you are protected or not, what is your anti-HBs titer. So less than 30% were immunized. So we really need to focus on that. So I'll just move through that. Key components were on diagnosis and treatment, monitoring and evaluation, building the capacity of the healthcare worker, and all these activities have taken place significantly over the last 6 years. So viral hepatitis control program basically has also basically integrated and synergized with the other programs, like if you see the injection safety, the blood safety program, with the surveillance for viral hepatitis with National AIDS Control Organization, harm reduction in key populations, and to focus on A&E, they are also working with the Ministry of Water, Sanitation, Biomedical Waste Management, and also with other programs like tuberculosis, cancer control program. The importance of cancer was highlighted in the previous session also, that if we are able to tackle the cancer, today we are going to save the costs and lives saved in the future. Service delivery, I think you are all aware, I will not go into details, but this is more for completing that. You have got different laboratories at the different levels of healthcare, which can provide rapid tests to ELISA, to basically RT-PCR, and then we have got different levels of healthcare facilities where you have model treatment centers, which will basically are focusing on complicated cases, those with the cirrhosis. All this basically is from the National Operational Guidelines, Hepatitis Treatment Center, and the structure of the HR at these centers. So to conclude, basically, as of now, this may not be very updated data, but this is up to December 2023. There are almost 978 treatment centers across 711 districts. So all districts of the country have got a treatment center, and where there is a high burden, they have got model treatment centers also. Almost 9 crore people have been screened. More than 300,000 people received the treatment till December 2023, and more than 5,000 people have been trained. Some of the awareness activities that has been held in the past basically involved the celebrities and other institutions and organizations. So to summarize, India has got a huge burden of hepatitis B and C. Viral hepatitis control program has made an impact. Training of healthcare workers, availability of drugs at all districts, substantial number of people have been treated, but we have miles to go. I don't think the viral hepatitis control program alone can lead to the elimination, and efforts like this hepatitis elimination summits where we raise the awareness, bring the stakeholders together, will definitely go a long way in strengthening the hands of the program and working towards our elimination goal. Thank you very much.
Thank you, sir. And it is integration at all stages, sir. And this is one of the example of decentralization and diversifying the public health, where we get the medications even at the primary health center level. Thank you, sir.
Requesting Dr. Gerard Maria Selvam to please felicitate Dr. Rewari, if you do the honors. Can we have a round of applause, ladies and gentlemen? Thank you, Doctor.
Next, we go on to a very important session, which is going to be the epidemiological overview and disease burden, HEAT, HEAT, hepatitis evaluation to amplify testing. We have with us Dr. Vaishnavi, the project coordinator of Chennai Liver Foundation, who is a public health researcher supporting evidence-based work and has been actively involved in coordinating health screening camps and community outreach activities. So we have an appropriate person to talk to us on this important topic. Welcome.
Good morning, everyone. So today I'm presenting our project findings. Today I'm presenting our project findings on epidemiological overview of hepatitis burden and testing capacity. The project, this is collaborated in coordination with ICMR, NI and DPH and funded by Task Force for Global Health. So why do we need to assess the capacity of laboratory testing? So globally, we all know it's around 1.3 million deaths occur every year due to hepatitis B and C. And in India, the burden is a huge burden. Around 40 million HBV infection and 6 to 12 million of HCV infection is there. So there's a WHO goal to eliminate viral hepatitis by 2030. And the key target for this is to increase the testing of hepatitis B. That is the only way for the prevention and the treatment of hepatitis B and C. So we all know that many people are still unaware and undetected of their infection. As I already said, for this, since there is a limited testing infrastructure, so we had gone with this study. So the objective of our studies was divided into two phases, phase 1 and phase 2. In the phase 1, we created the evidence synthesis of the burden of hepatitis testing, in which we tried to synthesize the seroprevalence of hepatitis B and C, to describe the proportion of time, place and person, and to describe the distribution of laboratory testing methods. And in the phase 2, we had explored the testing capacity across the labs in Tiruvallur district. So coming to our phase 1, we had included around 89 studies, in which around 61 studies for HBV and 69 for HCV. And most of the studies were hospital-based studies. So we found out for the hepatitis B infection, there was a seroprevalence of 3%, and it was similar across all the regions. And in general population, the proportion of hepatitis B was more. And for hepatitis C, we saw that the seroprevalence was around 4%, and it was more in east and north regions of across India. And in both, the testing methods were usually the rapid test and ELISA. For the phase 2, we had gone with, to assess the laboratory testing methods across all the 14 blocks of Tiruvallur district. So we had surveyed around 282 facilities across all the 14 blocks of Tiruvallur district, as you can see. So our findings were that around 70% of the facilities had testing capacity, but still there is a gap of 30% which didn't have the capacity, testing capacity. And if we talk about sector-wise, around 72% of those which had testing capacities were private facilities, whereas 30% were public. The hepatitis test, among those 200 facilities which had hepatitis, most of the tests were done for hepatitis B, and then 50% were tests for hepatitis C. So in most of the public facilities, hepatitis B's testing is there, whereas hepatitis C has to be increased. And the most common method across all these facilities were rapid diagnostics tests, and then comes the confirmatory tests like ELISA, CLIA, and PCR. So in conclusion, we can say that we need to increase our hepatitis testing capacity so that we can achieve the WHO goal of elimination of viral hepatitis by 2030. Thank you.
Thank you, Vaishnavi. It was a good study and compilation of studies, yes. Doctor, kindly identify yourself and pose the question.
Dr. Sivasubramaniam from Salem. Prevalence of C is 4%.
Yes, sir.
So more than the B, how can it be possible?
So that was for our SRMA studies, sir. So most of the facilities were community hospital-based studies. So it can be a bias, so we're still looking into it.
It can't be, it's unlikely.
So we had...
No.
Maybe I can little bit throw a light towards that. This is a systematic review meta-analysis. These are all based on the published studies. Since all the published studies of hepatitis C are either from the high-risk group or those people who had attended into those testing centers in the tertiary care. We have mentioned in that particular limitation. Because of that, this meta-estimate of the proportion is very high, which is true actually. That is not the true reflection of what is there in the community prevalence, which is the right possibility. Thank you.
Thank you, sir.
Thank you. We'll move on to the next topic.
Just before that, requesting our chairs to please hand over a token of appreciation. Vaishnavi, if you would please join us on stage once again. Can we have a round of applause from the audience? Thank you.
Thank you. Now, may we request Dr. M. Santosh Kumar to deliver his lecture on the seroprevalence of hepatitis A virus infection in India in 2021. Dr. Santosh Kumar is a scientist cadet of the ICMR National Institute of Epidemiology. He's a faculty member of the ICMR School of Public Health with expertise in epidemiological research. He leads and collaborates on large-scale seroprevalence studies across diverse populations and has been a key contributor to India's ICMR COVID-19 serosurveillance, co-authoring major papers on SARS-CoV-2 prevalence and immunity trends. With this expertise, we would like to hear from him about the seroprevalence of hepatitis A virus in India. Over to you, sir.
Yes, sir. Thank you, sir, and thank you, the organizers, for giving me this opportunity. So I'll be very briefly presenting our study on hepatitis A seroprevalence in India. Like we used the COVID-19, like we did the 4 rounds of COVID-19 serosurveys in India. We used the 4th round of serosurvey samples and tested them for hepatitis A and hepatitis E virus infection against IgG antibodies. So this is a paper published in Lancet Regional Health a couple of months back. So WHO recommends countries to do seroepidemiological studies to classify a geographical area according to the endemicity. Like the WHO recommends, like if the seroprevalence is more than 90% by the age of 10 years, then the area is classified as high endemicity. If the seroprevalence is less than 90% by 10 years, and if it is more than 50% by 15 years, then it is an intermediate endemicity. And if it is less than 50% by 15 years and more than 50% by 30 years, then it is low. If it is even by age of 30 years, if it is less than 50%, then an area is classified as very low. So the WHO recommends introducing the hepatitis A vaccine in the universal immunization program if it is in the intermediate or low endemicity. So we did a review of seroepidemiological studies published in India in the literature. So we identified 104 studies and 32 studies reported the seroprevalence data on hepatitis A. And then we found that 6 of the studies fall into the high endemicity and then 10 in the intermediate endemicity. But when we look at the studies by the timeline, like most studies published in 1980s and 1990s, so they were reporting high endemicity. But the studies after the year 2000, it shows a shift in the endemicity from high endemicity to the intermediate endemicity. So we stratified the age groups into 6 to 10, 11 to 15, and 16 to 30 years to classify our seroprevalence according to the WHO classification of endemicity. So this COVID-19 sero survey we did in 70 randomly selected districts across 20 states and 1 union territory, and we tested 14,000 samples from 6 years to 30 years using the Architect Abbott assay. And then we estimated the overall and state-specific seroprevalence with a 95% confidence interval. You can see in the map the seroprevalence, it was, most of the Indian states had a intermediate endemicity. The seroprevalence was very high in states like Uttar Pradesh. By the age of 10 years, they reached almost 90%, but whereas in Kerala, even by the age of 30 years, it is around 50%. So very low endemicity in Kerala, which is corroborated by evidences from the outbreak investigation. We also reviewed the published literature from on hepatitis A outbreaks in Kerala. We found very high attack rates among the adults category, whereas in the other region, other parts of the country, it's mostly in children and adolescents the outbreaks were reported, hepatitis A outbreaks were reported. By going by point estimates, surprisingly, West Bengal had a low hepatitis A endemicity, but when we looked at the 5 to 11 years 95% confidence interval, it was going above the 50%. So we could not certainly classify whether it's an intermediate endemicity or low endemicity in West Bengal. So the age-specific seroprevalence curve shows that as age increases, seroprevalence increases, and you can see in Kerala very low seroprevalence even in adults. So the limitations, we got a very limited, because COVID-19 sero surveys, it was done with the COVID-19, estimating the COVID-19 seroprevalence as a aim. So we had a smaller sample size, particularly for small states like Himachal Pradesh, Haryana. We had a very limited sample size, particularly in the younger age groups. So the precision for classification may not be sufficient for these smaller states, but it gave an idea at the national level where we are in terms of hepatitis A endemicity. So our findings indicate at national level we have intermediate endemicity with high endemicity in Uttar Pradesh and low endemicity in Kerala. While this data supports the introduction of hepatitis A vaccination in the universal immunization program, but we also need to look at the disease burden data and then the cost effectiveness to guide the evidence-based policy decision. Thank you.
Thank you, sir. It was interesting. I mean, could you use the same samples also to check for hepatitis E? Because there is a pipeline of hepatitis E vaccine which is likely to be or going to be introduced this month.
Yes,
so do we have any data on that as well?
Yes, sir, we have completed the testing and we have almost analyzed the data. It's not ready to present here. So maybe in a couple of months, we will be publishing the paper on hepatitis E, where we have used samples from 6 years and above all age group, and we tested for hepatitis E virus as well. So actually, the prime interest of the Gates Foundation was to test for hepatitis E, and then in addition, we tested for hepatitis A. So we'll be soon publishing those findings.
Okay. I mean, So, I mean, what we see now is more of like some, not an endemic kind of hepatitis A. Sometimes we have sporadic outbreaks in certain pockets.
Yes, sir.
Particularly in young adults, that is coming up in Tamil Nadu as well. I think a couple of
Yes.
years back, we had a fair number of patients who had hepatitis A coming up, but then again it subsided. Any specific reason that you could contribute? Because by the age of 20, 30, I think in Tamil Nadu also about 80% have seropositivity there.
Yes, sir. Maybe like the shift is happening, like in Kerala, the most outbreaks for the past 20 years, I think I reviewed 7, 8 outbreaks. All of them reported high attack rates in the adults. Maybe we are also moving towards that direction when we move towards lower seroprevalence. Maybe I can show you, I think the slides are not visible. I have the data for Tamil Nadu specifically because I thought there will be some questions. Only 3 districts we did the study, like even by 10 years of age, we are reaching almost the point estimate, you can see like 55%. Like less than 90%, even 89% also can be classified as intermediate, but we are reaching almost 50% by the age of 10 years. So that age shift is happening, so we may see among the younger adults increased incidence of severe disease, or as you are saying, like maybe we have to think of having a vaccine for hepatitis A. But we need to have those data on the clinical burden while making this decision. That's what.
I have a comment, sir.
Yes.
Though our focus is on B and C, and
Yes.
hepatitis A cannot be written off.
Yes.
Recently, we had a sporadic outbreak in one of the reputed colleges in Bhopal, Madhya Pradesh, where there were reported deaths due to acute liver failure. Thanks for bringing this, doctor. Thank you.
Thank you.
Requesting our chairs to do the honors and present a token of our appreciation. Thank you so much, Doctor.
Come to the end of the session. The last topic is the economic evaluation of rapid point of care screening for hepatitis elimination. To deliver this talk, we have Dr. Akhil from the ICMR NIRT. Over to you, doctor. Come to the end of the session. The last topic is the economic evaluation of rapid point of care screening for hepatitis elimination. To deliver this talk, we have Dr. Akhil from the ICMR NIRT. Over to you, doctor.
So, good morning, everyone. This session was supposed to be delivered by Dr. Karigalan, but due to an emergency, I will be delivering instead for him. So, the backdrop has already been set. So, previous speakers has told about the prevalence, incidence, and the need, and the economic burden, the disease burden, and the importance of screening. So, at the backdrop in 2018, when the national program was launched, the government of Tamil Nadu and the HTA team in ICMR NIRT plan to undertook this study, and this was delivered. So the aim of the study was to find out the cost effectiveness of HBV and HCV infection at primary healthcare facilities. So the objectives were to estimate the QALYs, the ICES. These are economic jargons. I will try to simplify it. ICES is a metric to understand whether the intervention or the program is cost effective. And QALY is quality adjusted life years. So we also estimated the out-of-pocket expenditure for the screening of HBV and HCV in the primary healthcare facilities. So the methodology, the population was high-risk population for HBV and HCV, and the target audience were hospitals and the primary healthcare centers. So the interventions were the screening and treatment for HBV and the vaccination for HBV, and the screening and treatment for HCV. So the comparator or the comparison was current scenario. So this is how we do economic evaluation, and this is a case of cost utility analysis. So these are economic modeling methods. So the time horizon was a lifetime. What it means is like the cohort was followed till death. And what we use here is a hybrid model which includes a decision tree and a Markov model. And we used something called as a societal perspective. Exactly an abridged societal perspective. It means we included the entire healthcare cost along with the out-of-pocket expenditure cost for the analysis. So moving on to the decision tree for the HPV. So the target population, the cohort moves into the model. They will either have the current scenario or the screening at PHC, and they can be positive, and they will follow through the ELISA at tertiary if they are positive, or they will follow through the vaccine if they are negative for the RDT at PHC. And in case of current scenario, they will follow through the ELISA at tertiary, and in case of positive, in both arms, they will follow into the Markov model. So the Markov had 7 states, with death state being the observing state. So the transition, the entry into the asymptomatic and the transition into each of these health states were modeled for the 1,000 people. So these disease parameters, the transitional probabilities all came from literature. These are things which we input into the model to understand how the transition happens and the progress happens inside the model till death for the entire cohort. So we included the vaccine cost, we included the delivery cost, we included the total treatment cost from the national programs, and quality of life were taken from the literature. And a systematic review was actually conducted to understand the percentage of pool prevalence for the HBV among key population. This was undertaken in 2019. So these were the population which we found from the systematic review, from the highest in the people living with HIV, and we used an all-pooled estimate of 3 for the particular model. So coming to the result, what we found was the intervention is cost effective. In exact terms, it is dominant. If you can look at the lowermost row, you will see a negativizer. What it essentially means, we gained more QALYs with lesser cost. As in, the intervention in consideration is more cost effective than the comparator. As in, the screening strategy is much cost effective than the comparator or the current scenario at 2019. So this is a cost effectiveness plane where we actually look into the joint uncertainty. It is nothing. We simulate the same result for 1,000 or 5,000 Monte Carlo simulation to understand how the results vary. This is a form of a sensitivity analysis, and we found that most of the results stay in the cost effectiveness quadrant or the dominant quadrant of our interest. So in summary, we found that screening for HPV at PHC level and treating HPV in earlier stages cost saving, or it's a dominant strategy, and we can actually undertake vaccinate HPV negative persons in gaining more QALYs. So the hepatitis C is also a similar model with the decision tree and Markov following the same structures, and I will move through the result. So here also we found that it is a dominant strategy, as in the screening is cost effective than the current strategy. So if you look at it, it's a negativizer, which indicates that we gained more QALYs with lesser cost, or the screening gained more QALYs with a lesser cost than the current scenario. So this is also the sensitivity analysis, which indicate the probability of the evidence, and we can see everything is in the southwest quadrant, which indicates it's a dominant strategy. This is something which is called as a tornado diagram in sensitivity analysis, where we look at each parameters to understand which is the most influencing parameter for the ICER. So here we found that the quality of life for the asymptomatic was the one which was causing the more change in the ICER, which is very normal, and we found that none of the other parameters were creating change in ICERs. So in summary, we found that when compared to the tertiary level screening strategy, the point of care screening strategy actually gained more QALYs for the model cohort of 1,000 population, and it is a dominant strategy, and we are gaining more QALYs with lesser cost. So this results and the policy briefs were produced to the government of Tamil Nadu, and we had already published these papers, and it has also been undertaken by DHR. Thank you.
Thank you, Doctor.
Any questions from the floor? So, I mean, given these two strategies that we compared, how many more people, I mean, I understand this was a cost analysis paradigm that you looked at, but how many more people, in simple terms, were we able to identify by introducing the screening test in the PHC as compared to a screening test in a tertiary care hospital?
Yeah. So, we actually looked at the deaths averted, but we didn't look at the excess number of people which we were able to identify.
Okay.
So that, like, it was done in 2019. Then immediately I believe it got approved from the government, and they undertook for the screening and process. So that was consideration.
So 4 deaths were averted for every. More deaths were averted by this.
I believe for the HCV, it is for the cohort actually, 1,000 people. So if the cohort increases, like, the numbers that's averted will increase.
Sure.
That's how it works.
Thank you so much.
I just want to touch upon 2 important points out of your Markov model of analysis. One is you mentioned 294 deaths out of 1,000 were averted for hepatitis B virus. Is it correct? 294 deaths out of 1,000 were averted.
Yes, sir. Discounted was actually 132, sir. There is like undiscounted. Undiscounted for any health.
Speak closer to mic.
For any health technology assessment, there is a concept called as discounting. Like for in India, we have set it at 3% for both cost and outcomes. So it's like discounting for the future cost and outcomes. So that is where you have 2 results, undiscounted and discounted. The undiscounted is 293. The discounted results is 132.
132. The other point I wanted to ask is, you have brought an important point for a policy implication. That is, at the primary health center level, we should also introduce screening for hepatitis C virus, as we do for hepatitis B virus.
Yes.
What are the other supportive evidences? Can you share some of the supportive evidence from other studies or from other country experience?
Basically, since it's a modeling exercises, so there are many other models across the globe, so which has shown the same results, as in the screening is cost effective and it can be implemented at a tertiary level. Or what they are asking for is a decentralized screening strategy for these hepatitis B and C.
The real-time settings, no? The real-time settings, are there any studies done with regard to hepatitis C virus?
So, sorry sir, I am unaware of those one. I am like a health economist, so it's like out of my scope actually.
Okay.
We come to the end of the session, and we are glad we are keeping up the time.
Thank you so much. Requesting our chairs to please felicitate Dr. Akil. Please do the honors. Thank you. And now I would like to call upon Dr. Ganesh Kumar P. to felicitate our chairs for a wonderful session. If you would please do the honors. So once again, let's give a big round of applause to Dr. Malarviri, Dr. Gerard Maria Selvam, and Dr. Pirmanayagam for kick-starting this day with a wonderful session. Thank you so much. Thank you. Our next session is on diagnosis, prevention, and challenges. I'd like to invite our two chairs to take the stage, starting off with Dr. Kaveri, the Joint Director, King Institute, Chennai. Dr. Kaveri leads virology research and diagnostic development, including COVID-19 and dengue biomarker studies. She provides academic guidance through lectures on emerging viral diseases and serves as a reviewer for scientific journals. Welcome, Doctor. We request you to please take the stage. Joining her for this session is Dr. Tasneem Banu, Professor, Institute of Microbiology, Madras Medical College. Dr. Tasneem is a former director in charge with active roles in HIC and NABH committees. She's a dedicated mentor to numerous postgraduate and PhD trainees. Welcome, Dr. Tasneem. Can we give both our chairs a round of applause as I hand over this session?
Very good morning to everyone, and thanks to the organizers for having given us the opportunity on behalf of the co-chair too. And we welcome this august audience to the third session, which should be on diagnosis, prevention, and challenges in hepatitis elimination. We all know that hepatitis is a scourge to mankind, and we all know that all the hepatitis viruses can affect the liver, but there are a lot of differences in the mode of transmission, mortality, morbidity, clinical features, control, and prevention. Hence the importance of early diagnosis and further management. With this, I would like to call upon Dr. Priya Abraham to give her lecture on the challenges, early diagnosis, and in hepatitis elimination. A small introduction about Dr. Priya Abraham. She needs no introduction. And Madam is the technical lead. She's the Director of Virology in CMC Vellore. She's a technical lead, HIV, hepatitis, WHO India. And Madam has evaluated India's first indigenous hepatitis B vaccination and introduced molecular diagnostic testing for hepatitis B, C, D, and even E. She's contributed to the WHO on the guidelines for HIV, hepatitis B, and hepatitis elimination in the CR region. And Madam was the director, ICMR NIV Pune during the COVID-19 period, leading to virus detection, isolation, and effective control during the pandemic. We welcome Madam for your lecture.
Good morning, everyone. I'm really truly honored to be speaking at this session and to have two very eminent microbiologists as a chairperson for this session. So my job is to take you to the nitty-gritty of the use of markers to screen for the big five, the 5 viruses known to cause hepatitis. And for those of you who are not familiar with the markers for hepatitis B, let me just see if I can use the pointer here. Is anybody? Yeah, so you can see here that hepatitis B surface antigen is the sentinel marker that one would use in acute infection or in chronic infection. And it might vary in concentration over the course of disease. Another important marker I want to bring to your attention is the IgM core antibody. This is described as the most definitive marker of acute HBV infection, and we often ignore this. There are times when surface antigen may not be detectable in acute infection, but IgM core antibody will be detectable. So for those of you who are undertaking screening of individuals for hepatitis B, keep that in mind. What's happening here? It's just getting bigger. Can you just take me to the next slide? Sorry, next slide. In the context of blood-borne virus screening in the blood bank, we always say surface antigen, hepatitis B surface antigen is the first marker. But do keep in mind that even before the hepatitis B surface antigen becomes detectable, HBV DNA is detectable, and that is the rationale behind why blood banks are now introducing nucleic acid testing so that you can pick up, shorten the window period, and pick up HBV in the blood bank setting. You can see here in both these insets, the pre-NAT indicated on the extreme left comes at 15 days as compared to surface antigen. So therefore, the window period is shortened if you use NAT testing. As per WHO's latest guideline, if one were to pick up hepatitis B surface antigen, either using an RDT or an EIA, if the sample is non-reactive, no evidence of infection. But if it's reactive, a person is expected to be screened by reflex testing for HBV DNA, so he or she can be linked to care and treatment from there on. With hepatitis C, you can see that if you apply an RDT or an ELISA, if a person is negative, of course, no serological evidence, but if a person is reactive or considered positive by the screening test, they are guided to look, to be screened for HCV RNA. And I want to introduce another antigen, which you can see in the big orange box, known as the HCV core antigen. Many of you may not know about it. It's a marker of active infection. It can be easily done using a serological assay. No need to do an RNA test. It works out much, much cheaper. WHO highlights that for you, and we often ignore it. It's there in the guidelines. And if either RNA or even HCV core antigen is positive, they are linked to treatment. To give you a little more about this core antigen, now this is the serological profile if somebody were to get infected. You can see in your extreme left, HCV RNA is the first marker. It comes up in about 2 weeks' time. And almost immediately following HCV RNA, that brown curve you see there is HCV core antigen. This is less known to many people, but this becomes detectable, and you can see it shortens the window period much, much more than if you wait for HCV antibody. HCV antibody comes up 7 to 8 weeks after infection. So if you use RNA, if you have the resources to, well and good. But HCV core antigen, unfortunately, it is restricted to only few testing platforms, but is an extremely useful protein to detect, much cheaper, can be done in an ordinary serum sample. Turnaround time is much faster. So where would you want to use it? Particularly in dialysis settings, in immunocompromised people, where RNA virus loads will be very high, core antigen will definitely be detectable, and we see positivity in all these sets of patients in our tertiary care setting. Having said that, when we move to HAV infection, the easiest marker, though viremia, that when we say viremia, that means HAV RNA is detectable. That's more difficult to do. You have to catch the individual early in the course of disease. The easiest marker is IgM antibody to HAV. This must be available widely in our country because, as was mentioned earlier, we are seeing a surge of acute HAV infection. In fact, in response to one of the earlier posed questions about what's the role of HEV, HEV is much less than HAV today, and HAV antibody detection must be available in all settings to detect the most common cause of sporadic acute hepatitis. With HEV, again, it's pretty much the same. While you could detect RNA in plasma or in stool, the easiest marker is picking up IgM antibodies to HEV. To bring in, complete the setting, if one were to look for HDV, which is somewhat rare in our country, we're a low endemicity country, if you look for HDV in the context of co-infection, as you know, HDV occurs in the context of HDV. If there is a suspected co-infection, acute markers of HBV and HDV are present in the form of either DNA, HDV RNA, or IgM antibodies to both assays. When a person gets super infected with HDV, this is usually in the case of a carrier of hepatitis B. They get super infected with HDV. You will find that there are markers of chronic infection for hepatitis B, but acute markers for hepatitis D. What are the challenges we have in our country? As was mentioned many times in the earlier presentations, there is an abject lack of awareness among the general population and to some extent in our primary care providers. And we need to highlight the burden of the problem and encourage them at least for referral to testing in labs where they can be interrogated. We must remind ourselves whether it is hepatitis A, B, C, E, or D. There are huge disparities in positivity rates in our country. Again, that was brought out in one or two of the earlier public presentations. The kits used. We tend to be happy with just any kit. It is important the kit should have been transported properly. The stability of the kit should be ensured by transporting it in the right temperature. We should ensure regular supply, at least to our main government medical colleges in our state who are undertaking the important task of screening individuals. Validation of every new lot must be done with known positives and negatives. Kits are like the proverbial description of the girl with the curl. When she's good, she's very, very good. When she's bad, she's horrid. So if you don't treat the kids properly, they will not give you the right results, and you could be misled. They could be erring on the side of false positivity or even false negativity. Good point of care molecular assays are important. Training and retraining of staff, particularly with molecular assays, is a must. And we do need to expand our repertoire of markers. I showed you a wide array of markers that we would use. IgM core antibody, which is a very sensitive marker of acute hepatitis B. E antigen testing. If you don't have HBV DNA, at least HBe antigen testing must be available for our testing sites. I would be daring to say that, we always celebrate July 28th as the World Hepatitis Day. Why don't we extend it to the National Testing Day, where we screen people in the general community, general population, to pick up those who are otherwise, unsuspectingly positive, and 50% of patients that test positive for HCV and HBV have no risk factors or abnormal ALT. We need to remind ourselves of this. Our emergency departments reveal that large proportions of them are positive with no risk factors. And under the current guidance, such patients will go undetected, untested, leaving their infections undiagnosed, untreated, and transmissible. With that, thank you for your patient listening.
The floor is open for questions.
Thank you very much, madam, for your presentation. For as take home message, I would like you to I noted down some important points out of your presentation. One was hepatitis B virus DNA testing you have recommended to shorten the window period. The other one you mentioned is hepatitis C virus RNA nucleic acid testing or even core antigen.
Yes.
Then the third one you mentioned is your a good point of care molecular assay is not in place, and there is a lot of issues with the kits. These are the 4 points, plus involving ED department, which can be also a potential point where you can detect, this kind of hepatitis infections. My only request to you is, for us, for policy makers, as way of recommendation, which of these we should take up immediately? Second is, with regard to kits with so much of issues, what is the standard methodology our government should put in place so that we keep a check on the kits we are using?
Thank you, sir. Very, very good questions. I think in terms of priority, quality of kits and ensuring their transportation stability and validating a kit, when a new lot of kits, the manufacturer sends out new lots to end users. When a new lot comes, it has to be validated for its performance. So I think that is number one, sir. And with regard to HBV DNA, I actually highlighted that particularly in the context of blood bank screening. We find that blood banks even use RDTs. RDTs for HBV particularly are not sensitive compared to an ELISA, and at least if blood banks can introduce NAT testing, then HBV DNA can be picked up in the blood bank setting. Thank you, sir.
Thank you for nice presentation. As a public health person, I have always been testing for HBV surface antigen core antibody. But this was a new information, rather lack of my knowledge that 32 days and 12 days are a significant period of time. So my question now is that, do you suggest this to be a kind of a pilot study, or have you already done it? Because that is a significant number of time. Because in program it will be not cost effective, I understand. But core antigen is not very expensive as compared to other tests. Second was basically about the emergency department testing. I think that will be a great initiative because even NACO is thinking of having, not in emergency, but in OPDs in high prevalence states, NACO is thinking of having testing everyone presenting to health facility, of course with consent, but offering the test to everyone. Should be a similar strategy be adopted for hepatitis B and C also.
So in response to your first question, thank you, Dr. Ivari, I think you were referring to HCV core antigen.
Yes.
Yes, this is definitely something bigger laboratories can undertake because it's a very quick turnaround time. The same sample that comes for HCV screening, even preoperative screening, you can use the same sample for HCV core antigen detection. It's much cheaper. Of course, one caveat is that remember, core antigen is detecting the antigen per se in the sample, whereas RNA is artificially amplified. So when you need about 10^3 copies of RNA for core antigen to be detectable. So in high-risk populations, and I showed you the high-risk populations from our experience, definitely dialysis patients, HIV-infected patients, medical oncology, rheumatology patients, we must apply this because otherwise we might just report HCV antibody positivity, which does not suggest current infection. If we are able to point out core antigen positivity, that means the person has current infection, needs to be definitely triaged for RNA estimation or for treatment to the hepatologist.
I think, Dr. Vivek, we can have some takeaway from this summit, particularly on this aspect for high-risk groups. But I had one more question also about testing for generalized testing in healthcare setting with high prevalence.
Yeah, I think it's a very good idea, and we actually implement that because we do very wide-scale preoperative testing for HIV, hepatitis B, and hepatitis C, and many of them come to ED because of a surgical emergency. And we find, an ENT patient, a pregnant woman, a geriatric patient, they are positive for either B or C. They are patients that have low risk, and they are positive. So I think ED testing is something we might like to consider.
Thank you.
Good morning, ma'am. Ma'am, I'm Dr. Priyadarshini from Government Krishnagiri Medical College. I like to highlight the challenges that we face. So as this program is aimed at screening high-risk patients, and when we have dialysis patients sent for screening, when we do a rapid card test, they are not satisfied with that. They only ask us for an ELISA test. But this program is including only the rapid card test under the screening. So could this be modified? Like they are asking even emergency ELISA when they want to do a emergency hemodialysis. So in that case, when we give a rapid card report, they are anyways asking for a final ELISA report from us. So in that case, when we can have ELISA screening for all these patients instead of a rapid card test, as we all know universally it is not highly sensitive as compared to the ELISA test. So why the program is now, maybe because of cost benefit maybe, but at least we can slowly include ELISA testing so that we will not face these kind of issues in the core setup there. And the second thing is regarding the PCR kits that we are supplied. So every time, when the first type of kits that we had many negative samples amplified falsely. Whenever we try to prove that the company person finds out some sort of contamination, somehow they make it up to that point that it's only from the lab. However, effectively we try to eliminate that. Sometimes we get some samples amplified in spite of that. So when we had another kit this time, they say whatever low values that we have got for all the samples, they still tell us to report that it is positive only. Our kit is very much sensitive compared to the other kits. Like we have patients doing the same test in a private lab coming to us with an opposite report. Like when we gave positive, they are coming us with a negative report with another test kit. So when we ask for these kind of, these kind of opposite reports from different kits, they say our kit is sensitive, you can report it with confidence. But what is the gold standard test? We are now in a dilemma when we report such kind of tests as positive and someone is coming and challenging us with a negative report and putting us in a very dilemmatic situation to deal with them. Like it is not a simple disease, like we give some antibiotic and they are cured. So when it is a very high-risk disease which is to be treated seriously, when we have such kind of problems in the kids, it is really difficult to report at the college level for the patients.
So I'll take your second question first, that the best way a laboratory can reassure themselves about their quality of testing is to take part in a quality assurance program. And we in CMC Velo run it for more than 800 labs. I think we've crossed 1,000 as I speak. So we are in the same state of Tamil Nadu. Please participate in our quality assurance and you will know how your assay is performing. That's the best way to know quality. Because you get a coded panel, you will give the result and we will give you a rating. The second is, yes, ELISAs are more sensitive, but the turnaround time is a little more problematic when, say, a dialysis lab or an emergency preoperative screening. So I might make this suggestion, which I think will not be tenable for the National Virus Hepatitis Control Program, but at least for major medical colleges, they need to have automated platforms wherein they are random access. So as and when patients come, they are very sensitive ELISAs, you will pick up and not miss a single sample. I know it's not tenable for a complex country like India, but that's one way forward.
Thank you. Thank you so much.
Thank you, Dr. Priya, for highlighting the problems what she was telling. Just to add on, like, of course, we have problem with RTTs, but for an emergency, we can use it. And some of the centers, what they are adopting is, they isolate these cases, then morning ELISA is done, then accordingly they are grouped. For emergency, you go for RTTs, but next morning, please do with your ELISA or whatever platform you are having. Then with regard to quality of the PCR kits, we have discussed a lot on that. Unless you get satisfied with the results, you validate the kit, and for each run, please go by every parameter, whether the standards are in line with the efficiency, all that. Otherwise, please do not report. Instead of giving a wrong report, it's better we wait like. So always take it very stringent like while you're reporting the viral load. because the treatment is going to be, especially with HCV, based on that we are going to stop the drugs. Thank you. Thank you, Doctor.
Thank you, madam. Thanks for your very lucid presentation. A complete overview emphasizing the significance of early interventions and the newer methods, madam. It was an eye-opener. Thank you very much, madam.
Thank you so much, Dr. Priya. Requesting Dr. Kaveri to please do the honors and present her with a token of our appreciation. Thank you.
Next speaker. Mother-to-child transmission of HBV is a cause of chronic hepatitis B virus infection. That too, especially mothers with high viral load, they carry much higher transmission risk. Now to talk on programmatic intervention for prevention of mother-to-child transmission, we welcome Dr. J. Nimalsen, who is Joint Director of Public Health and Preventive Medicine. He has 27 years of clinical experience with strong public health leadership, leads statewide maternal and child health initiatives driving significant improvement in service delivery, and he has implemented various programs to reduce morbidity, mortality with regard to hepatitis. Over to you, sir.
Thank you, ma'am. First of all, I want to thank all the organizers who have given me this opportunity. What we are doing in the government sector, especially the primary sector and as well as the tertiary sector. The HCV and hepatitis B, what we are doing it in the primary sector as a rapid core test, and what we are doing it in the PHC. In India, and what we are looking at is as per the program, what we are looking at, we have to close it down by 2030. Mother to child transmission, we want to have a very strong activity at all the levels in the primary sector. So I will be going with, because I want to stress on this point, because everywhere, the previous speakers, they are pointing out somewhere around 4% was the positivity rate and amongst the general population and other population. But when we are looking at the mothers, so this is what we are coming across with the available numbers. The 0.3% is the positivity rate for the past 2 or 3 years, what we are continuously coming across. Even though the numbers are very huge, we can take this as a point of what we are to do it in the future. Around 8,20,000 tested in the last year. So we got only 2,775, which is 0.3. Again, this year also the same number in the percentage of the positivity in the antenatal mothers numbers. Because right now it is a mandatory test for during the first visit itself. All the mothers undergoing this test in the primary sector, secondary sector, and as well as the tertiary care, even in the private sector also. And it is a mandatory test for the Muthulakshmi Reddy scheme. It is a maternity benefit scheme, what we are doing giving in the thing, and it has to be entered in the PICME. So the result, report where we have taken is from the PICME portal, what we are doing in the antenatal mothers. So all the other things, I think I am not the right person to talk about, and what we are doing is the mode of transmission, how to curtail it, and how to prevent this, and how we have to go with the other activities. So the risk factors, as all of you are aware, and these are all the risk factors. I just don't want to repeat whatever the previous speakers have said. So the impact on the pregnancy regarding hepatitis B, most often it is asymptomatic where we are missing it out. So if we are at the primary health sector doctor, it is very highly, it is not at all possible for pick up with any symptoms. Maybe with jaundice and other things they may look at, but most of the time it is asymptomatic, and it is very tough to pick up these cases. Maybe in the later stage with the viral load replication and other things, we are looking at these kind of activities. And last year also we had 2 or 3 deaths in the hepatitis B with fulminant hepatitis. And apart from this, again, another, the previous speaker also is talking about hepatitis E also, we are coming out with the fulminant hepatitis, even though it is a minor infection in other persons. Right. So home to screen, these are all the screening what we have done in the high risk mothers on the previous aspects. Right now it is going to be or already we are doing at the universal screening for all the antenatal mothers at the first visit. That's what we are doing right now with the cord test, the serological test. What we are provided by the thing is looking at the hepatitis B in HBsAg antigen. So we are looking at what are all the other activities we can incorporate, as rightly pointed out by Dr. Gerald sir also, what are the other things and how to improve the sensitivity rate in this aspect we have to look at. So this is a routine thing what we are doing, and first visit we are doing for all the mothers we are doing, and then only we are doing the registration in the PICMI portal. Then we are monthly following if they are hepatitis B positive, that is HBsAg positive, we will be monthly following them up, and we are referring them to the medical college hepatologist and gastroenterology department. And we are recommending the 28th week one testing of viral load on the medical college, and the birth planning is usually done in the medical college with the help of medical gastroenterology department. So tertiary care is taking care of the remaining area where they are looking at. Right. So these are all the other areas what the medical college people and medical gastroenterology department is doing, and we are insisting just one more thing from the medical college whoever assembled here, the hepatologists. So we have to ensure this 28th week testing and the follow-up is done at the medical college level with a very imminent thing. So then the intrapartum, again we are looking at how to do the delivery, and we are looking at what are all the procedures she should not do or we should do, all those kind of things we are looking at in the medical college, because or in the private sector, the tertiary care level where the gastroenterology department is available to take care of the other activities. So then the other we are looking at is HBsAg give HB vaccination. That's what we are doing within 24 hours. Initially we started way back in 2008 in the primary sector. Within 72 hours initially we have started. Then we have changed it within almost a year. We have changed it way back in 2010 in primary sector in government of Tamil Nadu. We have changed it to within 24 hours all the persons, all the mothers should be, all the babies should be given hepatitis B. So it is mandatory, and we are ensuring that this is happening. And other things, previously this is the schedule, and right now with pentavalent vaccine, 1.5 months, 2.5 months, 3.5 months, we are giving this vaccines. So positive babies, we are looking at hepatitis immunoglobulin that is available in the medical college hospitals for other things. These are all the flow chart what we are doing at in the PHC, and then we are referring to the medical college or the hepatologist for follow-up and viral load testing. Based on the viral load, the tenofovir is the mainstay, and we are changing it over at the medical college level for antiviral therapy, and they are following it up in the medical college. So these are all the other areas what we are looking at, and so I want to highlight what are all the key interventions under this program of MCTC. So we are insisting on universal antenatal screening, point of care testing for in pregnancy in the government and private hospitals also, flagging positive mothers and ensuring hepatitis B vaccination within 24 hours, then antiviral prophylaxis strengthening, that is from 28 to 32 weeks at the medical college medical gastroenterology department, and ensuring safe and effective birth practices. Then training and capacity building at all the levels, starting from the village health nurse to the correlation up to, it has to go up to the medical gastroenterology department with the OGCNs at the medical college level also. So then the strategies right now what we are following is already we have enlisted the hepatitis B immunoglobulin and other things also been incorporated. So the challenges, definitely the low awareness, maybe in some places, because they don't know what is the injection or what are the things we are giving or what are all the testing we are doing them. So we have to keep on insisting that we are doing this, and after, if it is a positive one, it is very tough to push them, and if they are not aware of the things prior. to make them to understand that they are positive mother for hepatitis B and other things. Then if somebody is missing their antenatal screening on what we are doing, and we are also at the risk at the doctor's level when they are doing the other thing. Then inadequate viral load testing, maybe sometimes the patient is not going to the medical college for testing and other things. These are all the other gaps and challenges what we are right now doing. Definitely we want to scale up, and as previous speaker also, madam is also talking about the positivity rate. Again, we want to ensure we are not missing out based on the sensitivity of the test. We don't want to miss any positive mothers by being calling them as a negative. With this, I want to thank once again the organizers. It's open for the questions.
Thank you, Dr. J. Nimelsen. Now the floor is open for questions. Any questions from the delegates?
I'm Dr. Rivari. Thanks for the wonderful presentation, highlighting the current guidelines, and I think we'd like to compliment the National Viral Hepatitis Control Program for providing immunoglobulins, which is a practice which is not widely available in many other countries in Southeast Asia. So a combination of birth dose, 3-dose vaccination and immunoglobulin will definitely prevent the transmission in majority of the cases. But recently, not very recently in 2024, WHO has also advocated provision of antivirals to the positive pregnant women from the 28 weeks onward to reduce the viral load. That is an additional intervention which is not part of the program, but I'm pretty sure this will be discussed further by the program in coming days.
Thank you, sir.
Just to add on, sir, as you said, we are having very good antenatal follow-up, referral for viral load testing, all is happening. But the gap what we are having is the postnatal follow-up, what we have to focus like. And with regard to institutional deliveries, I think the programs we have attained 100% and 100% I mean dispensing of the HBIG and starting the primary vaccination series for the newborn, all that is done. So I think the next challenge or whatever we need to focus for complete elimination is to focus on the postnatal follow-up. We are left with, of course, the antenatal women, they come to medical college setup. As antenatal, they are more sensitive and they come. But once they get back, like we are not getting many referrals on the postnatal. I think that's one thing we need to focus on. Thank you so much, sir.
Thank you
for the presentation.
Thank you so much. One more question, please go ahead, ma'am. Ma'am, request you to use the mic because then the others are not able to follow. Thank you.
Yeah, good morning. This is Dr. Archana. My question is, sir, we know that the zero-dose coverage for hepatitis B nationally is not that good. So how is it in Tamil Nadu? And what are the particular challenges why zero-dose vaccination for hepatitis B is problematic? Because Tamil Nadu is a state with...
I never said this is a problem. We are doing it in the primary sector and secondary sector, and we are doing it in the government sector, and we are crossing it almost 95% in entire thing.
What are some of the then best practices that Tamil Nadu can teach the rest of the country? Like, because the national coverage is not that great.
The main thing is Tamil Nadu is having the highest rate of institutional deliveries. Almost 99.9% is the institutional delivery, where we can definitely give the
zero dose.
Zero dose is definitely audible. Maybe somewhere we can miss it, maybe because of the open vial. Again, the open vial policy is also available, so we can give it in the easiest manner. It is not at all a problem, to be frank, to implement. Only thing, we have to improve the coverage of institutional deliveries. Otherwise, we cannot insist on them.
Okay. Thank you.
Thank you, ma'am.
Very nice presentation, sir. I just want to echo what Madam just mentioned. She spoke about zero dose. In the government sector, probably you didn't feel a shortage, but in the private sector, there was a shortage. And I actually reached out to the companies, and what they're doing is they find it more lucrative to market the pentavalent vaccine rather than the single dose. I took it even to the head of the National Viral Hepatitis Control Program. So I bring it to the attention of Chennai Liver Foundation. Those of us who are in the private sector and NGOs need to put the pressure on suppliers to make sure every baby, irrespective of public or private sector, must get that 0 dose? She's very justified in raising that question.
So
Thank you.
actually, the next topic is going to be on the immunoglobulin. So I don't want to, immunization. So still, I think you are very much correct that last 6 months back it was the thing,
Shortage.
and by that time the government, I think JD Immunization is going to be the next speaker. So he has supplied to the private sector also during that time. So and again, I think he will be the better person to answer for this. Thank you. Ma'am.
Thank you, sir.
A big thank you to Dr. J. Nirmalsan, requesting Dr. Tasneem to please do the honors and present him with a token of our appreciation. Thank you.
We shall go on with the third speaker. I would like to invite Dr. Edwin Fernando, Professor, HOD, Stanley Medical College, to give his lecture on hepatitis in prevention and safety measures in dialysis setting. A small introduction about him. He's my classmate and internationally trained nephrologist specialized in renal transplantation and key advisory state committee. He's got 135 plus publications and has received the Award of Excellence from the Government of Tamil Nadu. He's a renowned expert in AKI and pregnancy-related kidney disorders with over 200 plus invited talks. So over to Dr. Edwin.
Respected chairpersons, a distinguished audience, I thank the organizers for calling me over to talk on this very important topic on hepatitis prevention and safety measures in dialysis. I bring to you warm greetings from the Government Stanley Medical College. So, infections in hemodialysis units, what is it about? This dialysis unit is a high-risk environment for blood-borne pathogenic transmission due to frequent vascular access manipulation and extensive blood contact. Hepatitis B and hepatitis C are primary concerns in these clinical settings, requiring vigilant infection control measures. An effective prevention relies on implementing and maintaining robust infection control protocols, comprehensive staff training, systematic surveillance, and programs to protect both patients and healthcare personnel. Why are hemodialysis units high-risk environment? Frequent vascular access. We have AV fistulas, we have dialysis catheters, and we have the AV grafts. The shared equipment, the hemodialysis machines are shared, BP monitors, other shared devices can serve as vectors for cross-contamination. And environmental contamination. HPV, for example, 1 drop of blood can have 1 million virions, and that can stay up to 7 days, even in bed sheets or in tablecloth, making it very, very infectious. The major hepatitis virus in dialysis settings are the hepatitis B and hepatitis C. Hepatitis B is highly transmissible with exceptional environmental viability, and hepatitis C primarily spread through lapses in infection control practices, including improper injection techniques, inadequate equipment disinfection, and though it is less environmentally stable than the HBV, but still poses a very important risk. And what are the standard precautions that one should follow? Very, very important is a hand hygiene protocol, single most critical prevention measure, glove usage, changing of gloves between seeing patients or changing of gloves after touching equipment, and surface disinfection. So whenever there is a blood spill, it should be immediately disinfected. So these are all potentially contaminated surfaces should be disinfected between patients and at the end of each shift. Goes without saying that we have to keep on reminding our staff about these 5 moments of hand hygiene, and I have put up this poster in our dialysis room also, kindly always reminding the personnel there that how important hand washing is. Next is the environmental cleaning and disinfection. We must have critical cleaning protocols, the machine disinfection, all the touchable surfaces. Most of these machines are buttons which the technicians keep touching. So this should be cleaned after every session of dialysis. Dedicated equipment, for example, hepatitis B has to have a separate dialysis machine, and there are blood pressure cuffs and stethoscopes which can be shared, and this should be infected. And we use this bleach that is supplied by the Tamil Nadu government. This is sodium hypochlorite of appropriate concentration, 1:100 dilution for disinfection. And there are a lot of high-touch surfaces in the dialysis room. The bed controls, the bed rails, the table, the overbed table, cabinet knobs, call lights, door knobs, you just name it there. There are systems there, computer tables, ventilator controls, thermometers, and even the handrails. So these are areas of high infectivity. Medication safety and safe injection practices are very important to avoid the multi-dose vials. We give the hepatitis B vaccine, and the government supplies multi-dose vials, but we try to segregate the vials for individual patients, and this should be avoided. And all the injections should be prepared in a different area, and there should be no medication transport. And of course, needless to say that needles and syringes are single-time use and never must be reused, and each patient requires fresh sterile supplies. If multi-dose vials are unavoidable, then dedicate them to a single patient. These are the infection pathways in dialysis unit. You have the patient, then you have the surfaces, then the environment, and then the staff, the hands, their gloves, and this is how it gets transmitted. So understanding these transmission pathways is fundamental to breaking the chain of infection. We vaccinate double dose vaccine 0, 1, 2 and 6. I accept that we had a shortage of hepatitis B vaccine, but somehow we were able to get it through the government, and we were able to vaccinate all our patients. So it is 40 mics on each deltoid, 0, 1, 2 and 6 months, and we ensure that most of these patients are vaccinated well before they enter into dialysis. So the vaccination should be at the first visit when CKD is diagnosed. The vaccination should be done. Earlier done in CKD, better is the immune response. Managing hepatitis B patients goes without saying that these patients have to be, the machine has to be isolated, dedicated machine, dedicated working area, dedicated personnel, and no sharing of any equipment including BP apparatus. So somebody who has hepatitis B positivity, in the first itself, we isolate them straight away. The isolation room is there, and a staff from the dedicated area should not move into the regular dialysis unit. Hepatitis C, though the CDC and the KDIGO recommend that isolation is not required, however, it is left to individual centers to decide, because sometimes we have shortage of staff, and there may be reasons why people keep shuffling between two dialysis units. And so we follow the protocol that though for hepatitis C, the CDC says patient need not be isolated, we are a little worried because we do get some outbreaks of hepatitis C as we had in 2014. So this is the way hepatitis C can actually transmit: medications, injections, poor hand hygiene, glove change, etc. And we have what is known as a transducer protector there in the machine. So this is where when the venous pressure rises, the blood can actually get into the machine and infect the hydraulic parts. So we use this transducer protector and make sure the venous pressures don't go high, because this is one area where the virus can actually enter into the hydraulic parts of the machine. And as I said, since I don't have enough staff and I cannot ensure that my staff will follow all the universal precautions 24/7, we have an isolated dialysis unit for hepatitis C patients, and this is the practice throughout the country. Goes without saying again, this is a study, and nosocomial transmission of HCV within HD units remains substantial, especially in our country and also the other low middle income group countries. Screening and surveillance, somebody mentioned that we insist on doing a HCV PCR before we take a patient from some other unit. This becomes mandatory because this patient would not have tested for HCV. You know, the ELISA has got lesser sensitivity. And suppose the patient has a negative ELISA, but his HCV PCR turns out to be positive, he would be infecting the other patients in the unit. So we make it particular that we would take a patient from some other unit into our unit only if the HCV PCR is negative. For patients who we have to do emergency dialysis, we have an isolated machine that is, status unknown. That sort of machines, 2 machines we have where we take these patients. So very important that every month that we do HBsAg, HCV and HIV by ELISA for all our 250 patients who are on dialysis. Very important to take care of our staff. It is not the patients alone because these people are working in this environment. They are exposed to blood spills, sometimes a spurt of blood from the fistula. They may have hand pricks, injection needle pricks, etc. To make sure all our staff are mandatory vaccinated and have good antibody titers, needle stick response, post-exposure prophylaxis, and very important to involve the patient also in the care. You must have patient education regarding personal hygiene, avoiding behaviors that increase transmission risk, and recognizing signs of infection. So the key takeaways here, infection control is paramount. There are different protocols for hepatitis B and hepatitis C. Hepatitis B has to be isolated. Hepatitis C also we isolate because of our problems working in a large public hospital. Vaccination and surveillance are essential. And very important to have the equipment management and waste disposal also done ideally. We must make sure that all our last grade servants are also vaccinated and then educated about gloving and masking when they are dealing with these infected materials. So our HIC, the Hospital Infection Control Committee, stealthily visits our dialysis unit and does a very vigorous audit of all our procedures and points out mistakes then and there, make sure that all the disposables go into the right color bins. And patient safety and self-care responsibilities, hand hygiene for the patient, vaccination compliance, access site care, and education and advocacy are important. These are patients with catheters, so we advise them how to take care of the catheters. And these are patients with fistulas and grafts. And we have to tell them to recognize infection earlier and how to handle these catheters. Very, very important to have audits, and we do a monthly audit of all our dialysis patients. So that is very, very important. And that is the reason why the culture of safety and continuous improvement is essential for maintaining high standards. So infection prevention and you, where does it start? You are an important part of infection prevention. This is how we store our dialyzers. All the names are written and the dialyzers are stored because we do reuse dialyzers. But recently, I'm happy to share that Stanley adopted a single-use dialyzer policy, first time in a government hospital, that we dispose all our dialyzers single-use from May 2025. And from 2014, we have been disposing all our blood lines because we had an outbreak of hepatitis C at that time. About 16 patients turned positive. So we thought the best way is to give good quality care. And by instituting the single-use policy at our center, we aim to provide all our CKD patients with the highest quality of dialysis care available. So this is our Honorable CM who visited our unit to see a patient in 2021, and this is our dialysis unit. So thank you very much for the patient listening.
Thanks, Dr. Edwin, for your vivid presentation. The floor is now open for questions.
Very good afternoon, sir. Yeah. So I have a question regarding the vaccination. We are giving the double dose, sir, but we are not able to check the titers for all the patients because of unavailability in government setup. So we generally do the routine immunization booster every year. What is the exact guidelines you recommend?
It is important that somebody has, CKD is an immunosuppressed state. People are not able to mount an adequate immune response with the vaccine. Even with our very early vaccination protocol of double dose, only about 50 to 60% of patients do have a protective antibody titer. So now that we have insurance facilities available, we could outsource, because if this test is not available in a government setup, the rules permit us to do the anti-HBs titer in a private lab and reimburse to that lab. So this can be very well done.
Okay, sir. Thank you, sir.
Very good afternoon, sir. Good afternoon, ma'am. Ma'am, I have a doubt. As sir told, hepatitis C virus estimation is very useful for dialysis patient. Though it is available under NVHCP, we are restricting their usage towards for positive patient only. Those who pick up positive by rapid diagnostic test will be tested for HCV RNA estimation. Why don't we use HCV RNA estimation for dialysis patient? Though they are negative or positive by ELISA, why can't we use it as a first-line test for dialysis patient alone? Because in our colleges, our nephrologists keep on insisting us to do HCV RNA test for dialysis. They don't rely on rapid diagnostic test, ma'am.
As I mentioned earlier,
Yes,
the
sir.
rapid diagnosis test is something that we don't rely on,
Yes, sir.
number one. Number two, to do HCV PCR for all dialysis patients in the state will be a very huge economic burden.
Yes, sir.
What you say is ideal, but may not
Yes,
be
sir.
practical.
Yes, sir.
So, as when we look at our monthly parameters, whenever we find somebody's liver enzymes are high, we subject those patients or increasing liver enzymes. Even if the HCV ELISA is negative, we ask for a PCR
Sure,
upfront. So, we follow an aggressive policy of testing.
Yes.
But it is, as you mentioned, that it is not possible for us to do HCV PCR for everybody. All our microbiology labs and our hepatologists would get burdened by the huge burden. And I'm sure that we'll be able to pick up earlier cases of hepatitis C if you do PCR for all patients. If somebody says, I don't have HCV in my unit, he has not tested it.
Actually, it is available under program, sir, but we are restricted to usage.
Dr. Chitra, we will aspire for HCV RNA testing for all dialysis patients in future. And meanwhile, as Madam had pointed out, we can go in for strategies like core
antigen assays, ma'am.
So that would be, when compared to viral load, sure, the working cost also would be less, and TAT also is going to be reduced. I think that can be incorporated since we have NHM officials, Gerald Sir is there. Sir, kindly provide us. We would be very happy if you supply us with anti-HBC IgM kits and also HBeAg and core antigen to HCV, at least a few centers where the dialysis facility is there, and for other patients also to help.
Thank you. Thank you.
Good afternoon, sir. My question is, the treatment failure are very high among the dialysis patient. What happens is
hepatitis B or C?
C. What happens is we have a dedicated mission for hepatitis C. Once the patient attains an SVR, even after that the patient is undergoing hemodialysis in the same mission, where there is chances of a reinfection with another genotype. This is what we are encountering in clinical practice, sir.
I do accept what you say. When do I shift a positive patient after treatment into the negative unit? This is $1 million question. Nobody knows the answer. Some experts feel that if you do 2 PCRs 6 months apart and both the PCRs are negative, probably you can shift him into the regular unit. However, I have not had the guts to do so.
Thank you, sir.
You mean hepatitis C, sir? Yeah, we have to be careful with the secretions. The secretions have to be taken care, because the hepatitis B, viremia and viruria could be there. Fortunately, most of our dialysis patients are anuric, but other secretions may have. Of course, we would advise. Yes, sir? Yes, sir. Of course, we would do that. We would check. Fortunately, we don't, because of our aggressive vaccination policy, we don't have much hepatitis B patients. But as you rightly said, vaccinating other members of the family would be a very useful technique. And the other thing, Malarvali, you were mentioning about the HCV testing. Somebody was telling. Even when I send a test, it takes about a month for me, because they collect all the samples, then open the kit, and by the time I get the result, it's a month. So I think that also has to be fast-tracked a little.
Sir, I am Dr. Sivasubramanian. So for a patient who got cured, given 3 months treatment and HCV sustained viral response achieved, why can't they have a separate machine for them rather than putting them on same hepatitis C positive patient dialysis machine? So why can't we follow that? Number one. Number two is regarding this vaccination you mentioned about hepatitis B. Why can't we make it mandatory to get salary unless otherwise they got vaccinated? Why can 3 doses should be completed to get salary? You should get salary. You will get salary only you completed vaccination.
That is a government policy, sir. I cannot interfere with salaries.
That's I am suggesting that can be recommended by you.
I'm very happy to note that most of our children are born, I mean, when they are born, they are vaccinated. That itself is a great thing. Very important thing is anybody with CKD, the HbA1c status should be checked as early as possible. If I see somebody with a creatinine of 1.5, 1.6, at that point I should vaccinate. So that we keep educating our patients as well as our children, I mean our students also. If the other suggestion that you mentioned, that we could have an area that the status is unknown, have a couple of machines there and dialyze them in those machines after they have attained SVR, is a fairly good suggestion. It is being undertaken in a few centers.
Thank you, Dr. Edwin, for promoting infection control practices, especially 5 moments of hand hygiene. And in dialysis setting, the moments of hand hygiene are more also. Thank you for putting up that message. And one more thing regarding the healthcare providers' vaccination. I think we need to promote, we have to talk, most of the surgeons, it is very surprising, they are not immune, they are unaware also when we start testing. We make it very confidential, so be open, get immunized those, I mean, when your titer is very low, take doses and get tested, there is no harm in that. I think it must be 100% as said, though we don't have any strict norms about like, it has to come from our own self, like for our own protection and to protect our patients. Thank you, Doctor.
Madam wants to.
With your permission, can I make a comment?
Yes, sir.
So actually, one suggestion is when you're handling patients with AV fistulas and so, you know, the phlebotomists who take blood or are handling them, they move from patient to patient without changing gloves. This is a more than the mask, because these viruses they are not inhaled.
Correct.
They're all contact.
Correct.
So I think if they can change gloves between patients,
right,
that would be a good measure to prevent patient, I mean, it's a small effort in the direction, but could make a difference.
Right. Most of our dialysis patients, we do the monthly testing in the dialysis room itself. So when the technician inserts the needle, at that time itself he draws the blood. So this technician does not move into the next bed.
Okay.
So there is a separate technician to do that.
Okay.
So this is one way of minimizing.
Yes.
But what you say is pertinent in the lab. In the lab, I'm sure NABL labs would insist that after every patient, the technician changes gloves.
We do it especially for molecular testing because carryover can. Thank you, sir.
Thank you. Thanks, Dr. Edwin, for a very interesting speech. Thank you so much for the question.
Thank you so much, Doctor. Requesting both of our chairs to please come forward and do the honors and present him with a token of our appreciation. And now I call upon Dr. C.E. Epan to please do the honors and present our chairs with a token of our appreciation. A big thank you to Dr. Kaveri and to Dr. Tasneem for conducting this session. Thank you so much. Thank you so much. Ladies and gentlemen and members of the audience, we are honored to have with us Dr. Arun Tamburaj, IAS, Mission Director, National Health Mission Tamil Nadu. He continues to strengthen healthcare delivery systems across Tamil Nadu, ensuring improved infrastructure and efficient service delivery. He oversees key national health programs and leads digital health transformation initiatives. He's also leading expansion of type 1 diabetes care centers across Tamil Nadu, improving access for children from underserved communities. We're so honored to have you here with us today, sir, inviting Dr. Arun Tamburaj to the stage to address the gathering.
A very good morning to all of you. And I take this as a moment of pride and honor to be a part of this Hepatitis Elimination Summit. I should first convey my thanks to Dr. Vivek. So he was literally behind me. He was stalking me day in and day out to organize this. And I was very happy to see such people who are very passionate to take up this initiative. And at NHM, we have a lot of schemes and programs which keep happening. So we definitely tend to lose our focus on certain schemes. It's only the stakeholders from that particular scheme who should definitely come and make use of people at NHM or at the helm of affairs and get a lot of things disseminated for the welfare of the people at large. So this National Viral Hepatitis Elimination or Control Program, which is already in vogue since the last decade, but we felt that it requires a relook as to where we need to focus, what will be the direction for the program, and in what initiatives can be taken by Tamil Nadu in this elimination of hepatitis. So for that purpose is what this one-day workshop is being held, this summit is being held. And we have people from across the state, especially from the government sector, so who were invited to be a part of this meeting, just to share your views, your ideas, your plans, your thoughts on how to revamp and how to strengthen this existing program. So I will not take much time because we are running from one program to another program, but I will not waste much time on giving things because when I was not here, I heard about the lecture given by the CMC, a person from CMC, Professor Priya. I don't know where ma'am is there, I have not met her also. But I heard a lot about her and I was really impressed to note a lot of good things which she had shared. So definitely NHM will take up the initiatives given by Dr. Priya madam and will also make her a part of our expert committee. I don't know how you are not a part of NHM. So from now on you will be a part of us and definitely look forward to taking up a lot of initiatives forward, especially in the perspective of testing. In fact, for NAT, a lot of the committee was also held and Tamil Nadu we have taken up a couple of high-load centers which we should introduce NAT and almost tendering is in process and TNMSC is processing it, it's in the process of bidding. So I think CMC was giving the lead in that and Government of India was requesting and we've taken that forward. Similarly also the quality of the testing kits, which was also repeatedly the microbiologist from MMC, madam is here. She was also coming and telling me repeatedly that we need to take a look at the quality, for which I think ma'am was suggesting about EQUAS. So definitely that is one thing which should also be part of this. And in fact, we are working for the PIP for the coming year. So definitely whatever good work has been done in CMC and which you think can be scaled up, we'll be more than happy to take it up. And also about hepatitis B vaccine, this is one of the vaccines like HCV vaccine, like HPV for the hepatitis B is one which we can prevent cancers. So at least those aspects I think we should definitely give more impetus on the routine aspects. Though it may seem to be routine, even when we're reviewing, we would see number of our own first line, people in the first line of treatment, even though of giving treatment, they even don't take up HPV vaccination. It's very unfortunate. So definitely we need to sensitize even our own stock to at least take care of those basic things, the small minor things but which we terribly lack. So I think it's time that the entire one-day workshop or the summit which you have today looks into various things which can be scaled up based on various factors, especially the financial viability is one important thing. Of course, we should take up, at least on pilot basis, we can take a couple of initiatives. And I want to take up at least 2-3 initiatives which come up from today's summit as a part of the program implementation plan for the coming PIP, the 2026-27 for Tamil Nadu. So I once again thank also officers from NHM, especially Dr. Gerard and the senior consultant Beulah, for being consistently working with Dr. Vivek and getting this through, and also welcome and appreciate all the stakeholders from across the global hepatitis elimination, that coalition for global hepatitis elimination, the task force for global health, and all the other stakeholders who are here today. Please give your inputs and make Tamil Nadu one of the best states, and also towards paving way towards hepatitis elimination. Thank you and wish you all the best.
Thank you so much to Dr. Arun Tamburaj. Calling upon Dr. R.P. Shanmugam to please felicitate him on stage. Thank you so much. We now move on to our next session titled Programmatic Management, Challenges and State Perspectives. I'd like to welcome our chairs to please join us on stage, starting off with Dr. K. Prem Kumar, Director, Rajiv Gandhi Government General Hospital, Chennai. He's a senior gastroenterologist with 30 plus years in Tamil Nadu Medical Service. He's a medical educator with 10 plus years of teaching experience and the co-author of several research papers presented at national forums. We welcome Dr. K. Prem Kumar. Next, I'd like to welcome on stage Dr. Aravind A., Dean, Government Stanley Medical College. He's a specialist with strong academic excellence and previously served as the Dean of the Government Medical College. He works closely with government bodies to strengthen hospital infrastructure and welfare measures. Welcome. And rounding out the panel is Dr. B. Sumati, Professor and Head, Department of Medical Gastroenterology, Stanley Medical College and Hospital. She's a senior gastroenterologist with 32 years of experience, and she's skilled in therapeutic and diagnostic endoscopy. She's actively engaged in research, workshops, and scientific publications. Welcome, Doctor. I now hand this session over to the chairs.
Good afternoon all. Just a brief history about hepatology in Tamil Nadu. So it all started in 1986. It started as a liver clinic by the Department of General Medicine by Professor J.R. Shankaran Sir, who himself was a world fellow in HIV and AIDS. The project was supported by ICMR then. Every Saturday, we collect LFT, blood for LFT and HbA/AG. So then way back in 2003, Department of Medical Gastroenterology took over the liver clinic. And from 2008 onwards, we have a dedicated Department of Hepatology, which was later upgraded as an Institute of Hepatobiliary Sciences. PG courses was also started, and now liver transplant is also being done there. And today the topic is programmatic management and challenges, state perspectives. So we have three topics: overview of NVHCP by Professor Malarvili Madam. She needs no introduction. Currently, she is professor and HOD of medical gastroenterology in Kilpack Medical College. We worked together in Salem Medical College about a decade back, where we got appreciation from the World Hepatitis Alliance twice for the screening programs. Over to you, Madam.
At the outset, I would like to congratulate the organizing team for organizing this very good hepatitis summit. And my respects, due respects to the NHM who has given me permission to talk about this topic. National Viral Hepatitis Control Program, our state perspective. What happened? So the National Viral Hepatitis Control Program was started in the year 2018. it was started in the year 2018. Then there was a COVID pandemic. It was hampered by the COVID pandemic. It was basically started as India's commitment, global commitment of the SDG, which is a Sustainable Developmental Goal, one of which was to combat hepatitis. So there were several components in the different programs which were merged together: the immunization, the Swachh Bharat mission, the safety of blood and blood products, and safe drinking water. All this were integrated, and NBHCP was launched on the World Hepatitis Day on 28 July 2018. And it rolled on to the National Health Mission to provide preventive, diagnostic, and treatment services. So this is coordinated by the states. It has a component of a National Viral Hepatitis Management Unit, a State Viral Hepatitis Management Unit, a District Viral Hepatitis Management Unit. So what is the state program? We have a steering committee. The steering committee comprises of the policy makers with the technical expertise. They make policies, and there are treatment centers. The State Viral Hepatitis Management Unit will have a model treatment center, a state lab, and then they will have a district treatment center, and this has to percolate into the sub-district level at the community health center and primary health center. So what are the key components? As already discussed from the morning, it is prevention, diagnosis and treatment, monitoring, evaluation, and capacity building training and research. So what is the state perspective? Our prevalence, this is a prevalence study which was done in 2015 and 16, a sample survey where we are in the blue line when it comes to hepatitis B, a prevalence of 1 to 1.5, and C it is 0.16. So what are the functionaries? It is headed by the dynamic mission director of the National Health Mission, which is integrated with the JDHS of RCH and immunization. We have a state nodal officer and the program officers who are NHM consultants and a data entry operator. All these people are state people who give technical advice and guidance, ensure supply of diagnostic kits, ensure prompt supply of drugs, conduct monthly review meeting, they collate and analyze data, and also they conduct expert meetings. And it is integrated at the state level where you have a JDHS, RCH and immunization, where there will be a screening of AN mothers. If they are positive, they are referred for an institutional delivery, and hepatitis B immunoglobulin is given to the newborn. And a state nodal officer for dialysis, where the high-risk group immunization takes place, where you can reduce the transmission among dialysis patients. The new kid on the block is the integrated target intervention, that is, screening of 3 diseases, the STD, hepatitis B, and hepatitis C. This happens in the prison, and this is with the help of volunteers from the TANSACs, where they screen the prisoners for all the 3 diseases, and treatment and counseling is given. The Ministry of Social Welfare and Justice is also roped in for screening at the de-addiction center and rehabilitation center, the psychiatrist for the counseling, and narcotic supplements for those who are having an IV drug abuse. So we have a model treatment center at RGGH and one at Madurai Medical College, and a state reference lab at RGGH and Madurai Medical College, where it is headed by a nodal officer, a pharmacist, a data entry officer, and a peer supporter. And the state lab run by the state lab nodal officer, lab technician, and data entry officers. Similarly, at the district level, you have a treatment center, and the one thing which is, they are at the district level, they are also people from the DMS and the DPH side who are NHM coordinators, the district maternal child or health officer, assistant program officer, district health officer, district training medical officer, the ANM and the VHN. So this program is integrated at all the levels to prevent, screening and immunization, for diagnosis and treatment, conduct monthly review meeting, consolidate the district report, conduct camps in prisons and health camps. So the surveillance is the low-hanging fruit. The low-hanging fruit, I mean, is the high-risk groups. What we do at the institution is, we target only the high-risk group, those who come for blood banks, the dialysis units, the transgender clinics, the STD clinics, the psychiatry OP, cancer clinic, and hemophilia. This happens in the institutions, but unfortunately, the community level, there is not much happening of the surveillance. So we should not keep hanging on to the low-hanging fruit. The strategy should gain momentum because the countdown of 2030 starts. We are only 5 years behind that. It's a time to strategic modifications, revamp and revisit the operational guidelines. Then only we will be able to combat hepatitis and strive towards elimination. So what are the scope of improvisation? We have to improve surveillance. The surveillance should happen at the PHC level. Tamil Nadu is one of the states where we conduct NCD-OP and there is something called a Makkalai Thedi Marthuvam. Here you can identify the risk population. The hypertensive and diabetics could be a potential CKD patients. If you are identifying this CKD and if you give a double dose vaccination at the primary level, because they are the source of transmission once they go on for hemodialysis. And at the community level, the IEC activities should be undergone and outreach activities, school health and awareness campaigns should happen. So what is the missing link? The missing link is, unfortunately, we don't percolate to the bottom level where the PHC, community health center, that is the one which is, the program has not taken very well. At this juncture, I request the integrated, already we are doing integrated service of RCH and immunization. But IEC activities should happen. This juncture, I request the district health officer, the DD training medical officer, the assistant program officers to kindly actively participate to educate your VHN, ANM and staff nurse in the PHC. So the scope of improvisation as diagnostics, as everybody was discussing, we have to ensure quality control because only then we will be able to identify who are the eligible patients, whom should be put on treatment. And there is one more thing is hepatitis C requires a stoppage of treatment after 3 months. That is solely dependent on a very quality control of HCV RNA detection. For this, we have to send for an EQAS and training workshop should be conducted for lab technicians. And we can improve, like a difficult terrain, there is something called reflex testing, where so a sample can be taken and it can be stored in a laboratory. The patient need not visit the healthcare facility the second time. Once the sample is tested for an anti-HCV positive, the sample which is stored can be tested for HCV RNA or HBV DNA. This one reflex testing can be a pilot project for improving our scope of improvisation. The scope of improvisation as treatment. All of us know that antenatal mothers, we screen them, we ask them to go for institutional delivery. But a viral load test has to be done because a high viral load dictates the transmission during the delivery. So treatment with tenofovir at 28 weeks if indicated will prevent the transmission. And recently the WHO has come with guidelines of treatment of children about 12 years of hepatitis B and HCV treatment for children about 3 years. And scope of improvisation in vaccination, you should ensure birth dose vaccination and high-risk group vaccination. At this point, I would like to say our NHM was pertinent to get this high-risk group vaccination enrolled in this year of program. And also, he was very, very pertinent in doing healthcare workers, especially the students. He was very, very interested in getting the students vaccinated. And one more thing is the family contacts we are not vaccinating. That also should be included. And for healthcare workers who are routinely they are exposed to the risk, we should conduct a periodic anti-HBs titer for 5 years, and then if they are eligible, a booster dose of vaccination should be given. The scope of improvisation doesn't stop here. We need research and publications because we have to encourage prevalence study. Till now, the government of India, the transgender data, if you take, the percentage will be high in Tamil Nadu because we have a state. Thanks to one of the Stanley Medical College, Professor A.R. Venkateshwaran, he has done an HCV prevalence in transgender. I request all of you, the medical institutions, to take up research and publications for encouraging prevalence study. And pilot projects can be done using the diagnostic like reflex testing, point of care testing. And one more issue we are having is treatment failure, where you can do a whole genomic sequencing to identify mutation, especially in patients with hemodialysis. We can involve the Society of Gastroenterology and the private-public coordination. And you can also use an AI and digitalization for predictive models. To conclude, National Viral Hepatitis Control Program, which was started in 2018, the goal of elimination by 2030 it is to reduce the incidence by 90, mortality by 65%. So we have to gear up and we have to give a strategic improvisation in surveillance, diagnosis, treatment, vaccination and research is the need of the hour. So advocacy, capacity building should be perpetuated to the grassroots level. A teamwork only will pave way towards the goal. Together we can. Thank you.
Thank you, Dr. Maladwali, for the talk. And any suggestions from the floor?
I am Dr. Venkateshan, former Director of Medical Gastroenterology, MMC. Thanks, Malal, for inviting me, because I did the initial work in transgenders. It's difficult work in transgender. When 2018, when we started the National Viral Elimination, now it has become controlled. I myself, along with Priya and Abraham, as well as with Taslim, we are the first members. We started the program under Professor Dr. Nadu was the coordinating officer at Delhi. Only one suggestion is that I did a study in prisoners, both remand and convict prisoners at Pearl Jail, way back in 2015. The study was published by my assistant professor, now he's an associate professor at Austria, Vienna. We found certain cases which were brought to Stanley for treatment. One suggestion is, all the patients who come to the hospital, is it difficult to get hepatitis B testing? If you test one shot, and if you vaccinate those negative, the entire load will go away, because treatment is prolonged. There is only one saying in Tamil. Hepatitis C means is 3 months or 6 months maximum. C months, God will cry. In my lifetime, I don't think you will see the end of B. That's what the suggestion is.
Thank you, sir.
Any other questions and suggestions? Thank you, Dr. Malavali, for highlighting about the program, National Viral Hepatitis Control Program. Maybe we'll go on to the next topic. Now may I invite Dr. Vinay Kumar, Joint Director Immunization and State Immunization Officer, Tamil Nadu Government.
Yes, before we move forward, requesting our chairs to please do the honors and present Doctor with a token of our appreciation. Following which, we would call upon our next speaker to join us on stage. Thank you so much.
Dr. Vinay Kumar, Joint Director, State Immunization Officer, Tamil Nadu. He's contributed a lot to the society with 14 years of experience in World Bank's supported Tamil Nadu Health System Project and National Health Mission. Is a leading universal immunization program in Tamil Nadu since 2022, and he has been overseeing special immunization initiatives including COVID and hepatitis B, HPV vaccination, hepatitis B as well. Over to Dr. Vinay Kumar, please.
Respected chair and chairs and dignitaries of the dais, on the dais and off the dais, and the organizers, a warm good morning to everyone. And also my sincere thanks for giving me an opportunity, and to the mission director. Sincere thanks for the opportunity given for this addressing the gathering over here on this immunization as a pillar, and also the gap for what is the gaps and challenges for these activities. So first of all, sincere apologies for being delayed, because I was held up in another program of HPV vaccination. So we're going to roll out HPV vaccination in Tamil Nadu. So I was held up over there. I'm sincere apologies for the chair also. And I'll just start the presentation on immunization as a gaps and challenges for the hepatitis B elimination. I know I've seen the audience mostly from the assistant program managers, microbiologists, and the treatment nodal officers from the state. So my perspective here will be a public health person, and odd man out maybe from the clinical modality. So what my previous speaker was talking about is about the prevention is the first part of the key element of the entire National Viral Hepatitis Control Program. So I talk about mostly on the preventive part of the hepatitis B, which we are sitting over here for this Elimination Summit. So the entire presentation I just gathered like this, introduction and then immunization, because since everyone are doctors over here, and everyone who have been a PhD medical officer in a career, so just I want to know updates about the immunization, and then go about what is hepatitis B vaccination, what we are giving to the people of Tamil Nadu and to the country of India. So I thought of giving a short brief about immunization in India, and then immunization in Tamil Nadu, and then what is impact of UIP programs, and then finally the topic of discussion on hepatitis elimination. So of course, one thing is immunization, most cost-effective health investment, everyone would know, so I don't want to drag on this slide. And of course, by immunization, you all know that we have eradicated smallpox, and we eradicated polio also in India. And of course, globally, polio is not being eradicated, so we are continuing a polio vaccination in the UAP schedules. And UAP, we are having this largest public health program. I just have a lot of thing to say that Immunization program is one of the largest public health intervention and the oldest public health intervention program in India. It started in 1974. The only program which started before is about only tuberculosis control program 1962. And after this immunization program, we are running for last 50 years. So this is a program running for last 50 years. And of course, the effect of immunization in the globally is about we are reducing deaths more than 1 to 3 million deaths. And the program, of course, I already told that we have 1985, we started the universal immunization program. And we are vaccinating, we are giving 11 vaccines against 12 diseases which contains 13 antigens. And the only thing, other main important point in this immunization is about all the vaccines which we give to the people of Tamil Nadu and to the Indian countries, all Indian made. It's all made in India, and we're not importing any vaccines from any country. So we are self-sustained in vaccinations. And of course, 60% of the vaccines, to the global vaccines, are supplied from India. So the only point I want to tell in this slide is about we don't have face any shortage of vaccines in the universal immunization program. If to happen, it happens for a short period of 1 or 2 months. That's the maximum shortage which we encounter in the immunization schedule programs. And of course, these are the milestones. And finally, everyone can't forget the last point of the slide, COVID. So we faced COVID, and it was again, we vaccinated more than 200 crore beneficiaries in COVID vaccination, and we gave the COVID certificate. So we are able to, so vaccination, we are able to do it. So coming to the hepatitis B, again, vaccination prime important point, but the problem, what I'm going to just to tell to the treatment nodal officers as well as the microbiologists and the APMs is about the issues what we're facing in hepatitis B vaccination. And of course, this is a roadmap, and hepatitis B, all the yearly, of course, the last 10 years, we are introduced more than 10 new vaccines into the system. And right now, we are going to introduce the HPV vaccination and typhoid vaccine also into the system. And of course, new vaccine introduction, I just run through the slides. The objective of the entire program is to have 90% full immunization coverage. That's only our aim of the entire program. And of course, we are targeting the MR elimination and polio-free, and maintaining the polio-free status. And this is an example of how immunization by say, we have eradicated certain diseases. One is the smallpox, another one is the polio, and tetanus we have eliminated right now. And the efforts globally, we can see that performance of India and globally. The Unigenic is a report from WHO and the UNICEF. They do independent analysis of the country's immunization performance. So you can see India is standing ahead of the global perspective. It's 93 against 71. And these are the program, the pertaining to this audience is hepatitis B coverage. Administratively, the admin data and the official data shows more than 86% of the kids, infants are vaccinated within 24 hours. So basically, you all very well know that we should vaccinate hepatitis B within 24 hours, but unfortunately, we are able to less than 90% only in the hepatitis B within 24 hours. And this is after 24 hours, again, it is 90.74%. And of course, this is not known. And the immunization division where I come from is, we have a lot of various departments and joint directors working for the public health department, and one such is immunization division. And we have this program being reviewed in this planner of universal immunization program and special immunization program. I just want to say over here is about this hepatitis B vaccination being carried out as a both birth dose vaccine as well as pentavalent vaccine as an universal immunization program. And we have this special immunization program which we are vaccinating the healthcare workers and high risk groups. The thing is, we are doing the routine activity of giving a birth dose to the infants and also the pentavalent doses to the infants. But healthcare workers were not very much successful, and also the high risk group, as we already talking about, we need to start for the high risk group at present. And of course, the programs, I already told, 12 diseases, 11 vaccines are being given over here. And we have more than 3,000 cold chain points and 12,000 vaccinators. The only reason I'm projecting slide is, if vaccines are available and vaccines are given, and when Tamil Nadu is able to procure the vaccines, or Government of India is going to supply the vaccines, it's not easy, it's not a tough task for us to vaccinate all the healthcare workers and the high risk groups. And of course, these are 11 vaccines which are giving to thing, and I just want to say is hepatitis B, as a birth dose we are giving, and as well as our pentavalent we are giving one of the 5 doses, one of the 5 antigens. At birth we are giving hepatitis B, and 6th week we are giving pentavalent, 10th week we are giving pentavalent 2, and 14th week this pentavalent 3. Just to orient you, what is the hepatitis B component given in the universal immunization schedule in India and in Tamil Nadu. Of course, coming to the performance, comparing to the NHS 5 performance, the HMI's performance of 24 till December 25, we are ahead of the National Health Surveys. So we can see the blue border over there, which is all about 100% BCG, and Penta 3 is about 95%. It's all HMI's reports. I again have my own apprehensions, being it's a closed forum within our group, within our fraternity. HMI's reports are just HMI's reports. It's only a number report. It is not the line list data. So we cannot 100% sure about this data is perfect. But anyway, since many states do not have a line list portal, we are only following the HMI's portal. Again, my own apprehension that we need a line list data to say all the 100% are immunized. To be very frank with you, and Professor Shanmugam sir also knows that we had a series of events like from January or 2025 to July 2025, there was an acute shortage of hepatitis B vaccine in the private market. But Government of India is able to supply the vaccines for the universal immunization program, and we are able to vaccinate. And there is a system, even then also we got the percentages, 95% in immunization in the HMI's performance. So this is the one what I am telling to you right now is we need a line list database which the viral hepatitis control program is able to get it, and this is only dependable data which we can rely upon. The HMI is mere numbers. Numbers, when we have a strong review or a strict review, the numbers may increase. So mostly I don't depend on HMIS. My only depending on the Pakka UWIN portal at present, what Universal Immunization Program is doing upon, and of course the PICME portal. And this is the one source, again I am saying from the HMI's perspective only. So hepatitis B, the target of a global, Indian review point will be 95%, and incidentally we are all able to be 99%, which really I admit that it's not the exact figure, maybe. Why? Because of that there was a shortage of vaccine in the period of 6 months, where in Tamil Nadu 99% deliveries happens in institutions, and out of it 65% happens in government deliveries and 35% happens in private deliveries. And it's very hard to believe that all the private deliveries got vaccinated hepatitis B within 24 hours with no vaccine available in the private market. Because vaccines are available in the government system, either think they had to come to the government PHC, or should have gone to there to vaccinate the kids in the private hospital, which is not so. So 100% we can say it is not 95%, less than that, but for an HMI's figure it is 99%. And this is the coverage data for the 2023-24, and we are doing above 98%. And they just want to say the impact of universal immunization program in the diseases. So we can see the number of cases in 1981, and there are 0 polio cases. Again, polio deaths also nil at present. Diphtheria again 317, now no cases. And deaths also not happening at present after 2006. And these are measles cases. Of course, measles are reporting in Tamil Nadu, and measles indicates a clear indicator, it's a proxy indicator of a immunization gap in the community. If there is a measles case being reported in a system, it clearly indicates there is a dropout in the measles vaccination. It happens because any child born will be from 0 months vaccination, 6 weeks, 10 weeks, 14 weeks. The mother will be very interested to get vaccinated. Then there is a gap of 9 months and then the 18 months. So what happens is, come after 1.5 years, the mother may skip off the doses. And there are migratory things also, because the mother get delivered in the mother's house and then shifted to her husband's house. So there is a gap in those things. That's the reason why it's delays. I'll come to the point finally, just last 5 minutes. Yeah. And then this just to show the measles cases also reported. Coming back, these are measles cases also being reported. And now coming to hepatitis, the point of view for discussions today. Elimination, of course, everyone told that prevention is the first point. We need to go by preventive aspects. And of course, I've already dealt by the state nodal officer, ma'am. I don't want to run the slides here. So as the program says, the objective of the program, I have just highlighted the 2 points over there. There are many objectives. To my perspective as a public health person, my perspective is on first and fifth point. Enhance the community awareness on hepatitis and lay stress on preventive measures among general population, especially high-risk groups and in hospitals. I need to target upon as a public health person, and APMs, all the APMs also over here, and also develop linkages between the national programs towards awareness, prevention, diagnosis, treatment of viral hepatitis. So again, the program strategy in the viral septal control program, my scope as immunization joint director or state immunization officer, I need to give for immunization for the healthcare workers and the high-risk groups as being done by under universal immunization program. And the key components over here will be the birth dose, high-risk groups and healthcare workers. And of course, this activity has been already explained to you. Administer hepatitis B vaccine to the newborns during the hepatitis B positive mothers, and vaccination of healthcare workers and high-risk groups. And as Madam also said, they allocated 50 lakhs for high-risk groups. The proposal, government order is yet to be approved, if I'm right. So once the government order is approved and the procurement has happened, we can start the high-risk group vaccination here. So before that, I just want to say what are the vaccines available in the system at present. There are more than 12 vaccines available in the system. And all the green color indicates we are included in the universal immunization schedule. Other things, Sinopharm, Glassmith, that's not included in the immunization schedule. There are 10 type of preparations are available for the hepatitis B vaccination in the system. And the recommendations for hepatitis B, according to international WHO recommendations, newborn children up to 18 years and all adults with high-risk infections. And the viral hepatitis control program says birth dose, high-risk groups, and healthcare workers. So what we started as the last 2 minutes presentation. So the healthcare workers, which we are dealing upon. So healthcare workers, we started the vaccination. We gave the requirement to Government of India. In 2018, we wrote to Government of India. Government of India gave more than 7.8 lakh doses of vaccine, and we distributed to all the 42 treatment centers, including the PHCs also. And then finally, we got vaccinated, and the estimated target was about 2.2 lakh as per the CoWIN portal, because by then the CoWIN portal, all the health workers were pre-registered in CoWIN portal, so we got the database from CoWIN portal. So it's for 2.24 lakh. But the performance is really this is a system. Of course, you all know that. So 1 ml, 0, 1 and 6 months, and universal schedule we are giving 0.5 ml, whereas adult injection we need to give 1 ml. And this is the performance. So we got the vaccine in 2001, 7.8 lakh as 0.5 ml dose. So we need to give 1 ml. The utilization is only 3.2 lakh doses only. The balance 4.5 ml doses was unutilized in the healthcare settings, including the 42 treatment centers and the medical college institutions and the government hospitals. But now we are talking about prevention and giving healthcare workers a vaccination. I gave the vaccine as an immunization officer, I gave the vaccine to the healthcare workers for vaccinating, but the response was very, very meager, and ultimately we got 4.5 lakh vaccines unused, and I converted it into the universal immunization schedule. So this is a rough analysis. Only 41% of doses given were utilized by you. And among 41, only 33% have the first dose vaccination. And among the 33%, 71 only utilized the second dose vaccination. And among the 71, only 48% completed the schedule. So ultimately, only 48% of the 71% who 52,637 persons who got vaccinated. So we gave the vaccines to you, we gave the knowledge to you, we gave the awareness to you, but since the response even from the health sector, from own health sector, is very less when compared to hepatitis B vaccination. And of course, now a proposal has been requested from NHM, and we gave the revised number of 1.25 lakh again for the doctors, all the param, including there's a concern for the nursing students, A&M students, and MBBS interns. Everyone we have included right now. We are giving 1.25 lakh as a number of healthcare workers to be vaccinated. And we are given to NHM, and through the NHM is a PIP proposal. We'll be getting the funds for that. And of course, I have requested only for 3.38 doses, because we'll first complete 0 and first dose. I can't wait for the 6-month dose, so I've just proposed only for 0 and first month dose initially, and then we can get the doses later part. But again, this process just started. It is not taken up to the ROP level. Maybe once NHM approves it, we can go ahead on this healthcare workers continuation of the vaccination program. Coming to the high-risk group, as Madam State Nodal Officer said, we already proposed for high-risk group, including we had a meeting with the TANSACs and other departments, and we have line listed the details. Of course, we have more than 2.16 high-risk groups available to be vaccinated in Tamil Nadu. We got the line list, and only thing is we need to get the vaccines for them. Once the vaccine is available, we'll be able to complete the vaccination, and I can use my own staff, or even it's an intramuscular, so even a staff nurse can be given trained on these activities. And coming to the gaps, what I find in the birth dose gaps is only missed birth doses, because as I already told to you, there may be some issues in the children, infants. The hepatitis B will not be given within 24 hours, but still we forget our own consciousness and we write as given as within 24 hours. That's not happening anyway. And we do find when we enter the inspections and all, we can find out the baby is not given hepatitis B, but still the report says hepatitis B given within 24 hours. It is really, we should feel for that. We're giving a false information to the mother and to the child. And when compared to other things and all, priority groups, usually the third dose getting delayed always. And schedule gaps, we are able to follow it up. And of course, just want to say how as a joint director immunization or state immunization officer, I can have a role on this hepatitis B elimination. We have a strong experience of COVID vaccine experience. We get vaccinated more than 12.7 crore vaccinations within a span of 1 year, so it's not a big deal for us. We can do that. Only thing is we need support and we need consent from, not a consent, we need support from the healthcare workers first of all, because even for COVID, when Health Secretary Sir himself got vaccinated, we were able to improve the vaccination coverage. Even our own fraternity, we were not able to come out with the COVID vaccine initially. So this obstacle what we are facing at present. So the thing is, many people doesn't have the records with them. I'm sorry, just completed. Yeah, doesn't have the old records, but still we need to get the records available for the hepatitis B vaccination, get the vaccination done. That's it. And finally, immunization, we can rely upon immunization for hepatitis B elimination. And of course, everything is available and we have the vaccinators with us and we can do it. Thank you.
Thank you, Dr. Vinay Kumar, for the extensive coverage on the vaccination program in the state of Tamil Nadu. Due to want of time, we are moving ahead with the next speaker. And maybe any questions, maybe you can ask during the lunch time.
Requesting our chairs to please do the honors. Thank you.
So next I call upon Dr. C. Vijay Shankar, gastroenterologist from Madurai Medical College. He is a nodal officer from Madurai Medical College to talk on clinical management of hepatitis B.
Good afternoon to all. This is a pre-lunch session. I'm trying to limit it to a short, but the feasibility is questionable because most of the doubts I get from the treatment centers is regarding hepatitis B. And there are several treatment strategies like treat all, treat select, but I'm going to confine to the National Viral Disease Control Program guidelines. And this all, in the previous lectures, we see it is the most rampant disease which can ultimately lead on to cirrhosis and HCC. And about 40% of HCC and 20 to 30% of the cirrhosis in India is due to chronic HPV infection. But the favorable factor, it has an effective vaccine and then safe and effective antiviral therapy. And coming on to the natural history for understanding the treatment guidelines, mostly in India, the perinatal transmission is the most common route of transmission from mother to child, which accounts for about 60 to 70% of the cases. And these infants, when they acquire the infection due to the weak immune response, they have more than 95% chronicity rate. Whereas adults with a better immune response, even after 5 years, they are able to clear the virus. They can have a mild acute hepatitis, which resolves soon, and the chronicity rate is only less than 5%. And these are the stages of HPV infection patient undergoes once the virus enters the body. The first phase is the immune tolerant phase. It is mainly due to the presence of hepatitis B E antigen. The envelope antigen is responsible for the viral replication, and also it helps the virus to escape being unidentified by the host immune response so that the virus can build its army in this phase. All these phases are mostly seen in the perinatal transmission, and the immune tolerant phase can last up to 2 decades. And then because of the immune pressure, the virals will get cleared, and in this phase, the DNA will be lower, and the E antigen will be destroyed by our home immune response, and anti-HB antibodies develop, but at the risk of hepatitis, recurrent flares of hepatitis, which can occur for years, leading on to chronic hepatitis. And ultimately, patient can land in an inactive carrier state with anti-HB antibodies with low DNA levels, but inactive carrier is also a misnomer. Even ALT flares of about 4.6% happen in this period. And then once the immune response overtakes the virus adapts to fight back by mutation, that is the pre-core and core promoter mutation, it able to replicate even in the absence of E antigen, and this is called as E negative hepatitis, which is most severe and fluctuating disease. And very rarely, less than 3% can clear the virus and develop anti-H-based protective antibody. And because the immunity is the key factor in liver injury, the virus will destroy the immune response, will destroy the liver cells, immune system will try to heal by fibrosis. This process occur for decades and leading on to cirrhosis. And then comes a question, whom to be treated? Those patients, individuals who have features of liver injury in the form of ALT alteration, or who had a sequelae of liver inflammation happening for over a variable period of time in the form of liver fibrosis, these patients should be treated. But identification of liver fibrosis is by liver biopsy, which is practically unacceptable, and there comes the roles for the non-invasive testing and the fibroscan. And when we label as a persistent ALT elevation, when there is at least 2 values of ALT alteration above the normal, taken 4 weeks apart in the last 6 months, this should be taken as due to can be activity of the virus, and the normal can be as per the lab cutoff, or the 40 international units male or 30 international units male. What is the difference between ALT and AST? The ALT usually indicates the injury, what happens to liver as of now. It indicates an active hepatitis, and AST can indicate injury to the liver happened so far. So it is indicative of fibrosis, so it is incorporated in the non-invasive markers for fibrosis. And the APRI and the FIB score is the most widely available test, because these can be done even with a basic investigation like AST, ALT, platelets, and the fibroscan. The APRI is the AST platelet ratio index, incorporating AST values and platelet counts. A value of more than 2 is suggestive of cirrhosis, and APRI score of more than 1.5 indicates significant fibrosis, that is the F2 fibrosis. And FIB score incorporates age, AST, platelet, and ALT values. The FIB score is equal or more than 3.25 indicates cirrhosis, and more than 1.5 indicates significant fibrosis. But care should be taken when we are doing this non-invasive markers, because there can be flares of acute hepatitis in patients with chronic hepatitis B. These patients can have false positive results, and also other coexisting disorders like alcoholic hepatitis and drug-induced hepatitis can alter the scoring system. And the formula appears complex, but there are several calculators. Even our MAS portal entry, if we enter the values, we will land up in the APRA and FIB score. And other option is the fibroscan, which is available only in few centers, and it can measure the liver stiffness. A value of more than 12.5 kilopascal indicates cirrhosis, and more than 8 indicates fibrosis. It varies based on the disease etiology. And this is the chart which should be held in every treatment center. Though it is applied complex, it can be easily sorted out. Once a patient is HPCG positive comes to our clinic, we should do the non-invasive testing and identify whether the patient is falling into cirrhosis or not. If APRI score is more than 2 and FIB score is more than 3.25, these patients, irrespective of other lab parameters like enzyme alteration or DNA, they should be treated. And once the patient, stating a non-cirrhotic is main concern, and one patient is non-cirrhotic, then we should look for whether the patient having persistent ALT alteration. With persistent ALT alteration and with high DNA, these patients should be treated. Even though the patient doesn't have a high DNA levels, even DNA more than 2000, but they have evidence of liver injury, liver fibrosis, that is the significant fibrosis, F2 fibrosis with APRI score of more than 1.5 and FIB score of more than 1.45 and thrombocytopenia, these patients also require treatment. Hence, cirrhosis, irrespective of other parameters, they should be treated. Non-cirrhotics with persistent ALT alteration with high DNA should be treated, and non-cirrhotics even with a DNA of more than 2000 with evidence of significant fibrosis by non-invasive testing or thrombocytopenia should be treated. And what are the drugs available as per the NVHP program is tenofovir disoproxil fumarate available as a 300 mg dose, and entecavir used as 0.5 mg for compensated cirrhosis and 1 mg for decompensated cirrhosis, and TAF at present is not available in the program. And how to select the antiviral drugs? Patients older than 12 years, only pediatric population, entecavir is recommended. Patient with more than 12 years, drugs with high barrier of resistance, both entecavir and tenofovir are higher barrier for resistance. They can be used for long period of time. In women of childbearing age, tenofovir is a preferred drug because if they consequently become pregnant, the tenofovir is the only drug that can be continued during pregnancy. And tenofovir has few disadvantages as with related to bone disease and altered renal function. And in this situation, entecavir can be preferred over tenofovir, but the recent analog of tenofovir, alafenamide, is usually free of this renal and bone toxicities. And once the patient is started on treatment, he should be monitored for the disease progression and response to treatment, and also monitored for drug-related side effects. That RFT should be monitored 6 monthly and monitored for hepatocellular carcinoma. So chronic hepatitis B is a condition in which cirrhosis, even without cirrhosis, the patient can progress to hepatocellular carcinoma, because cirrhosis is a risk factor for HCC, but there are certain situations in which it can progress even without cirrhosis. In the chronic HBV is one, hence ultrasound should be done, screening should be done for any abnormal nodules in the liver every 6 monthly. At the first visit, patient comes to a treatment center, we should do just a basic test, CBC and LFT, and to calculate the APRI score and FIB score, and ultrasound should be done, and HPV DNA should be done. All patients should be tested for co-infection like HIV and HCV. And once the patient is on follow-up, they should be followed up for ALT every 6 months, even initial phase if they are not started on treatment. If there is ALT alteration fitting on to persistent ALT criteria, they may need treatment on follow-up. So ALT should be done every 6 monthly, and HPV DNA should be done annually, and APRI and FIB scoring also should be done every 6 months. Once patient is started on drugs, the renal function should be monitored every 6 months. அவருக்குள்ள 4 bill, எனக்கு 2 bill. And coming on to the special situation, pregnancy and HPV, pregnant women similar to non-pregnant women, if they fall with the high persistent ALT alteration with high DNA titers and cirrhosis, they should be treated with antiviral tenofovir. And the use of antiviral drugs to prevent mother-to-child transmission is unclear. And hepatitis B is not a reason for considering termination of pregnancy or not an indication for cesarean section. And coming on to other co-infections with HCV, it is mainly both has the same route of transmission. When there is a co-infection with HCV, there will be accelerated disease, and HCV will be the main driver of the disease, and B will be suppressed by C. But once if we treat C with DAAs, there will be reactivation of hepatitis B, and once even the patient can be started concurrently on hepatitis B therapy along with C therapy. And other co-infection we commonly encounter is HIV and HBV co-infection. Both has deleterious effects on other. HIV can increase the high DNA polymerase activity of B, and there will be low loss of E antigen and increases cirrhosis and HCC. And also B also will cause faster CD4 decline and also increase incidence of ART toxicity and risk of immune reconstitution hepatitis. And the tenofovir-based regimen is routinely incorporated in the ART regimen, and it itself will cause significant DNA suppression, E antigen loss, and also will reduce the progression of the disease. And there are special situations. Once, if you are clear with the case patient who are fitting with the treatment guidelines as per the high viral load or with the ALT alteration or with evidence of features of cirrhosis and with evidence of fibrosis in non-invasive scoring, the patient can be started on treatment even in peripheral hospital itself. In special situations like cirrhotic patients, they need further endoscopy and for varicose screening, and those with co-infection, those post-chemo reactivation, those with virological failures, these patients should be referred to the model treatment centers. And take-home message, perinatal infection is associated with more than 95% chance of chronicity, and the prevention of mother-to-child transmission is the main mode of prevention of chronic hepatitis B. And the treatment can be decided based on the liver injury as by ALT flares or by evidence of liver fibrosis in non-invasive markers. And chronic HBV is at risk of HCC even in the absence of cirrhosis. So all chronic HBV patients should undergo HCV surveillance 6 monthly by ultrasound. And tenofovir and entecavir, which are the drugs available in the program, both have high barrier of resistance and both are safe for long-term use. Thank you.
Thank you, Dr. Vijay Shankar, for the extensive lecture. I think questions can be taken up during the lunch session for the want of time. The next lecture is on clinical management of hepatitis C by Shafiq, who is from Tirunelveli. Medical College, who is a senior assistant professor, who is well interested in all the therapeutic endoscopy. Over to Dr. Shafiq, please.
Good morning, everyone. First of all, I am thanking the opportunity for giving me this. And I also very happy to speak in front of my teachers. My topic is clinical management of hepatitis C in purview of National Viral Hepatitis Control Program. To have a brief introduction, hepatitis C, it's a single-stranded RNA virus. It replicates cytoplasm. The beauty of it is it serves mRNA, which can causes viral replications. It has two proteins, that is non-structural and structural. Why it is so important is the reason DAS, directly acting antivirals, acts mainly on these non-structural proteins, whereas the previous era of PEG interferons, they activate the immune activation. So this virus entry into the body, you all know about IV drug abuse, blood transfusion, sexual activities. And we have lot of serotypes, genotypes. There are around 7 major types of 1 to 7 genotypes. This is one of the reasons there is no vaccination for hepatitis C because of lot of the subvarieties, genetic variation. We don't have vaccination so far. And among the genotypes, genotype 1 is common, and genotype 3 is more common in India, and is also very difficult to treat. They postulated few reasons why it's very difficult to treat, because it's more common in IV drug abuse, and it has low SVR rates, and needs prolonged therapy, and it has high relapse rate, etc. And transformation to HCC also is very common in genotype 3. Coming to the HCV natural history, whenever a patient infects, about 55 to 89% will go for chronicity, around 2 to 24% will go for cirrhosis. Rapid progression, as I already said, genotype 3 is very common, and patients with dual insert like alcohol or HIV co-infections will progress rapidly. Similarly, decompensation, the patients go 3% per year, and HCC around 1 to 4% per year. Diagnosis, you all know about the anti-HCV antibody we do. The next is the HCV RNA, which can be detected every 2 to 3 weeks. So the window period is most important. So especially in like dialysis patients, we have to detect the HCV RNA is the most preferable method, though it's not practically possible for all the patients. Whereas the antibodies take some time, like 2 to 3 months to occur. As Madam said about the HCV core antigen, which is also one of the recent marker, will be useful, especially in case of the dialysis patients. So treatment for these patients, we have to reduce all the case-related mortality and adverse consequences like cirrhosis and HCC. So who all is eligible for treatment? Whoever unlike acute hepatitis B virus, whereas C, we have to treat all the patients, both acute and chronic, except those patients with short life expectancy. The history of treatment of HCC dates back to 2011. So those days very, very difficult because we have to entirely depend on this interferon-based treatment like peg interferon. Since it activates the immune system directly, we have a lot of side effects. You have to admit the patients, you have to keep in monitor. This treatment only can be done by specialist people like hepatologists, because patients develop like flu-like symptoms, fever, body ache. They may have at least 2 to 3 days of body ache. Psychiatric problems sometimes occurs. And another disadvantage is it cannot be given to cirrhotic patients. Decompensated chronic liver disease, peg interferon-based therapy cannot be given. Next comes the direct antiviral treatment from 2011 to 2014, but still it is also a peg interferon-based regimen along with the direct DAAs and ribavirin. Initially, boceprevir or tenofovir was recommended, but the duration is very long, 24 to 48 weeks. In spite of this triple-based therapy, still the sustained virologic response was achieved only in 65 to 75% only, and it also has high toxicity. Then comes our wonderful drug, sofosbuvir, in 2015. So the treatment of hepatitis C was simplified after the invention of the sofosbuvir. I am going to talk about the treatment aspect in 3 categories. One is the patients without cirrhosis. The second category is patients with compensated cirrhosis. The third one is decompensated cirrhosis. So what is simplified treatment for HCV without cirrhosis? Overall indicated. All hepatitis C, irrespective of genotype. In this, our NHP program, we are not doing any genotype thing. So any genotype, you can, with chronic hepatitis C, you can give the short treatment, but they should not previously received hepatitis C treatment. So only hepatitis C naive patients we have to give. So who are not eligible, patient with cirrhosis, ESRD, HIV patient, hepatitis B positive, pregnant patients, and prior liver transplantation. So how will you follow this patient? When you confirm that the patient's complete 12 weeks of treatment, we have to see whether the patient is having ongoing HCV infection history, like IV drug abuse, like any risk infection, we have to curtail the risk infection. Ask the patient not to take alcohol, but there is no specific liver-related recommendation. But for the patient who are not achieving a virological cure after 12 weeks, they should be treated to specialist treatment center where the specialists are available. For the patient who is not fit for treatment, they are unable to be retreated, they have to be under follow-up with the LFT, CBCA and PTINR measurements. So the treatment for compensated cirrhosis patients, what we do is the same thing like chronic hepatitis C patient, but child PUC A, we have child PUC A, B and C. In that only the child PUC A is included in the compensated cirrhosis. So those patients can be treated. But who is not eligible is the patients with decompensated cirrhosis, like CTP score more than 7, the patient's bilirubin is more than 2, and albumin is less than 3.5, or INR is more than 1.7. The rest is the same contraindication as the patient without cirrhosis. So how do you follow up these patients? Similarly, you have to do after 12 weeks, you have to see whether the patients achieved the good virological cure, SVR is achieved or not. If achieved, then we have to do a ultrasound surveillance for HCC. Every 6 months you have to do. The same time, we have to look for the patients whether they are going for any decompensation. For that, we have to do an endoscopy to look for any varices, or patients is having any ongoing other infections like IV drug abuse, or patient is taking alcohol. So you have to monitor serially, annually with ALT, AST, and bilirubin value. Suppose the patient not able to achieve a virological cure, you should be immediately referred to the higher center. Higher center in the sense with the center with a liver transplantation unit or a specialist there. Those patients also be treated for assess for ultrasonogram evidence of HCC every 6 months, and also they have to monitor with every 6 to 12 months with CBC and INR. So coming to the last is how you treat the patients with recombinant cirrhosis. As I said earlier, we are not using the peg interferon therapy regimen at present. So we are using this direct antiviral therapy with or without ribavirin added to the patients with cirrhotic patients. But ideally, these patients should be treated under the control of a specialist or a liver transplant unit. So irrespective of genotype, you can start sofosbuvir and velpatasvir with weight-based ribavirin for the duration of 12 weeks. Suppose patient is not eligible or a renal toxic patient, or if you not want to give ribavirin, then you can continue the drug for 24 weeks without ribavirin. The same combination of sofosbuvir and velpatasvir. So this is a summary of what I have told. So patients without cirrhosis, the duration is 12 weeks, the combination of sofosbuvir and daclofenavir. With cirrhosis, compensated cirrhosis, the same combination, 12 weeks. Decompensated cirrhosis, with ribavirin you can give 12 weeks, but without ribavirin we have to give for 24 weeks. So who are the patients to be referred to specialist centers? Patients with DCLD, treatment experienced patients, patients on chemotherapy, patients with altered renal function, patients with HCC, pediatric patients, and thalassaemic patients. All these patients to be referred to higher treatment center. So what about the patients with childbearing potential? Strictly DAs are contraindicated in pregnant women. Even also, not pregnant women also, we have to give, when we start about DAs on these patients, insist upon the effective contraception during treatment, and especially for ribavirin-based management, even after 6 months out, also we have to, after stopping the drug also, we have to give contraception. So what about HBV, HCV co-infection? This is a tricky situation. So which to be treated first, which is to be treated later? So that is the question for everyone. We have to see which is dominant, whether HBV is dominant or HCV is dominant. So this is the chart which shows we have to monitor the AST and ALT level. If it's elevated, we have to monitor the HBV DNA level. So if it is very high, there is more than 1 lakh, it considered to be HBV reactivation. So you have to start the hepatitis B treatment. Similarly, if HBV is dominant, we have to monitor the AST ALT level. If it's elevated, you do the HCV RNA. If it's elevated, it means HCV reactivation, and you have to start the HCV. So these co-infected patients will have a higher level of HCV RNA than the HCV only infected patients, because especially in HIV patients, they correlate with CD4 count. So usually this IL-10 level is proposed to decrease inflammation in HCV patients, but naturally these HIV patients have a lower level of IL-10. So there will be a observed accelerated liver disease in patients with HCV co-infected persons. We have more accelerated liver disease, especially with. So what is the treatment aspect is, first we have to start the HART therapy, that is antiretroviral therapy to be started first in these patients. It also depends on CD4 count. What they say is less than 250, if CD4 count is there, till you achieve CD4 count more than 500, you wait for the HCV treatment. Once you reach the HCV count, CD4 count more than 500, you start the combination therapy of sofosbuvir and velpatasvir. So what are the drugs in heart treatment to be contraindicated is efavirenz, etravirenz, and nevirapine should not be used. So what about CKD patients? As already mentioned in the previous speakers, there is no need for dose adjustment for the HCV. Before they used to say you have to give a sofosbuvir alternate days. Now there is no recommendation says even with severe renal impairment patients, there is no need to have an adjustment. Only same thing like child decompensated cirrhosis, we have to add ribavirin for 12 weeks. If you don't want to add ribavirin, we can add for 24 months. So only if you are considering ribavirin in these patients, especially CKD patients, the weight-based treatment. So you have to give a reduced dose. 600 milligram daily can be given. Coming to the summary of these things, when the patient is confirmed HCV infection, see whether the patient is having cirrhosis or not. If no cirrhosis, you can give for 12 weeks. If cirrhosis, you can give a ribavirin-based management for 12 weeks or a non-ribavirin management for 24 weeks. If it's complicated, like in fact, in spite of 12 weeks treatment, if it's HCV RNA is detected, then you have to refer to the higher center. So this is the thing we are doing in our NLC program. This is it's not a medical officer's work, it's a combined work. So whenever a patient comes to your hospital or any GH or a medical college, first you have to see whether the patient is already treated or experienced. If it's experienced, you directly refer to the higher center, already treated patient. If it's a new patient, then we have to see whether referred from, which healthcare providers has referred. First you do the anti-HCV done. If anti-HCV is positive, do the HCV viral load. So next is we have to enter into the treatment register and makes the HCV treatment card. Doctor has to examine the patient and advises a baseline investigations in the necessary forms. Peer supporter's role is there because he guides the patient to the laboratory. Then comes the role of the lab technicians who draws the blood and ensures the transport also. Then with the report, doctors reviews and does all the investigations and assessment. Then the pharmacist will distribute the drug. Then the data manager enters the data into the Excel sheet. So patients leave the center with the clear inclusion. So this is the model has to be followed in all the centers so that the elimination of the hepatitis C can be achieved in 2030. Thank you.
Thank you, Dr. Shafiq. I think we come to the end of the session for the...
Requesting the chairs to do the honors, presenting Dr. Shafiq with a token of our appreciation. Dr. Rivari, requesting you to remain on stage for just a moment to present the honorable chairs with a memento. If you would please do the honors, Doctor. Can we have a round of applause for all of our chairs for that very, very insightful session? Thank you so much. Thank you. Ladies and gentlemen, we will now take a 45-minute break for lunch, and we will see you back here in the hall as we begin our next session at 2:15. Thank you so much. We do have a power-packed day. We move into our post-lunch session now with a very interesting panel discussion. Strengthening treatment pathways for hepatitis elimination. I'd like to invite and introduce our moderator, Dr. Malarviri, to please join us on stage. She's the State Nodal Officer, NVHCP. She has been working towards eliminating viral hepatitis as a public health threat by 2030, and she is the ideal person to moderate this panel discussion. So, Doctor, over to you to take things forward.
Good afternoon, one and all. It is a session on panel discussion, strengthening treatment pathways for hepatitis elimination. We have three expert speakers on this. One, I invite Dr. N. Murugan. Sir, kindly join us on the stage, sir. who will be discussing the issues related to pregnancy and infection, and Dr. C. Iepan, who will be discussing co-infection with HIV, HCV, and HIV, HCV, HBV, and HCV, and Dr. Hemamala Ilango for treatment failure. Sir. உங்களுக்கு அனுப்பிச்சிருந்தேனே சார். So it will be a discussion like practical points. First, let me introduce the panelist. Dr. N. Murugan is a hepatologist and lead consultant, Apollo Hospitals, Chennai, who has a professional contribution of 25 years of clinical experience with 1,200 liver transplants, 20 publications, and research interest is mainly in ACLF, autoimmune liver disease, and mast cell D. Recipient of the Best Doctor Award from the Tamil Nadu Dr. MGR Medical University. First session, we will have a discussion on pregnancy. See, the majority of the cause of transmission of hepatitis B is mother-to-child transmission. So, mother-to-child transmission is the key. When we prevent this mother-to-child transmission, maybe we can, majoritarily we can cut down the transmission and the prevalence of hepatitis B. Sir, I just want to know what is the prevalence of hepatitis B among pregnant women?
So like Dr. Malar said, this is probably the most important route of transmission that we have to address. So the first thing is all pregnant women have to be screened, which may not be happening all the time, but wherever we can advocate that, that is very, very important. I would even take it one step further that women who are conceivable age should be screened and vaccinated. So that will go a long way to even preventing hepatitis B in would-be mothers. Even that is not a policy, but it's something that we should seriously think about. The prevalence is about 1 to 2% in pregnant women, which is kind of in keeping with the general population, which is what is expected. They are no different. I think the reports from other countries seem a little bit higher, but overall in India it's around 1 to 2%. But they are a very important source of further transmission, so this is a very vital step to prevent further hepatitis B, so towards elimination. This is a very, very key step.
We have a statistics of 10 lakh mothers, AN mothers in Tamil Nadu, and out of which 970 to 1,000, which means it amounts to 1% of, as sir said, that is the prevalence of hepatitis B. And regarding prevalence of hepatitis C, sir?
I think it's around the same, no, 1%, which is again in keeping with the general population. So it should be no different for pregnant women, unless they are high risk in terms of multiple sexual partners, IV drug abuse. It should be the same as the general population. I wanted to ask you, do you know from government hospital data, how many women actually completing screening for hepatitis B? Is it universally practiced?
Yes, sir. It's universal practice, sir. Okay. All of the antenatal mothers are getting screened for HBsAg, even at the time of booking. Okay. That time itself they are screened for HBsAg.
I think that's excellent to hear, because I think Tamil Nadu probably is much ahead of other states, because there are reports coming from around the country that the testing rate in pregnancy is very low, maybe 30-40%. So if we are doing close to 100%, that's phenomenal.
In regarding treatment of hepatitis B, sir, what do you say about the treatment? Because this program does not advocate treatment of pregnant mothers. Okay. All they do is they screen the mothers and they advise institutional delivery and newborn immunization. This program covers only this. There is no treatment of mothers, antenatal mothers.
So, like I mentioned, first we have to screen all the mothers. Around 2% may have hepatitis B. That means HBsAg positive. So, what do we do next? So, there are two things you need to do. You need to know the mother's viral status. And second, you need to know the woman's liver status, because we don't know how long the woman has this virus. And many times you get gradually fibrosis because of periodic activation, which is subclinical. And the patient doesn't know they have this, and they eventually end up with fibrosis. So these two things have to be checked.
For viral status, you do hepatitis E antigen, HBeAg. That alone is enough. You don't need to do antibodies and other things. And secondly, wherever possible, you should do a HBV DNA viral load. In private practice, we do for all patients these two tests, but I don't know how accessible it is to everybody in this country. Certainly WHO says that around the world, especially in countries like Africa, there is no access to even HBe antigen and certainly not towards HBV DNA. So it's a huge problem in many countries. So these two things for viral status. For liver status, you need to do liver function test to see if ALT is high. That indicates ongoing inflammation perhaps. Second, probably an ultrasound to just see if there is any chronic changes. But more important is to know the fibrosis status of the mother. That's again a new concept that we need to know the fibrosis status because treatment depends on the fibrosis status. So the commonly used test is elastography. There are different ways to do elastography. Commonly it is done using a scan called FibroScan, and WHO has now given values when the treatment is indicated. So they have given a value of 7 as a cutoff, beyond which you should treat any patient, including pregnant women. So these are all the tests. FibroScan is expensive, not widely available, so it may be a challenge to do it on all patients. So this is the first thing you should do. Whom do we treat? I can do that, yeah. Whom do we treat? So there are two aspects to treatment. One is to protect the mother, because if the mother has active virus not known before, and even if with or without liver disease, especially if the mother has liver disease, then the mother is at risk of having decompensation, sometimes a flare of the virus during pregnancy, which will lead to liver failure, jaundice and complications, which will affect her and the baby. So one is to protect the mother. So there are treatment guidelines for the mother, which WHO has now expanded the treatment guidelines, which applies to pregnant women as well. So anybody with a DNA more than 2000 who has a ALT which is elevated, the cutoff for that is only 19 in women. So anything ALT more than 19 and a DNA more than 2000, they are eligible for treatment. If they have DNA more than 2000 and they have a fibrosis score of more than 7 or which is F2, they need treatment. If E antigen is positive, they need treatment. So it will cover a lot of people who might need treatment during pregnancy. The second is to prevent the transmission to the fetus. For that, the cutoff, supposing they don't meet this criteria for treatment, then you see how is it safe to allow her pregnancy with the B, will the child be safe? For that, the cutoff is 2 lakhs. If the viral load is more than 2 lakhs, the child has a higher risk of getting the infection from the mother, despite the prophylaxis that we are going to give. So in this situation also, you want to reduce the viral load. When do you treat the mother? You treat them from second trimester, 26, 28 weeks. The official recommendation is 28 weeks. And say 10, 12 weeks of pregnancy before delivery, you can significantly reduce the viral load. What drug is safe? Tenofovir. There are 2 types of tenofovir. Both are safe in pregnancy. It was tested in HIV patients, found to be safe. Is considered a class B, which means human data is not there, but still is considered safe, and that is the drug of choice. Earlier we used to use lamivudine, but now tenofovir is good enough. So you treat it till delivery. All the infants at the time of delivery should receive both immunoglobulin and the first dose of vaccine within 12 hours. And then you have to complete the vaccination. In India, we give 4-dose regime. Some countries they use 3-dose regime. So this will be basically the treatment for hepatitis B in pregnant mothers.
What about mothers who are already taking tenofovir, sir? Should they continue once they become pregnant, or we should stop?
We always worry about the first trimester. I think the data is not very clear whether we should. I have not come across this recently, but personally I would continue if the mother has advanced liver disease, because there is a risk that suddenly there will be a flare and that will affect a pregnancy. So we need to know why the treatment was started. But if the mother has advanced fibrosis or even early cirrhosis, and they still chose to get pregnant because there are some risks of pregnancy in patients with cirrhosis, then yes, we should protect the mother. So I would still continue, but it's controversial. I don't know if Dr. Epen has an opinion. Emma, same.
tenofovir data we can extrapolate from the HIV treatment, so it is safe to continue in the first trimester also.
And so first trimester is okay to continue. Okay.
What about the mode of delivery? Does it have any say on the transmission, sir?
Again, you would expect slightly more transfer during normal labor, placental transfer, compared to a cesarean section, but all the guidelines from American College of Obstetrician Gynecology, Indian colleges, CDC, WHO, do not recommend mode of delivery based on the presence of virus. So that shouldn't be a consideration at all.
What about breastfeeding, sir? Is it contraindicated or you can go ahead with breastfeeding?
No, for both having the virus and for having tenofovir, you can continue breastfeeding. The tablets, if you choose to start tablets, you should continue either up to the end of delivery, up to the time of delivery, sometimes up to 12 weeks post-delivery, especially if the viral load was high. But it is safe to continue breastfeeding. Again, from HIV data, it is found to be safe, tenofovir. And even if you have virus, it may not transfer to the, it's unlikely to transfer to the child, so you can still continue to breastfeed.
What about hepatitis C, sir? Do we evaluate, if the patient is anti-HCV antibody positive, do we evaluate the person for HCV RNA
So
test?
we are focusing a lot on hepatitis B in pregnancy, partly because there is options to treat and prevent complete transfer. And secondly, because of the higher rate of maternal fetal transfer of hepatitis B traditionally known. It used to be the highest mode of transmission in India, but now with all these measures that we talked about and screening, it is now getting lower than blood-borne through needles and equipment. HCV, the rate of transfer to mother to child, even in unknown or unprotected or untreated, is not very high. I can't remember the exact figures, maybe 3 out of 10 or something like that, so around 30%. So not all HCV mothers will transfer the virus to the child. Hence, it was given less importance. But I think in current practices, we should check for HIV, hepatitis B and HCV in all mothers, without a doubt, maybe syphilis and other infections. But without a doubt, they should be screened. There is no vaccine and there is no treatment available for hepatitis C in pregnancy. All the medicines that we use are not approved for use in pregnancy officially. I was reading up last night, there are a lot of case reports where mothers who have advanced liver disease, there's a concern that they will progress into liver failure. They have used the standard direct-acting antivirals like sofosbuvir, velpatasvir combination without any adverse events. And there are studies in rats which show no adverse events in fetus. But it's still not an official recommendation to use. So as of now, in HCV, there is no treatment for pregnancy.
So regarding vaccination, suppose if the husband is positive, anti-HB is AG positive, and the person is pregnant, are vaccines safe in pregnancy?
It is recommended. Actually, CDC says that all women who are negative should be tested for antibodies. If the antibody is low, they should be vaccinated. But I'm not sure if it is practiced universally, even in our country. So vaccination is safe in pregnancy. There are other bodies like the obstetrics and gynecology bodies which say that if the woman is in high risk category of getting a virus during pregnancy, then they can get vaccinated. But they haven't defined the high risk category. So I think if they are not having intercourse after pregnancy, there is no other needle exposure to the woman. Officially, you can give. CDC is recommending you can give, but in practice, we are not strongly advocating that. But vaccine is safe in pregnancy.
Thank you, sir. To sum up, the antenatal screening is a must because mother-to-child transmission is the most common. You have to do HPS-AG screening for all mothers. And then at 28 weeks, though the program does not recommend, at 28 weeks, you can start tenofovir even though it is a class B drug. Mode of delivery, it can be a vaginal delivery. You cut short the second stage of labor where the transmission occurs more. And then what happens for regarding breastfeeding, there is, as the HIV, there is no contraindication for breastfeeding, but certain situations where you have a cracked nipple or all those situations that transmission can be there. Except for that condition, I think breastfeeding is can be continued. And the patient already on tenofovir, we have to continue, because stopping, you are going to reactivate the disease and they may develop flare. So I think you should continue the treatment. And regarding hepatitis pregnancy, vaccination is safe, and you can vaccinate against hepatitis B. And regarding anti-HCV, I think the treatment should be only after the completion of pregnancy. Your input, sir.
The conference is not good. 28 weeks was standardized previously. Now they say even from 16 weeks, Chinese standards understanding say it's not prevent the 28 weeks, you have to go for 16 weeks. And cesarean section, sometimes you are making when the load is more than 2 crores, when the load is very high, the cesarean section is being advocated. And E antigen positivity is important for giving immunotherapy. Our country is poor country, the resources are poor. We can give birth dose vaccine, it's called birth dose vaccine. What about the immunoglobulin? Is it costly? So is it always E antigen positive there, or E antigen negative also you can give both immunoglobulin and the vaccine within 12 hours?
WHO is not recommending immunoglobulins in all patients. They are saying high-risk patients, which is, like you mentioned, DNA very high, more than 2 lakhs, and E antigen positive. But all the other, lot of the other bodies like obstetrician gynecology bodies are recommending immunoglobulins. Even our literature like EASL and ASL is recommending immunoglobulin. But if there is resource constraints and the risk is low, then you don't have to give. This vaccine should be enough. Sir has mentioned you can give. I think exceptional cases you can use, like we just talked about. If somebody is high risk, has advanced fibrosis, or you have viral load like 2 crores, you don't think they will come down sufficiently before delivery. Exceptional cases you can always use. As a rule, maybe not. A general rule. Correct, sir. So there is a WHO guideline who should be treated, which has expanded the indications quite a bit compared to EASL or other societies. So if they meet the criteria of the treatment, you continue. Supposing you are using it just to prevent transfer to the child, then you can choose to stop. But if they meet WHO guideline for treatment for adults, they should be given.
Thank you, sir. We'll move on to the next thing. That is a discussion on co-infection. Like we encounter HIV infection, co-infection of HIV with HBV, HPV and HCV, or even a triple infection we are seeing, HIV, HBV, HCV. All they have a common mode of transmission. So all possibilities and combinations are there. So if a person comes with co-infection with HIV, to discuss about this, I invite Professor Dr. C. Epen. He's a professor, head of Department of Hepatology, Christian Medical College, a renowned expert in viral hepatitis, liver disorder in pregnancy and chronic liver disease with 300 plus publications. He was awarded the ISG Young Clinician Award and the esteemed EASL Sheila Sherlock Fellowship for his excellence in clinical hepatology and research. He has also served as a medical superintendent of Christian Medical College, Vellore between 2012 and 2017. Sir. Yeah.
Thank you, Dr. Madar. I had a few slides on this topic, if I could put them on this topic of HIV and hepatitis B or C co-infection. So to me, this is the first two slides are probably the most informative, I think. Why is it that with the currently available very good drugs, we can cure hepatitis C, but we can only suppress HIV and hepatitis B? So it's like if we start treatment, we are going to give lifelong treatment for hepatitis B and HIV, while hepatitis C is, we know it's very good treatment in a short period, 3 months or 6 months, we can stop treatment. So the answer is from this slide. So the question is, where does the virus reside? So the hepatitis B and C virus resides, the home is the hepatocyte, while for HIV we can say the home is the lymphocyte. So the life cycle of the virus within this cell. So hepatitis B, the life cycle within the hepatocyte has got both a cytoplasmic component and a nuclear component, while hepatitis C has only a cytoplasmic component in the life cycle. There is no nuclear component, while HIV has got both a cytoplasmic and nuclear component. These drugs, these very potent drugs that we have, are all acting only on the cytoplasmic part of the life cycle. So that is why for hepatitis C, which resides only in the cytoplasm of the hepatocyte, the drugs can cure hepatitis C, while the nuclear part of the life cycle in hepatitis B and in HIV is not getting addressed by these drugs, and that's why we are only able to suppress it rather than cure it. Now, a few points about hepatitis B and HIV. It's a bit like Dr. Rivari said now. In HIV, it is actually a treat all. So anybody with hepatitis B, any syndrome which we categorize that into, we would treat, is what is advocated. And the commonly, the first line drug is tenofovir is what is considered. One of the concerns to keep in mind is some of the drugs are active against both hepatitis B and HIV. And for example, lamivudine, which earlier was the first oral drug for hepatitis B, is also active on HIV. But if we use lamivudine for HIV, the hepatitis B would turn drug resistant very soon. So that's a point to be aware of. So the ART regime along with tenofovir would be the preferred choice for HIV and hepatitis B infection. And as I said, the duration of treatment is lifelong for both these viruses for therapy. For hepatitis C, the newer drugs have much higher response rate compared to peg interferon and ribavirin. And it is, when we start therapy in a treatment naive patient with HIV and hepatitis C, should we start both the ART and the hepatitis C drugs simultaneously, or should we wait? So this particular reference states that they would wait. Initially they would treat HIV for 4 to 6 weeks, and then only they would start the hepatitis C therapy. And they suggest 2 reasons why. This is from uptodate.com. So one is that allows to assess the tolerability of ART, and 2 is by having a lower HIV viremia level, theoretically it's possible that the hepatitis C outcomes may improve. So these are the rationale mentioned for that. So when we use multiple antivirals, are there any problems? Are there any side effects we need to worry about? It turns out that there are not many side effects, that the problem really is about drug interaction rather than side effect. So what about the drug interaction? So these are the microsomal enzymes, the P-glycoprotein transporters, etc., which if there are drugs which induce them or suppress them, then that can alter the levels of the antiviral drugs. So that is the drug interaction is one thing one needs to be aware of, especially when it's choosing the ART regimes for in this scenario of HIV and hepatitis C co-infection. And so to summarize, for HIV and hepatitis C co-infection, the anti-HCV therapy for this co-infection is the same as what is used for a mono infection with only hepatitis C without HIV. But the caution is really one should be looking out for possible drug interaction between ART and anti-HCV drugs, and thereby the selection of the ART drugs needs to be thought out in that regard. Thank you.
Now, presently we see a lot of acute hepatitis. They come with bilirubin elevation and SGOT, SGPT, both B as well as C infection. Especially young adults with history of IV drug abuse, tattooing. It looks more like an acute viral hepatitis. In that condition, which do we treat first, sir?
So the person has got HIV and...
No, hepatitis B as well as C.
Okay, so B and C together. Not about HIV now. Yeah. So, let me clarify again. There's no HIV here. It's hepatitis B and C, and it's thought that both are acute.
Yes.
It's not so common a situation, I must say. It's not so common. We may find co-infection, but to say both came at the same time it's anyone's guess. Now, let's take it one by one. Suppose somebody has acute hepatitis B, should we treat or not? In a person who's immunocompetent. In an adult, the chances of clearing the virus is very high. 90 to 95% would clear the virus spontaneously. So there was a logic on not treating earlier. But if somebody has got severe acute hepatitis B, then antiviral drugs can be given. This is the ESL recommendation. And they define severe as bilirubin more than 5 milligrams. So when you think it through, that doesn't sound very severe. Bilirubin more than 5 is like normal, but that is what the recommendation is. So we can give anti-hepatitis B medicines for hepatitis B virus in that scenario. So by that logic, tenofovir, for example, can be given. For acute hepatitis C, the risk of chronicity is higher compared to acute hepatitis B. It's like 2/3 of people would go on to chronicity. So thereby, should we then treat acute hepatitis B with the direct acting antivirals? In the interferon era, because the drugs were having more side effects, etc., people tended to wait and not treat acute hepatitis C. Nowadays, these drugs are very smooth to use. It's only the cost factor, really. So people are more inclined to take antiviral therapy for acute hepatitis C. So once you consider them separately, now if you say in the theoretical patient having two acute illness together, it's possible to take both drugs together. Only concern, as I said, is about drug interactions, but I don't think it applies for the anti-hepatitis B and hepatitis C drugs, but I've never encountered such a patient. So it's theoretical.
Dr. Eapen, in a chronic setting, it's known that if you treat C and as the viral decline happens, there can be a flare of hepatitis B, and there is some suggestion that you cover with prophylactic antiviral, because generally in C you see one of the two active, you don't see both active together, but if C is active and DNA is very low, should we universally give prophylaxis and treat the C, or treat the C, wait for a flare and then treat the B?
Thank you. So I know that there is literature around that one of the drugs can become more dominant or more active, but I believe that a lot of that was from the interferon era. So now that we have got these smooth drugs to use, I suspect we will not be encountering that as much, and I would treat both is what I would do. Why should I? Because there's easy drugs to give, unless there's some particular contraindication. That's what
What I meant was if DNA is very low, like say 40, 50, but C is there, you're treating C, there is an anticipated flare of DNA because of the C treatment, which has been reported, and I'm not sure if the guidelines have said, they said it can be given, but it's not clear whether we should for all patients.
So I would give antiviral hepatitis B only if it meets the indications for therapy. So you're saying if there was no indication, should you give? I think not, but it's an uncertain territory. I'm also not sure here.
Any inputs from him, Madam?
In case of drug resistance, the patient has leukemia and the patient resistance develops. So in case of resistance of drugs, the lamivudine, people can develop resistance. You combine with another drug or you switch over to another drug. Which is more effective? A combination of treatment, combined treatment is possible.
Thank you. So hepatitis B drug resistance is an issue, and as I was just mentioning, it is a lifelong therapy. So it'll be amazing if somebody can take the medicine every day. Like even a small fever, course of antibiotics, we may not take the treatment for even for 7 days, we stop it. So people take lifelong, so it's a problem. So the setting of having a hepatitis B drug resistant in a patient is a person who's non-compliant. So I must say, I have had an opportunity to look after maybe 5 to 10 such patients over my career. So it's not a common situation that we see, but if somebody says, I took the medicine for 6 months, then I stopped it, then I took it, then I stopped. So that such a person is prone for drug resistance. And in such a patient, when the viral levels are now very high, let us say it's 1 crore, the DNA level, and the setting was a non-compliant patient, what to do? So how can I prove drug resistance? So to prove it, really one has to look for the mutations, which are the drug-resistant mutants. Earlier, the lab at CMC would provide the drug-resistant mutants as part of our PhD research topic, but nowadays that's not done. So it is more, this is how I make the diagnosis. The non-compliant patient, and now the level has gone up, what was low earlier. So that's drug resistance. So there, I would give a combination of 2 drugs. I would give entecavir at double the dose. So 1 milligram once a day, as well as tenofovir. Then I wait till the levels become nil. That may take 1 year's time or 2 years' time. And then I start reducing 1 drug at a time. And all these 5 or 10 patients have done well like that. I've seen that to happen. So that's what I have been doing. But it's an expensive affair. 1 mg of entecavir plus tenofovir in a private setup is an expensive patient.
I think this is the simplest way of explaining why you can't. Simplest way of explaining why can't you cure B and HIV. The only point is you mentioned about drug-drug interaction with HIV and CV. Good point is how the national program, the AIDS program, is using dolutegravir, which doesn't have drug-drug interaction. That is a good point. And for us, is today's inhibitor is used only acceptance of patients. That's what you do. Thank you.
Thank you.
From TLD transition this year. From TLE to TLD, dolutegravir is 50, 300 for tenofovir, 300 for lamine. That's for 2018 is valid. So that's the ideal for HIV.
We'll move on to the next panel discussion will be on treatment failure, which is indeed very frustrating when we have treatment failure, especially for hepatitis C patients. To deliver this talk, I call upon Dr. Hemamala Ilango. She's a lead hepatologist and liver transplant physician from Coimbatore. She's a highly trained hepatologist with advanced fellowship in transplant hepatology and founder of the Liver World Clinic. She's an expert in ACLF, viral and autoimmune hepatitis, NASH, GI bleeding, Wilson's disease, and liver cancer. I invite Dr. Hemamala to throw some light on the treatment failure.
So thank you. So Epan sir and Murugan sir said, hepatitis B and HIV we have to give lifelong. So we all know the success story of hepatitis C. So 95, like Shafiq said, 96 to 99% SVR rates. 3 months, the virus gets cleared. So it's very easy to deliver from a national health perspective or a public health perspective. It's very easy to deliver. But but we do come across treatment failures. So for that, I'll skip all these things. Just the drugs, the 3 groups of drugs. Most of the, from the this National Viral Hepatitis Program, they will have either the Dacla, Ledipasvir or Elpatasvir along with Sofosbuvir. The Previrs, it's still not available here, except as I think as part of a compassionate program, it is not still available here. So we need to know this because this is one drug which will be used in treatment failures. So the efficacy, so 97 to 99% if they don't have cirrhosis. But if they have genotype 3 or if they have cirrhosis, then it drops down. If it is decompensated, it's even more drops down. So when we come to the point of elimination of hepatitis C, it is first we need to identify this group of high risk group of patients for whom the routine 3-month or routine 12 weeks treatments may not be enough. So upfront, they may have to be given for either at 24 weeks along with ribavirin. So when we say treatment failures, so we need to know whether it is a relapse. That means patient, we all know that SVR12, after 12 weeks of drug therapy, HCV RNA is negative. That means whether it is relapse or it is a reinfection. So both are different. So like as I was discussing Malar, in patients who are using IV drugs or in somebody coming from a dialysis units, it can be a reinfection. Whereas true drug failures is different. So how do we differentiate both? If the patient is definitely, if you have a documented SVR, and if we have a document of a genotype before starting treatment, if it is a different genotype, then we know that it is probably a reinfection. Then the treatment will be as per how you will treat a treatment naive patient. But if we have not documented SVR, then it will be very difficult to differentiate. Why do we have failed therapy? So most important here is the poor compliance. I will tell about the Punjab data where they have more than 50,000 patients as studies. Genotype 3 and cirrhosis, these patients are very difficult to treat. I will skip all these things. So how do we treat these DAA failures? One, either we add another group, especially the Previs, we add ribavirin, or we extend the duration of treatment from 12 weeks to 24 weeks. So the pre-treatment counseling about the importance of completing the treatment. So if somebody comes with IV drug users, if they come, we treat within 4 weeks, they start feeling well, but they should not stop treatment, and that 12 weeks should be completed. That counseling is very important from the beginning of the treatment itself. So if you look at the treatment guidelines, it's very, very simple. We don't even have to give a talk. It's very simple. Somebody has failed sofosbuvir treatment, you have to give this combination, sofosbuvir, velpatasar, voxelopravir for 12 weeks. If it is genotype 3 or composite cirrhosis, then you add ribavirin. It's very simple. So there's nothing much to debate about this. This has been there for last 4 or 5 years. But unfortunately, this combination is not freely available. I have had one patient with cirrhosis who did not achieve SVR after 24 weeks. So then I said, this is the only drug option. So they went to US, they got the medicine and they got treated. But in central institutes like ILBS or in Chandigarh, they are able to get this at a compassionate program and they can achieve treatment. What is our Indian data on this? So how do they manage the treatment failures? So 3 studies I have got. So one is the 3-drug combination. So this is from Lucknow. So SVR, so patients who have had failed DA therapy and they are difficult to treat. That means they have cirrhosis and they also have genotype 3. SVR was achieved in 100%. So if you have this drug, this is the best combination. What if you do not have this? Can we use these drugs again, same drugs again? So here, this is again from Lucknow. So 12 patients who had relapsed with prior treatment. 7 of them had cirrhosis and all of them were genotype 3, which is more difficult to treat. And they were treated with SOF, Velpa and ribavirin for 24 weeks. If they had previously received Velpa, then they were given daclatasvir. So with this, 75%, all of them cleared at end of treatment, but only 75% achieved SVR12. That means still it is a good response. And all 3 of them had cirrhosis. And out of these 3 also, one person was treated with the same regime, another person was given the 3-drug regime, and they were able to achieve SVR. That means there is still hope. You can try, if you do not have the 3-drug combination, we can give SOF, velpatasvir along with ribavirin for 24 weeks. We can still achieve 75 to 80% of SVR. Now the question here is, I think Malar was telling that if we have failure, they are being asked to send for resistance, RAST. So, but it is not freely available. Probably in central institutes it could be available. So should this be tested before initiating therapy? So if you look at American guidelines, they say for genotype 3, especially if they have cirrhosis, before starting even SOF, Velpa, you do the RAS studies. But it is not possible. So this is the study published this month. this not only looked at whether the RAS is useful, but it also looks at predictors of treatment failure. This is a large group of patients from the Punjab hub and spoke model, more than 50,000 patients who have been treated for hepatitis C, and there the cure rate was 90%. So this is a mix of, they had treatment failure, patients who were not compliant, patients who had cirrhosis. In that they could achieve 90% of success rate. And advanced age, cirrhosis, and compliance is a very significant factor. So those who got SVR, they are 95% compliance. 89%, I thought, what is this? 95 and 89, is it a big difference? But even that small difference in the compliance, for individual patient is different, but when it comes to a public health perspective, especially if you are expecting to eliminate or control, this is very significant. So compliance is very important. And the retreatment in this, around 640 patients, retreatment was provided with soft, Velpa and ribavirin. And in that, the success rate was 93 or 95%. With those with cirrhosis, it was slightly less, 90%. And those who failed the second therapy also, they got the 3-drug combination, 100% cure rate. So it's still curable in majority of patients. What about RAS? So they had sent these samples from around 240 patients. It could not be done in majority of the patients for 2 reasons. Because even though the viral load is detectable, but it is not high enough to detect the genotype or the mutations. So in in a group of patients, it's not possible even if we send. Second, 31 mutations were detected. So what they said was, Velpatasvir resistance, the Y93K, was found in a small subgroup of patients. The main conclusion of this study is that it may not be useful in a public health perspective. In whom can we use it? Maybe, probably those who had failed the second time also, maybe we can use, because then we can order the Voxlopravir regime.
I think it was a very lucid and very good explanation, madam. And coming to this conclusion, I think you have to, in the community setting, you have to see whether the patient is compliant with the drug. And also don't, relapse is not a problem. I think the reinfection will be a problem, and we can once again start the same treatment where she has shown evidence-based there is some amount of cure rate. Okay. So with this we come to the end of the session, and thank you one and all for this participation.
Thank you so much to our moderator and panelists. I request Dr. Archana Ramalingam to please join us on stage to do the honors and felicitate our panelists and moderator. Thank you so much. Let's give all of our panelists, our moderator, a big round of applause for a wonderful session. Before we move on to our next panel, ladies and gentlemen, I'd like to say that we are pleased to introduce Learn Hepatitis, a free self-paced comprehensive learning management system developed in collaboration with ICMR, National Institute of Epidemiology. Learn Hepatitis is India's first dedicated e-learning course on viral hepatitis, developed to enhance awareness and clinical competence among healthcare professionals. This course has been officially recognized by the Director of Public Health, Tamil Nadu, and was inaugurated by our Honorable Health Minister, Mr. Mas Subramanian. We have the details for you on the screen, and you would have also received it in the file. All of the details are there as well. So please check out learn.hepat.app for all of the information. Thank you so much. We'll now move on to our next panel discussion. This one will be moderated by Dr. B.V. Ruwari. So, sir, can we please have you on stage? We'd like to welcome our panelists on stage, starting with Dr. M. Janaki Ram. Can we have you on stage, please? I'd also like to welcome Dr. Subhash, Dr. Malayappan, and Dr. Nallamai. Can we give them a round of applause as they make their way to the stage? Welcome. Over to you, Dr. Ruwari.
Thank you, Dr. Vivek, for organizing this important session, because since morning we have been talking that we are here for a common goal, which is the ambitious goal of elimination of viral hepatitis. We know that we have the diagnostics, we have the drugs, treatment modalities are very clearly defined, we have a national program, but we still know that only less than 15 to 20% of people know their diagnosis and are linked to care. We have got drugs which cost as low as $45 for a cure, hepatitis C, and less than $30 for hepatitis B for a year. Still, we are far away, and we just have 5 years to. So where is the catch? Catch is basing to reaching out to those millions who are missing, basically finding out who are the missing, who are infected, and basically how do we link them to care. That is the catch that we really need. We know that the traditional healthcare setting, conventional approaches, hepatitis program alone cannot reach out to everyone. There are people who are high-risk groups, people who have got mental health issues, and then we have got people needing blood transfusion, those with comorbidities. Basically, they are often the last to visit a conventional health setting, and they are the first, basically, one who should receive the attention. So this session basically is on moving beyond the traditional healthcare setting, beyond the traditional thinking, and developing intersectoral collaborations with others, and get your views, basically, how do we reach out to these people. So my first question is basically to Dr. Janaki Ram, who is Senior Assistant Professor, Stanley Medical College, and he has led multiple state-level surveillance programs, including the COVID-19, HIV sentinel surveillance, and viral hepatitis. Deputy Director 10SACS for targeted intervention. So you are the best person to answer this question, basically. And my question to you is basically, how do we reach out to these patients, get them into care, and retain them in care? Over to you.
Thank you, sir. First of all, I thank the organizers for providing this opportunity. Before going to this topic proper, I just want to highlight few things regarding the program per se. Like there are two kind of programs in which hepatitis has been addressed. One is that one is a central sector program, which is the classical example is NACO, and another one is centrally sponsored program. All the data in the morning presentation, Dr. Ruwari has presented an extensive prevalence kind of data. All those data were all guiding tool, and they were obtained from NACO through its strengthened surveillance system. Whereas hepatitis per se doesn't have a robust data which is available even at the central level as well as at the state level. So it is still at the infantile state. So we have to run a long way to reach that level. Actually, regarding hepatitis, they are borrowing or leveraging the services from NACO. So I would like to categorize the high-risk groups as well as and other closed settings in which NACO is consistently working and developing an intersectoral coordination among various sectors. In India, like HIV, hepatitis is a concentrated epidemic where the prevalence is lesser than 1% in case of a general population, whereas it is comparatively higher among the high-risk groups as well as the prisoners. So, in those circumstances, we have to develop certain specific strategies to address the high-risk groups, especially the role of civil society organizations is very, very important. And there is no separate public health component which is available under National Viral Hepatitis Control Program, since it is under the bigger umbrella of NHM. So, all the clinicians, still now, what we are doing is, there is no passive screening at all. In HIV, usually there will be an client-initiated one, and there will be a separate thing called as provider-initiated one. Whereas still now hepatitis, we don't have a passive screening. So far, the data we are having were obtained only through active screening. So, involving civil society organizations and bringing larger number of networks, whether it will be very helpful in for the treatment aspect as well as screening aspect. As well as among the high-risk groups, there is always vaccine hesitancy is there, and it is difficult to screen the individuals or sensitize the individuals, especially for hepatitis B and C. The behavioral changes which has to be addressed among the high-risk groups separately in concurrence with the, it should not be handled in line with the HIV, so that we can actively screen large number of cases, and as well as in the closed settings. For example, I would like to correlate the data with the state of Tamil Nadu. In Tamil Nadu, we are having around 147 prisons, and among them, among the 147 prisons, around 128 prisons we are having prisoners, and we are having only 12 central prisons. Rest of them are district or sub jails. So for central prisons we are having an default settings were there to screen separately for hepatitis B and C, whereas in case of district and sub jails, it is always we have to map it with the nearest health facility where can screen the individuals on a fortnight basis. And we have to vaccinate the individuals in which we have observed, we have found hepatitis B negative. So this is a larger area which we have to concentrate and address by creating an intersectoral coordination with other departments. So the clinician should also create some peer group networks as well as peer group mobilizers to track the cases. Then only it will help us to proceed further.
Thank you, Dr. Janaki Raman. We know that viral hepatitis control program design itself says that there should be a close coordination, convergence with the targeted intervention program run by NACO, because these programs are not only for positive people, they are for the high-risk group. But also we need to address a lot of issues like stigma. There is a stigma related to HIV, there is stigma related to hepatitis B also that need to be addressed. So just going beyond high-risk groups, we call 4 conventional high-risk groups, which include sex worker, MSM, people who inject drugs, transgender, and also migrant and their partners. But we also need to think some of the medical high-risk groups where we should also focus on, and those include patients on hemodialysis, basically hemophilics, those with abnormal LFT, those kind of people, they are not traditional high-risk group, but these are the people where should also we have more screening. As we saw, 50% of the patient in the morning, it was shown that they are coming to hospital, have no signs or symptom, but they are presenting to hospital. So I will say we need to broaden the high-risk group in context of hepatitis. Since we have time restriction, we'll move on to the next speaker. We have 4 minutes for each of the speaker. We know that Supreme Court has mandated screening of all blood samples for 5 bloodborne infections, and that is the best way to screen. But my question is, beyond mandatory screening, which is a rule, what mechanism is needed to ensure that 100% those who are detected are flagged, counseled, and linked to care? Because once they are diagnosed, their blood samples are discarded. But what is the mechanism that we don't lose them, basically? So over to you.
So,
and Dr. Subhash.
The blood
Basically,
donation,
no,
there is...
I'll introduce you.
Myself, Dr. Subhash.
He's Professor and Head of Department of Transfusion Medicine at Madras Medical College. And you oversee statewide blood safety initiatives, lead blood donation awareness, and actively address public misconceptions. Over to you.
Thank you, sir. So, regarding your question, beyond mandatory screening, so here itself there is a lacuna. My mandatory screening is 3rd generation or 4th generation ELISA. But if the donor donates and if I call him back, he will goes to a nearby thing and say he will do a CAR test and say I am negative. So there itself the question remains inconclusive. So beyond the mandatory screening, what are the things to be done? There are 3 pillars: the technology, the SOP, and the accountability. Regarding the technology, the blood bank HMS should be updated with the viral hepatitis treatment center. So there should be a real-time notification when the donor donates blood. So the SOP is the dedicated counselor should be there at the treatment center. When this real-time notification comes, the counselor should immediately call them, make them, counsel them, and bring the donor to the treatment center and to treat, to investigate further and to treat. Then the accountability, track the progress and ensure completion. So he should be tracked from the blood bank and he should get the treatment, and after completing the treatment, this should be come to the real-time basis for us to view. So if these 3 things are linked, then beyond mandatory screening we can catch it. Regarding our center, we are having 0.4% of hepatitis B. So mine is around, we are collecting 30,000 blood units per year. So around 440 or 450 hepatitis B positive. We were able to link only 250 to 300. Rest, the phone is switched off. They say, I have done the test. I am negative. Why should I come there? So there are some gaps. And now we are trying to focus to improve this, and little bit we have come to around 80%, sir. Thank you.
I don't know the pre-donation screening, how effective is that? How rigorous is that? That is also very important.
Pre-donation screening means counseling, sir.
The screening of the donor, basically.
Screening of the donor, we do 4th generation or 3rd generation ELISA test, sir.
The questionnaire we use for
questionnaire,
selection,
questionnaire is there, sir.
How rigorously it is implemented, that is also important.
The thing is that around 1.1 to 0.2% of the positive case, if you call, they say, I am on treatment, or I know I am hepatitis B positive, I came, whether it has been vanished from my blood. So these questions are coming. So they are hiding everything and coming, sir.
So in this regard, I feel that the tracker mechanism needs to be put in place. You have been able to track more than 50%, but there needs to be a system of kind of, I will say, unique identifier code whereby you can treat them, and those who are positive, they can be linked to further testing, confirmation, and treatment.
Yes, sir. Thank you.
Thank you. We will have question answer at the end. So we move on to the 3rd speaker, Dr. Malaniappan. Dr. Malaniappan is Director of Institute of Mental Health with over 25 years of clinical expertise, advocates mental health awareness, and you lead an integrated psychiatric care and rehabilitation community reintegration program. That's great to know. Dr. Malaniappan, we know that mental health issues are a significant barrier to hepatitis treatment adherence. And that particularly among people who inject drugs. That is seen from HIV program also, which is a lifelong treatment. So my question is, what key challenges are faced by hepatitis positive patient and how taking care of their mental health issues will basically help their retention from a intersectoral collaboration perspective. And how can we institutionalize this process?
Thank you, sir. I thank the organizers for giving me this opportunity. Psychiatric comorbidity is one of important issue for those who are positive for viral hepatitis. So they can have depressive disorder, they can have anxiety disorders, they can have adjustment disorders, they can have normal stigma-related stress. They can have fear of infectivity. I may be infecting my daughter or my mother or my wife. Fear of infectivity, and they can also slowly they can develop guilt feelings. I am responsible for the infection which I have caused to my friend. So they can have fear of guilt feelings, and these normal emotions can progress to depression, and this depression can lead on to suicidal ideas also. So stress, depression, suicidal thoughts, and completed suicides also can happen. These are all the psychiatric comorbidities in viral hepatitis, well reported. And also, certain substance use disorders also make the person prone for viral infections. For example, alcohol dependence is an important factor in the progression of the viral hepatitis. So, not only alcohol dependence, when there is injecting drug user, there is a risk factor for hepatitis infection. So, the substance use, psychiatric comorbidity, these things have to be screened in a center which screens for hepatitis. When the individual is positive for hepatitis, he must be screened regularly for a psychiatric comorbidity and substance use. That has to be integrated into the health program itself. Screening for psychiatric comorbidity and substance use disorders, because when the individual is depressed, he will not have the hope or he will not have the desire to live long or to take care of himself. So that will interfere with the adherence to treatment. He may be having myths like, I will be lifelong infective, there is no cure for this. So these myths has to be addressed. These psychiatric comorbidity has to be detected, and intervention has to be done. When the psychiatric comorbidity is mild, the healthcare provider who is providing the screening, who is doing the test for hepatitis, itself can provide brief psychiatric interventions like support, reassurance, counseling. Even psychiatric medications can be given by the healthcare provider who is responsible for the hepatitis screening and testing. So it should start from the screening, and brief interventions has to start from the center itself. So once the screening questionnaires can also be used. Commonly used questionnaire is patient health questionnaire 9 version, which has 9 questions, which is very easy to administer, very easy to score, and identify cases of depression, anxiety, suicidal ideas, alcohol use disorder. So such screening questionnaires can be integrated to the National Viral Hepatitis Control Program itself. That will lead to improvement in the treatment adherence. We should be in the counseling, we should be able to address the stigma. Stigma is there in the society. When I am told that I am positive for hepatitis B or hepatitis C, my family even may not accept me. So there is a chance that I may be looked down upon even by my own spouse or my own father and mother. So it is there, it is a reality, it has to be addressed. So stigma and discrimination has to be addressed in the brief counseling by the testing agency itself. We can only when the psychiatric comorbidity becomes moderate or severe, then such individuals has to be referred to the mental health professionals. Primary screening and primary intervention for psychiatric comorbidity and distress and addressing the stigma has to be done by the staff who is responsible for screening and testing hepatitis infection. Further necessary treatment can be provided by the mental health team. So, universally, a short training program for all the health staff to screen for psychiatric comorbidity should be done throughout the country, and that will improve the outcome of the program. If we are not going to address the psychiatric comorbidity, substance use, behavioral changes, even small motivational interviewing techniques can improve adherence to treatment, can take off the discrimination, can take off the stigma-related stress, and improve the treatment adherence, improve the outcome, improve the quality of life for the client. So, integrating mental health care with the National Viral Hepatitis Control Program is a need, and also it will improve the overall outcome of the program. Thank you.
So I think that was a very important suggestion basically on the screening tool and the questionnaire 9 that you mentioned, because a few months back there was a consultation of National AIDS Control Organization with the NCD program, in which also it came that there should be similar questionnaire adopted for, but you can't have separate programs. So I think it is better to have sensitization of people who are in the viral hepatitis control program, as you rightly said, but for a larger issue we need to collaborate and discuss with the national NCD program also, because there is a national mental health program also.
NMHP is there.
So issue basically here is not only convergence but coordination also. We can't have every people trained separately on different diseases. So a coordination with the NCD program on particularly those cases where the screening is positive and their referral and linkage would be important. Thank you.
So primary health care, all the primary health care workers in the country and the secondary level health care workers, that may be any field of medicine, any hospital, any healthcare professional should have a basic skills to screen for mental health problems. That is lacking in the country now. Not only for hepatitis, but in any program, unless we address the mental health issues, the success will not be very robust, I would say, because mind is there in every human being, and mental distress is there, mental comorbidity will be there. So screening for mental health problem should not be equated with as a different speciality or a different disorder. Every doctor, every nurse, every healthcare provider should have a basic training to screen for psychiatric distress and illnesses, so that he can identify, give a brief intervention, treatment also, and refer appropriately and improve the outcome. That is my humble suggestion, sir. Thank you.
No, you're right, but that becomes a great wishful thinking also. But yes, programs like this offer us an opportunity to begin somewhere.
Yes.
Maybe HIV program, hepatitis program, integration with them. We begin somewhere and then naturally we need to expand.
Thank you.
Yeah.
Actually, counseling services are available only in 2 programs. One is at National Mental Health Program, another at HIV. We don't have a counseling services exclusively available. That is a need of the hour actually. And regarding the stigma and discrimination component, HIV is having a separate act, HIV Prevention and Control Act 2017. I'll take this opportunity for the civil society organizations and the representatives, especially Dr. Vivek, to create a platform where it has to be addressed in the perspective of legal epidemiology, so that how PCPNDT Act reduces female infanticide across the years, so that we can address the stigma and discrimination related to HIV. It can be addressed through a legal perspective.
Absolutely, that is a need, but we don't have a very strong community presence in hepatitis program like we had in HIV program. That led to basically development as HIV AIDS Act. But just for the information, from ILBS, we actually have got a bill introduced through some of the member of parliament. A bill has been introduced to address stigma. It is pending now almost for 2 years. It's a MP from the West Bengal. I think we have been following it up, but there is a bill already pending in the parliament. So move on to the last session, basically in another closed setting. We have Dr. Nalammi, who is Assistant Surgeon Prisons. Thank you for being here, because this is a very, very gray area and difficult area of intervention. That I said in the morning, despite being in closed setting and prison, the incidence is much higher. They have availability to drugs also, they have got availability to other high-risk behaviors. So how can basically we make their behavior safe? That is first thing. That is first part. And then basically screen those who are at the risk and link them to the care, because it is a big challenge. When I started my HIV program, I used to get patients from prison to my hospital with 3 people coming in, policemen coming with them. But that has changed over the years. Now there are services in jail.
Till now,
but post-release again. So I would like to ask you, how can we further strengthen this, and how can we work with the district health administration also, so that there is a continuum of care? Over to you.
Sir, actually for every prisoner, not only high risk, for all prisoners, those who are arrested, we are doing hepatitis B, hepatitis C and HIV card test we are doing, sir. We have ICTC personnel for the same. But the thing is, the main problem we are facing is they are hesitant to come for blood investigation, sir. What they think is, once something comes out, turns out positive, as we say, as sir said, family members are not accepting. Within the prison, they find it as a closed environment. So if somebody comes to know, so they don't turn out for blood investigation. That happens. But nowadays we are counseling them. We have counselors. We advise everyone to undergo blood testing. The thing is, awareness camp can be conducted for the prisoners regarding both HIV, because for immunodeficient individuals, what we do is we provide special diet. Once they receive the special diet, everyone in the prison gets to know that these people are having some disease. So they don't want to reveal that identity. We are making arrangements to call them separately for lunch, like that, something we are doing. Prison authorities, they are doing. So some sort of awareness, because many are like, what to say, 50-50 we can keep. Educated are also there, uneducated are there, no? So they need awareness, both for HIV and hepatitis B. Then once they are turning out positive, we refer them to Stanley Medical College, that is our referral center. Further treatment and follow-up we are doing, sir. Like maybe monthly one turnout to be positive for hepatitis B, because high risk people are there, IV drug abuse people are there, and transgender also we are having.
Do you think the prison medical officer has enough capacity to treat these people, or that capacity needs to be built so that they don't have to come back?
Sir, medicines and all they need there. Then for that DNA testing and all, we should send them to
in continuation of the treatment, maybe.
Continuation, we are continuing, sir. If we had one prisoner, they will provide monthly drugs and we follow them up. We send them for repeat DNA loading, like that we can do.
So is there a mechanism that when a person is released from jail, that he continues his treatment? He may be not from the same, and this may not be from Chennai, maybe from another district. So what is the mechanism? We need to establish that mechanism.
Sir, like for HIV, we have the ICTC personnel. They are doing follow-up, sir. The same way hepatitis B can be done, sir.
Thank you. So the session is open from questions from the audience, comments. It may be a convention. Any feedback you have on these issues? Anyone, doctor?
Yes. Escorts. So they have to undergo other liver panel test and ultrasound abdomen. For that, they have to come to the facility. So there is difficulty in mobilization. But what the government of India says is, the blood sample is enough. You need to transport the patient. You can transport the blood sample, and the treatment under the jail medical officer supervision, the treatment can be given. That is what the government of India says. And number two is, as there are categories of people like who are prisoners and who are not prisoners, just they will be retained for some reason. Those people are also there. And people who are detained from the prisons, there is a follow-up. As you said, for HIV, there are NGOs. For this program, we do not have any volunteers for follow-up. This is the reality. And our medical officers are facing a real big problem, especially in Vellore and Coimbatore prisons. They are really facing a lot of problems in getting the prison. And we have a part of the high-risk screening. We have prisoner screening every month. They have to do once in 3 months. They do a prison screening. And there are certain cultural practices, sir, like tattooing and all there in prison, that also will also increase the infectivity, like the transmission.
Thank you for that update.
So one more issue which has to be addressed inside the prisons is overcrowding. Because we used to see overcrowding may be a chance that the rate of infection is getting higher in case of droplet infections, whereas in case of HIV, hepatitis B and C, there will be a lot of behavioral changes if there is overcrowding in a closed setting. That too, usually in the central prisons, there will be, it will be like blocks. In a central prison, there will be around 8 to 12 blocks will be there. So it is not about the total number of inmates in a particular prison exceeds a particular number, but it, in a single block itself it exceeds. It will be more in a single block, and while adding up, while summing up all the blocks, it may be less. So in a single block, it will be a overcrowding. So it may lead to some behavioral changes, and ultimately it may end up in an infection. So it is an issue which has to be addressed from the socio-ecological theoretical aspect. We have to concentrate on this thing through some. So we can address these kind of issues through involving a lot of civil society organizations and volunteers.
Thank you. Yeah.
You can use the mic.
Mandatory that they have to, pass the test from the doctor before they are being released from the prison. So they have to, seek clearance from the doctor. So when they go to take clearance from the doctor, we get to know that the person is HIV, HCV or HBV infected. So, and there is a provision on the national portal that you can transfer that case to that particular district wherever that person is belongs to. So, and we had a contact with the district nodal officer of that particular district also. So we tried to, write letters from the prison. So that becomes easy, and we can link them for further treatment. And for especially for hepatitis C care, because the duration is less, so we used to hand over the medicines to them in case, they are left for like 1 month dose or half a 15 days dose. So we used to hand them over so that there is no gap. So we should ensure adherence. And on a lighter note, sir, I want to share another thing from Punjab. So there was a reverse kind of stigma as we talked about HIV. So the prisons used to be very big, like 3,000 to 4,000 people, and with 600 to 700 HIV positive people, hepatitis positive people in the prison, with a lot of co-infection also. And 2 of the clients, they came, the prison inmates came, and they said, I said, you guys are not positive. Why you are here in this particular barrack? Because for the ease of tracking them, we, allocated few barracks for them. Because it was very mammoth task, to find out people from 3,000. It's almost like a small village. So 2 of them, they were there because they were getting the food, the additional, nutritional these items, because they need some extra proteins. So just because for the sake of getting some extra proteins and eggs, they said we are HIV positive and we want to be here along with our friends. Thank you.
Well, that was a different thing, but thanks for sharing that best practice of linkage basically. Yes.
Like Professor Dr. Malavari Madam mentioned, that unlike your HIV and the community-based organizations, we do not have for this hepatitis B or C, that is hepatitis B. I think the TANZACS in the current context is definitely looking at various extended profile of diseases. I'm sure compared to what we were earlier, the HIV prevalence was high, we had a lot of issues. But right now we look at the HIV-TB comorbidity. Similarly, there are a lot of community-based organizations working under the empanel under the TANZACS. And similarly, blood bank, you got empanel lot of organizations which support the blood donations. I think instead of finding new ways of doing, the TANSACS is in a better position to take care of the high-risk groups, because the high-risk groups from where we get the disease. So it became so disease-specific that TANSACS works for HIV, that many times we have to think that we are addressing the community and the high-risk behavior. So in the high-risk behavior may contribute to HIV, or it may contribute to hepatitis, or it may contribute to other problems. So is there a revised thinking and strategy in TANSACS so that our program need not, like our viral hepatitis control program, need not unnecessarily look for more places to coordinate? So why not we strongly say that the current coordination between TANSACS and NVHCP is good enough to address the problem? Why we have not reached that kind of coordination? Because that's what we are also lacking in, at the NHM or Tamil Nadu also. We are thinking that we should have much more better than what it is.
Fully support you. Basically, there is no point in duplicating the efforts. Basically, when we have a community-based organization supported by NACO, there is no point in duplicating similar thing for viral hepatitis. So it is a question of the coordination. The guideline at the central level are very clear. Viral hepatitis control program guidelines, if you go through it, very clearly says piggyback on the viral and the AIDS control program. TI interventions are high-risk groups. So at the state level, basically, this has to be coordination between the NHM and the program. And many states, it's a common project director and NHM MD are common also. Where they are common, it is better integrated. But I think that is a point you have well made. Thank you.
Dr. Janagiraman wants to say something.
I think we are short of time. I'm getting signals from them. So we'd like to conclude this very important session with few takeaways. The panel thinks that the screening should be used as an integral part of service delivery in settings like prisons, mental health institutions, harm reduction centers, coordinating with the existing programs. The point of linkage and loss to follow-up in linkage is very important, and that needs to be addressed. Ignoring mental health comorbidities basically undermines the treatment success, and we really need to implement that score in these sites. And obviously, as you said, across the country we need to have that. I also feel that we should have a reciprocal screening and treatment mandate for people who are accessing mental health program and vice versa. And also basically we should have a clear mandatory verifiable notification for all HIV and hepatitis positive blood donors with a tracking system. So that this 100% tracking, this is a catchable, very low hanging fruit in a sense that we can reach out to them immediately. And also formalize a handover protocol, more systematized handover protocol for treatment during the prison and after this thing. So the overarching principle is that intersectoral collaboration basically requires convergence, coordination and integration all in different ways as you need. So with that, I think we'll come to end of this session. Thank you.
Thank you so much, Dr. Rivari and all of our panelists. Calling upon Dr. Gerard Maria Selvam to please do the honors and present our panelists and our moderator with a token of our appreciation. If you would please, sir. Yes, let's have a big round of applause for all of our panelists and of course our moderator, Dr. Rivari, for a very, very insightful and interesting session. Thank you so much. So ladies and gentlemen, up next we have a very, very interesting session with our speaker who is tuning in online all the way from the UK in London. Our next topic is community and patient empowerment in hepatitis prevention. I'm very honored to introduce Mr. Carey James, Chief Executive of the World Hepatitis Alliance. He leads the WHA, driving global advocacy for viral hepatitis elimination by 2030. He's had a distinguished career in community-led public health, advancing key populations' health and HIV movement. Mr. Carey James couldn't be here with us in person, but we're so excited that he could join us online. Carey, welcome, and over to you.
Thank you so much, and it's such an honor to be here. I'm so sorry I can't be there in person, but I was lucky enough to be there earlier in the year. See if my slides will move here for the Indian Hepatitis Summit that was there in Chennai at the beginning of the year, and it was a great honor to be at such a fantastic event. And I'd just like to thank the organizers of that event, and of course this one, Dr. Vivek and Dr. Shamugam, for this opportunity and for the leadership that they're showing in the region and nationally as well as globally. In case you're not familiar with the World Hepatitis Alliance, we're a network of community and civil society organizations in almost 130 countries. We think it'll be 130 by the end of the year, all working towards hepatitis elimination. And in India, we have 17 members, including the Chennai Liver Foundation, which you can see there. We also have members in West Bengal, Punjab, all around the country really. And not only do we engage with civil society in India, but also with healthcare. You can see on the bottom there some pictures, one from the Savida Hospital in Chennai this last World Hepatitis Day, and the other one from a women's teaching college in Hyderabad. So we're very proud of our partnerships in India, and that's why we're also so proud to be here today. And our mission as World Hepatitis Alliance is to harness people living with viral hepatitis to achieve its elimination. So community and people with lived experience are really at the heart of everything that we do. And speaking about prevention specifically, WHA's new strategy looks at prevention in this way through some key activities. One is to generate domestic funding and to initiate national and subnational programs around prevention of mother-to-child transmission, and that can include triple elimination, which we'll talk to in a moment, but also around hepatitis C as well through harm reduction, or just in test and treat strategies to reduce the viral load in the community and reduce onward transmission. In countries where they receive donor support, whether that be the Global Fund or Gavi, we are working really hard on a global level for countries to maximize those opportunities. So we work on a global level, engaging these donor organizations, and help our members to engage on a national level. So when those new proposals are being written, that they include hepatitis within them. And as I said, a big part of that is building the capacity of our members in countries so they can better advocate, better engage with their local and national health systems, as well as any kind of donor support. And we also deliver in-country programs, especially around triple elimination. So that's the elimination of hepatitis B, HIV, and syphilis from mother-to-child transmission, which is a growing strategy on a global level, and something that was actually getting quite a bit of traction and can really help us in Hep B. So as I said before, we were actively advocate for organizations like Gavi, and through the advocacy that we did with partners, we did convince Gavi to start their hepatitis B birth dose program at the beginning of this year, and already 12 countries have applied and are set to start Gavi support for hepatitis B birth dose. Safe Start Plus is a program that's funded by Unitate, which is one of the first programs to be donor-funded programs to be looking at triple elimination, which we're leading along with PATH and other partners. So that's really in-country work looking at triple elimination. And we've also been running for the last few years our No Hep Mums program, which is a community-led prevention of mother-to-child transmission of hepatitis B program that has several layers, one of which is resources for communities to use with pregnant women in their own settings. So these are some flyers that we made that helped explain the process of preventing mother-to-child transmission of hepatitis, as well as some facts that pregnant women need to know. And these were translated into several languages and available for any community organization or any healthcare providers to download and use. We know that they were used around the world. And a big aspect of the program is also supporting in-country work. And this really looks at the partnership between community and healthcare professionals and the power that can have to try to drive prevention forward. So this is an example from the Liver Foundation of Bangladesh, where we worked with them on a program where they trained 25 midwives on hepatitis B awareness, counseling, and rapid Hep B testing. And the program has actually tested over 1,000 women and reached more than 4,000 with information about Hep B through posters, leaflets, and awareness raising. So I think it's a really good example of the role that community can have in partnership with healthcare and public health to prevent hepatitis B transmission. Another big aspect of prevention, of course, especially for hepatitis C, is harm reduction. So especially when we're looking at people who inject drugs, this includes needle and syringe programs, opioid replacement programs to reduce the incidences of injecting, and also hepatitis B testing and treatment. And we work on several levels with several partners about how we can promote harm reduction in different settings and around the world. And one example of this was working with TAG, an organization in Malaysia, around organizing an event that brought community and healthcare professionals together to discuss how they can take forward harm reduction programs in Malaysia, how they can promote hepatitis C testing, and also ensure that people are linked to care and they actually complete their treatment. So again, in the Hep C space, it's a great example of how community and healthcare can work together. And there's also fantastic examples in India around key populations and working around Hep C, which I'm sure maybe you've heard about some of those already today. And I think the third pillar, looking at it, is really treatment as prevention, because we know that curing people from Hep C and lowering the community viral load is a absolutely proven way to stop new infections. But also in terms of PMTCT, prevention of mother-child transmission, testing pregnant mothers, and if they test positive, that enables us to test the families and their spouses and to treat them if necessary, but also to vaccinate families. To stop any viral transmission within the household. And in people that are on hepatitis B treatment and lower viral loads are much lower risk of passing hepatitis B on to others. So treatment as prevention is a huge aspect if we're going to really create a generation free of viral hepatitis. But I'd like to kind of expand the prevention conversation out a little bit more and look at how hepatitis elimination is also liver cancer prevention. We know that 3/4 of liver cancer cases around the world are caused by viral hepatitis, and 1 in 4 people living with hepatitis B can develop liver cancer if left untreated. And of course, if you're also living with hepatitis delta, that increases the risk even more. So we've been working a lot this year and with partners in the cancer space around really shining a light on the connection between hepatitis and liver cancer and how hepatitis prevention is cancer prevention as well. And earlier this year in New York, there was a United Nations high-level meeting on non-communicable diseases. And again, WHA, working with partners, advocated and was successful in including a paragraph in the political declaration highlighting that to prevent liver cancer, you not only should vaccinate against hepatitis B, but you should also test and treat people with hepatitis C and people with hepatitis B. And this not only reduces liver cancer, but through monitoring can also provide a means to diagnose people affected by liver cancer earlier, so that they can enjoy better treatment outcomes if they do need to be treated. And WHO published at the World Health Assembly a white paper on this connection between liver cancer and NCDs, and you can find this on our website. So if you're interested, please do have a look. So just in summary, I would say that civil society drives prevention by bridging the gap between medical professionals and the community. They're able to deliver trusted prevention services, especially with communities that perhaps either don't have access to health care or perhaps are wary of accessing health care for various reasons. Strengthening the linkage and retention in care. We know we have a huge problem both in Hep B and Hep C between people being diagnosed and people actually coming back and being retained in care. And peer navigators and civil society communities can have a huge part in helping to strengthen that linkage. Breaking down stigma and discrimination, reaching those underserved populations, and making health systems work for the communities they serve. Because there's no point in setting up expensive services for communities if those communities don't feel comfortable using them. Working with civil society and people with lived experience can help design programs that actually meet the needs and will be used by the communities that they're meant to serve. So just before I go, I'd just like to invite everyone to the World Hepatitis Summit, which will be happening in Bangkok, Thailand next year from 28th to 30th of April. We have a really strong program with many presentations from the region. We've already had a lot of really fantastic abstracts submitted from India, but we also have the late breaker window open now for a month. So if you haven't submitted your abstract yet, please do. We've saved some oral presentation slots for late breakers, and we would love to see you all there. So with that, I just think I'll say thank you very much. Thank you.
Hello. Carry Vivek here.
Hi, Vivek.
Thanks very much, and it's a delight that you could join. Of course, my father's also sitting here. We're just listening to your talk, and again, just to thank you for all that you've done over the years through the Alliance for Hepatitis Elimination throughout the world. Thanks for your leadership, friendship, and of course, your support. It's been quite immense. Thanks very much indeed for joining us, Carrie. Hope to see you soon.
Thank you. Thank you.
Can we once again give a big round of applause to Mr. Carrie James, ladies and gentlemen, joining us all the way from the UK. Thank you so much, Mr. James. We appreciate it. We'll now move on to our next session, which is a panel discussion titled Coordinating Multi-Sector Efforts for Hepatitis Elimination. I'd like to welcome our moderator to the stage. We have with us Dr. Archana Ramalingam, Scientist, ICMR, National Institute of Epidemiology. She leads NCD-focused epidemiology and implementation research with state governments and international partners. She's a senior faculty and coordinator for the India EIS and intermediate field epidemiology training programs. And she's a former lead epidemiologist at ILBS, contributing to several major surveys. Dr. Archana, we're so happy that you could join us today. I'd like to just welcome our panelists onto the stage, and you can go ahead and further introduce them. Ladies and gentlemen, please put your hands together for our panelist, Dr. Ganesh Kumar P, as we welcome him on stage. Mr. Kannan Mariyappan, can we give him a round of applause? Mr. Sridhar S. and Dr. Kanudeep Kaur. Let's have a big round of applause for all of our panelists. Dr. Archana, over to you.
Thank you for that kind introduction. And good evening, ladies and gentlemen. It's indeed a privilege to be here to discuss with you on this important occasion where we are talking about prevention, elimination of viral hepatitis. So we have got a very good set of panel here, and we are going to discuss on how different sectors can come together and help for elimination of viral hepatitis. We've got representation from the Indian Council of Medical Research. We've got Dr. Kannan Mariappan, who's a Senior Program Officer with PATH. We've got Mr. Sridhar, who's a Program Director from Mission Samriddhi. And also we've got Dr. Kanudeep Kaur, who's a Program Lead for Hepatitis from Find India. So as you can see, our panelists are representing different sectors, starting from diagnostics. We've got people who work with livelihood, we work with rural community engagement, we've got people who work with health systems, as well as people who work with diagnostics, and also we have got the representation from the Medical Council in India, the Research Council. So let me begin with you, Mr. Kannan Mariappan. My first question is, we know that PATH has been working on several aspects for viral hepatitis. Can you tell us a little bit about your work on how hepatitis C virus self-testing is important and how it might change the game for the future? Yes.
Okay. So good evening to everyone. So thank you for inviting for this program. So with regards to hepatitis C self-testing, so PATH has done a study year back. In India, first time we introduced, the way we introduced HIV self-testing in India. So this has reached very big milestone where we could not able to reach the people. We never thought that those people might be reactive. Especially we did it in Mizoram and Uttar Pradesh state, like high prevalent and low prevalent states. And where we could able to identify among the high risk population around 80 to 90% hepatitis C reactive, which we could able to identify through health self-testing and then put on the treatment. So self-testing can reach the last mile and also do early identifications, and this will be a very cost-effective tool when we compare with the further cascade of the treatment and then the overall cost of the particular patient kind of things. So this is a very good sample size, and we have did it with around more than 13,000 populations with at-risk populations as well as with the pivot populations, both the settings. And if you see, they could able to use it very easily, self-testing. And then they also said that it is very easy to, they have a very acceptance level also more than 90%. And we also gone to the level to understand their willingness to buy the self-testing kits. Because when we talk about the self-testing, that's a major part of it. And WHO also recommends this as a substantial tool in addition to the existing other testing tools to scale up. And self-testing kind of things which is very important to reach the self-care model so that we can reach, and it is a self-sustained one and the individual can know their status, and it's a stigma-free tool. So we can engage multi-sectors in this part.
I think that's a very interesting thing that you're saying. Like, just a follow-up question on that. What do you think is the reluctance among these high-risk groups to go for testing? And therefore, why will it be important to have a self-testing? That's question one. And then I would also like to know, like, how do you train them to do the self-testing? Is it like a very easy one or how do you go about? And you also mentioned that they are willing to purchase it. So if so, what would be the cost?
See, this is a various things. That is going with the other component as well, the way you engage the community. See, if you have a meaningful engagement with the community leaders and then the community systems, then it functions very clearly. Rather than having a namesake committees and then engaging them throughout the program service delivery will be a challenging one. So we engage them as a resource persons. We engage them from the beginning of the concept development of this tool, even for the self-testing earlier study and for this HIV self-testing, even the study that we are going for, people often kind of same hepatitis related activities. So where the community is part of a concept note itself, and they will end up with co-authors in the manuscript. So they are part of the entire journey of the things. So that is how they engage, and they are the
facilitator as well. They are the mobilizer as well. They are the distributor as well. So we engage our things, and then one of our study, like a 60% of our study team itself from the community. So we could able to do that. That is how we could able to reach around 1 lakh study participants for that particular study.
I think that's very important, because considering the high-risk group is a closed group, as long as we don't penetrate their network, it might be very difficult to do any intervention. I think very interesting points that you have raised there, Mr. Kannan. Moving to Mr. Sridhar, who again works very closely with communities, especially rural communities. Like, given your experience in working with people for self-help groups or rural youth groups and livelihood, how do you think that these groups can help in hepatitis elimination?
Thanks, Dr. Archana. In fact, possibly I am one of the very few non-doctors in the whole forum. And thanks for inviting, and that itself is a great privilege and honor for me. Maybe I'll start with a recent experience. Probably about a year back, I invited Dr. Ganesh to one of our panchayats in Kadalur. The Gram Sabha was happening on that day, coincidentally, when he came. And we also requested him to address the villagers. And obviously, his topic was on health. And he was asking a few pointed questions. And we could realize that more than 80% of them were suffering with NCD. So, welcome to the new reality where villages are no longer seems to be healthy as we thought once upon a time, possibly because of the aspirations of the rural areas, including the speed of development which is happening, and the ambitions, and a significant change in their own lifestyles, including eating habits. So this is the reality in which Mission Samriddhi is working as an ecosystem. I want to give a brief about Mission Samriddhi that would help us to answer your question also. Mission Samriddhi is a social impact enterprise spread across more than 500 panchayats in the country, including a spread in about 75 panchayats in Tamil Nadu. We focus on holistic and social development for the panchayats, for which we have followed a set of principles. When we started this, we created a community development framework based on the design thinking principles. Probably the people who attended the last India Hepatitis Summit, you would have seen Mr. Arun Jain coming and addressing people on the way you can find solutions through a design-centric approach. We followed the same for our rural model also. We created a framework based on 5 strong design pillars. One for the personal development, which imbibes the personal values, the constitutional values, the hygiene, personal hygiene, awareness and all that from an individual standpoint, and the social development which talks about the integrated health, education, all the things which you are talking about, wash, or etc. Then the economic development, which all of us, it's a no-brainer. We all know what we need to do from a village perspective. Then the ecological sustainability, where a lot of things related to soil health, climate action, biodiversity, disaster risk, etc. And most importantly, the 5th one, the institutional development, where we are strengthening the governance model around the panchayats. So we put this kind of a strong pillar approach. Then we choose a cluster of panchayats, which we call as the cluster development program, in which 5 to 6 contiguous panchayats are brought together in the form of a cluster. So we have at a state level the program coordinator, then at the panchayat cluster level we have the cluster coordinator within a district. Then in each panchayat we also put the resource person. This is the way we put the foundation. Most important thing is we are not an NGO. As I mentioned, we are a social impact enterprise. And what we do is we have got our resource persons to run the program for a minimum period of 4 to 5 years. And we also prepare the soil. So we deepen our relationship, engage with the panchayat ecosystem, build the trust. So that is, once we put that foundation across, our endeavor is to create a parallel system of what Mission Samriddhi is doing within the community. For that, we need to strengthen the community, and what we do is we follow what is called as the connect, catalyze and celebrate mechanism, where we connect all the stakeholders together. In this case, specific to your question on specific probably to the hepatitis elimination on health, what we have done is we have started various camps initially to get them a flavor of what it is, for an eye screening or a health checkup or a mobile van which will come and do a periodic scanning for cancer, all those things. And over a period of time, once we started building the rapport, we got into some deep health and nutrition programs. For example, a nutrition garden or a herbal garden, or even and we also engaged with some of the groups like organizations like RUSEC to create awareness on sexual reproduction and health rights. Slowly but steadily, while these are all the programs which we do, we are running it through a bunch of people. Predominantly, the focus is predominantly on students and women. So we started creating the collectives for women, and we started the concept called Bal Panchayat, where the students lead a Panchayat program. And at some point of time, what happens is we are able to connect all the self-help groups. We are able to connect the youth groups. You are able to do bring the students through the Unnat Bharat Abhiyan, create a spirit of volunteerism, and this is the fulcrum based on which we started driving all our initiatives. And this is what we are striving to do on the health aspect as well. If you want to start talking about the hepatitis elimination, we cannot have a separate hepatitis elimination approach in a village. It cannot be on a silo. It has to be an integrated health program where every village requires some kind of an anchor. The anchor could be an individual who could be a powerful, influential village head, or it could be a strong women's collective, or it could even be a students' initiative like a Bal Panchayat. So what we do is we are not only bringing it a top-down approach on the broader vision, we are also bringing out a bottoms-up approach where the people themselves have to build a strong community network at some point of time so that they will help us to run these kind of initiatives. While we have since I have traveled across the country and since we are working in more than 500 panchayats, Tamil Nadu definitely is way ahead in terms of development, health, infrastructure, no doubts about it. Along with that, the side effects of our change in lifestyle also, which is having a deep impact. So what happens is, in these situations, this kind of a community build-up is what we are working on, and we have been extremely successful in many of the pilots we have done. And I am happy to tell that today we had an opportunity to talk to Dr. Ganesh and Dr. Vivek, and we are going to go a little deep dive on this hepatitis elimination in the clusters in which you are working. So that is one of the positive outcomes I want to highlight.
I think that's very interesting. One of the challenges, I think everyone would agree with me, is how to get the community actively engaged with health. You know, often we can engage very well with patients, but when we talk about prevention, or when we talk about reducing stigma, or when we talk about improving the acceptability of a certain testing intervention, or penetrating it into areas where we cannot go, I think communities and this sort of structure that you said, which acts as a fulcrum where we can really go and position these interventions, are becoming really important. I think that's very crucial when we talk about multi-sectoral, sort of collaboration for a larger perspective in health.
Yes. The most important thing is awareness is the first stage, but ownership is very important from a community standpoint. From an hepatitis elimination perspective, awareness means people in the villages know what hepatitis is. Ownership means the people should start asking us when is going to be the next health checkup possibility available. When are the first, if I borrow some of the terms, pardon me if I'm not technically sound, the first dose vaccination for my children, what has happened, for example, or this person has been referred for a better health facility, why that has not happened? These are the questions. If it starts coming from the community, that itself is a half battle won. At present, the penetration is not as deep, and it is more preventive and not proactive as of now. And while we have a PHC and the Anganwadi and the Asha workers and others, you have to go to them to say that I have a problem. And we, people like us, what we'll do is we'll make the people to understand the problem and the community to take the ownership of the broader problem statement. And when that happens, what happens is we also try to create a sort of a baseline data which would help us to keep track of it, and we also have a backup through our Intellect CSR. So we are also an IT savvy company, so we digitalize the records, we track, we do our own, we in fact follow a clear social impact assessment methodology, right from the inputs to the activities to the output to the outcomes to the impact. So we have a clear gamut of the sequence in which we need to track the progress of any initiative. And we have been successful. For example, the nutrition garden which we established in Maharashtra, we could touch more than 12,000 households. And in that region, the hemoglobin levels have increased because of that. And on the economic side, livelihood, more than 8 crore worth vegetable produce have happened in the last 4 to 5 years. And most importantly, from an incentivization perspective from a villager, the villagers should also feel that this prevention is going to help them save a lot of money. At present, unfortunately, rural India, probably on a lighter vein, I would like to compare rural India with the American lifestyle. Americans live predominantly on debt. We all know that. Here also, rural India also is living beyond its means because of various cultural, social practices. And if you are able to earn 100 rupees, you are spending 300 rupees, and the remaining 200 rupees is coming out of your debt which you are borrowing. So there is a huge perpetual debt problem, and most of the families are in a serious financial distress. And this is also putting a lot of stress on their mind, body, health, and lifestyles have changed. Alcohol is rampant. Drugs have become more rampant in all parts of the country. So all this is also having an impact on this health. That's where we are doing a lot of things, both preventive. One of the important things which we do, I'll finish, I know I'm running short of time. One of the important initiatives we have done is to make women understand what is called as the sexual awareness and reproduction rights, along with what do you mean by the gender-based biases in the society and all that. That kind of, it is actually a stigma to even open the topic. Since you are all doctors here, I can tell, we even go to the extent of telling the woman the difference between the urinary passage and the vaginal passage, which a volunteer from Mission Samriddhi along with some of the other organizations goes and explains to the woman what is the difference between the two. And now that volunteer is able, for example, interestingly we had a recent social audit. The auditor went, and this woman, a common woman who comes from a very deprived socially and economic background, is bold enough to explain what are all the things she learned. She was explaining this to the auditor without any discomfort or anything. So if you are approaching the lot of sensitive things around and the lot of stigmas and biases which are passed on from the generations, to clear them off to the society. And I will also tell you one important example. The future for India, I feel, belongs to stronger women collectives and stronger youth collectives. And these are the ones, if you are tapping them properly, are going to work wonders. And they are the ones who are going to help us in our Hepatitis Elimination Summit also. In the interest of time, I will stop, because if I want, I can tell lots of such things. And I'm happy to be part of this engagement, and we would definitely be closely collaborating with Chennai Liver Foundation and with Dr. Ganesh, and we will take this forward.
Thank you. I think very critical points that you raised. The ones that caught my attention are the ownership and also demand generation from the community. I think that's very critical for any program to be successful. Thank you. Coming to Kanudeep. So you are coming from FIND, and FIND is one of the organizations that really kind of has experience in market shaping for diagnostics. Now, what do you think are the opportunities that exist if we need to reduce the costs for viral load testing or for diagnostics related to hepatitis in general? What do you think?
Thank you, Dr. Archana, for this very thoughtful question, and thanks to Dr. Vivek for this opportunity. And FIND has done a lot of market assessments, and around that, we did a lot of market shaping also. But unfortunately, we have not done it for hepatitis, but we have done it for TB and AMR extensively. So, but coming to the viral load, bringing down the viral load cost, I think that the viral load cost is already very competitive. The prices are, very well placed if we check like globally also. And like Dr. Rivari also mentioned that the prices of the treatment are also very, well placed in India. But still, there are a lot of things that still can be done. Like one, We can, do the optimum DNO thing, diagnostic network optimization. So wherever there are high throughput machines and the load is less, so we can, do the mapping, and we can make best use of the machines where the load is less and can transport the samples. And for transporting the samples also, we can leverage on HIV and TB systems, health system, because they are quite robust and the HCV program is still very young. So we can leverage those systems of transportation and other stuff, and also machines. So without adding the cost, we can, bring down the cost of the test. And another thing is we can go in for smarter procurement choices. We can have like long-term contracts, and based upon the high disease burden, high volume of test, we can, negotiate on the prices. And then we can also adopt the reagent, these, what do you call them, rental models that can also bring down the price. And another thing we have learned from the COVID times, that if we promote the Make in India things, so if we promote those tests, that can also, bring down the prices and also assure the regularities, supply chain will be more robust if we can go in for that. But I would like to highlight one point here, that though the cost is very competitive, and we can still, bring it down. But my question here is, and it is covered by the National Health Program, NBHCP program. So we don't have to bother much about it on a personal level. And also this is not affecting the treatment initiation of the clients. What bothers me is, like I've been working extensively in northeastern part of the country, the baseline costs are the major bottleneck there. So the cost of the baseline in some part of the country, it's totally free, and some part it's very affordable. But if you come to the northeast, where the prevalence of hepatitis is really high, the PVIDs are there, which, they can afford drugs, but they cannot afford the medical test. And the cost is as high as 810 rupees for the basic tests that need to be initiated on, they are required to be initiated on treatment for hepatitis. So that's the major bottleneck. And I think if we can, do some kind of advocacy to bring down those prices, or, make it free all across the country. I know health is a state subject, but still, I think there is a lot to be done on this aspect.
No, I think very interesting points what you said, and I really like the idea of optimization of the existing diagnostics. I think that would be very critical even for states, because the high throughput machines are located maybe in some prominent medical colleges, and then how to link them so that with the other places where it's not existing, whether there is an hub and spoke model or something that we can test. And that is something for the state to consider, and I think that's very important when we want to overall reduce the cost. I think that's important, and I totally agree with you about the Northeast having a lot of problem. I think also that's something for the national program also to take into consideration. Thank you, Kanudeep, and coming to you, Dr. Ganesh. Like, one of the things is now we are speaking a lot about multi-sectoral coordination. You heard from the other panelists. You heard from our panelist from PATH who's talking about self-testing. Then you also heard about how we can engage community, increase ownership. And we also talked a little bit about how we can use hub and spoke for throughput. Now my question is, now these are all different strategies, different interventions. Now how can we translate these, sort of potential interventions into research and actionable policies so that we can act and move forward for, viral hepatitis elimination?
Thanks for that question, and I'm really going to view all the other experts' opinions together, because at the end of the day, whatever the strategies or the interventions that which is coming up in different models, the ultimate thing, it is getting converted as a policy which fixes the sustainability aspect of it. If there is no policy, there is no sustainability. It ends when the project closes. Then second is that policy brings investments, policy brings partners together. So that's the most important key aspect of the bridge. From policy, it needs to get into the practice. So policy is something like kind of like a larger ambit. When it comes in terms of like converting all these evidences, models
into policy and practice, I used to take three things. One is called what, another is who, another is how. The what is all these strategies which have been demonstrated, and what is the level of evidence that it is working in the field. And second, the who is, who are those people we need to bring it together, who can convert, if it is brought as a policy, into a practice. How is the implementation science gap, which tells about, given in a constrained setting, to be very frank, as clearly said by Sridhar, in the community they don't see hepatitis separate. They see health, that's it. They go to a doctor, they say, I have a health problem and this is a problem that you need to do. When we are considering an individual, we don't see them as in silo, they don't see a health as an in silos. When we are totally moving into silos, when we are thinking hepatitis, we should not think in terms of the same silos. What I am trying to say here is that loosely the term kind of integration is very hard to do it at the ground. Fundamentally, whether this is a low-hanging fruit which is need to be addressed. This is a candidate disease which can be eliminated very easily because we have a proven vaccination, we have proven drugs, we have a testing strategy. The problem here is that we don't know how. That means what actually, how to do that in the ground. There were multiple models we will be saying it, but whether that fits into, say like for example, a village in Tamil Nadu, the same thing whether it will fit into a Nagaland in Kohima or in Mokokchung, whether the same thing will fit into a Ladakh, we don't know that actually. There brings something called an implementation science which addresses the how. Without these three clarity, it is very difficult to convert the policy into the practice. It's a very resource consuming exercise, but that's how we did it in our past in maternal health. We did the same thing in neonatal health. We did the same thing in immunization. These are our few success stories to say that we demonstrated into that. What we are not doing currently is, we are now more enthusiastic, jumping on, we could do this, but we need to go to the past, how immunization got matured over a period of time, how maternal health got matured over a period of time. Actually, that addresses that what, who, and how. And this was clearly done by multiple exercises with a lot of international partners. I would also proudly say one diseases where we have progressed to an end, but we are still struggling is that tuberculosis. This also has tested multiple strategies. It brought into what, who, and how, and to an extent, we know that why it is not working. The same thing is also should not happen for hepatitis actually. In HIV, there were a lot of resources, a lot of attention, huge amount of policy uptake, but this may not happen for hepatitis also. So with considering all this reality is what I would just park here, all those people who were working on an hepatitis, I would cautiously park that. This small looks like a low-hanging fruit, but that is a very difficult fruit to fetch.
No, I completely agree with you, Dr. Ganesh. I think the how is the main question here. And like just to share an example, recently we had this discussion. The government of India says for MASLD or even for viral hepatitis, we need to do a FIP4 testing. And then when we actually went into district hospitals and CHCs, we found that number one, testing was through a hub and spoke, and therefore the report turnaround time is huge. And then the report comes to a lab person who is not linked with the patient. So unless the patient goes and asks for the specific test, you don't get it. And then once you get it, who is going to do the FIP4 calculation is another next question. It doesn't come automatically in the report. And then how does the medical officer decide? He cannot in a busy OPD calculate FIP4. So these are like the questions about how. You know, these are very good interventions, these are very good guidelines and policies, but when we actually talk about implementation research, it's to go into that nitty-gritty of who is going to do the FIP4 calculation, who is going to do the report, which nurse will then interpret it, or which doctor will then use the medication. I think I totally agree with you that while we have listed various good practices and interventions, it comes to, at the end of the day, how to implement it. You know, I think with that, we would stop here for this round and open to the forum for any questions. Yes. Does he have a mic, or you can probably use that mic, sir? Yes. Yeah.
Yeah. Thank you. This is not a kind of question, but suggestion. This is Kannadasan. I'm from Eco India. So actually, this is related to the self-testing kit, because I was previously working with TANSAX, and Dr. Janaki Raman sir was my DD that time. So that time I attended the training session for the self-testing kit for HIV, but somehow I think it is not rolled out. But what the state is doing is CBS, community-based screening. So in the community-based screening, they are taking the HIV kit along with the syphilis kit also currently. They are going to the community high-risk groups like MSM, FSW and all those, TG and IDU. So my suggestion here is like Gerard sir also here, so the rapid test kits can move to TANSAX, and TANSAX can give it to the CBOs, which is CBOs and NGOs. 80 plus NGOs in Tamil Nadu and 5 TIs in Puducherry is involving in this community-based screening. So at least the high-risk group people can be screened easily, because they are already doing it for syphilis and HIV. So this is what I wanted to share. Yeah.
No,
thank you, sir.
That is the point that I want to make, and then I want to request the panel chair also that, see, the multi-sector engagement, the community-based screening, when we worked along with Tirvari sir in NACO as well as in the WHO also, we were talking about decentralization. Now it's an integration. Okay. At the state level, you go ahead with the integrations, because there are different layers, different dialogues goes on the other things. But at the field level, what is best for the population, what is the best to reach, the way you are telling that TANSAX can do or a hepatitis program can do, the MD NHM can decide, because the NHM authority and health secretary's authority can decide how this program has to converge and talk each other. The resources are there, diagnostic kits are there, and then the entire machines are there. Even now, what is left with the COVID diagnostic machines are lying as it is, TB machines are as it is, HIV machine as it is. So different machines are there where we can integrate, many things can be done. So that state is a health subject. Take a lead and then go ahead. Nobody is going to stop on that. Why we have to think about? Yes, we are also, as a diagnostic big agencies, we are also working on multiplex kits. Like the way you are telling about dual test kit, there are triple test kits also there, and we are also working on 5-in-1 also. Might be in another 6 months, this will come into the market, our ICMR will get approved and other things. We will introduce. So that will change the entire dynamics of the program, and cost effectiveness will increase. So let's start from the ground. Don't wait for the policy to make changes. Let's do the pilot.
So just a piece of information. Now dual test kits are being used widely for antenatal care and for people at high-risk groups. WHO has recently approved the triple test kit also. HIV, hepatitis B and syphilis. They have also been WHO pre-qualified. So there is another opportunity where PATH or somebody find you can do a kind of implementation in India. That could be a way forward moving ahead, particularly for the high-risk groups.
Definitely, sir. Yes. I think Dr. Gerard and then Dr. Janaki Raman also has got a question. Yeah.
Just out of curiosity, the PATH experiment for self-testing for hepatitis C. Normally, like there are certain areas where we are trying to do the self-sampling. For example, in cervical cancer, the self-sampling for HPV testing is one which slowly every state is trying to introduce. What is the actual purpose? What was the driving force behind your experiment to experiment this self-testing of hepatitis C virus? For two reasons I would like to ask. One is, priority-wise, hepatitis B is much more challenging compared to C. But treatment-wise, hepatitis C is much amenable to treatment. So you can achieve, once you detect, you can treat, say 3 months or whatever you say, 3 to 6 months, you can treat the person. There are two sides of the coin for hepatitis C. But whereas in your, is it a more of a, there should be some more reasons than something is like, something we need to understand better.
Okay. I would put it very gentle, not very scientific as it is. Hepatitis and HIV, both are more behavior-centric disease. People will never say that I have this, or I am prone to this, I am the high-risk populations. But I wanted to do it, but I don't want to do it in front of you, or I don't want to come to your center to do it. Because you have all sort of records there. That is one side of the things. The other thing is that if I am affordable, I can able to do it, I do it in early stages, rather than waiting for the symptoms to occur and then come to the facility and then do it. Self-testing helps me like the way a pregnancy test. I can do it on myself. Last week I went, I know some knowledge that window period is there after 1 week or after 2 weeks. At least if I do this test, it will give me indications. So I can do that. If self-testing is not available, I never do that. I will wait for the symptoms. That is what the best example of our NACP program. Still now, our CD4 count range is still average 200 to 300, which means we are identifying the patient after many, many years. We never gone to a level of early identification. That's the same thing is going to happen for Hep C as well. So self-testing kind of a self-care component is very important to reach the patient at an early stage so that you can treat. Like the Hep C, you can treat totally, not like HIV. So these kind of tools will add to reach the global SDG goal where we have to reach 95 target or 100%. The early identification, if you don't do the identification of the patient, then rest of the cascade is totally empty. What we have is also, even what we say 80% we identified, no, it is only on the high risk or prioritized population as per the program, not generalized population wise. So it's still a large group that we need to reach. And health infrastructure is not sufficient.
Can you just briefly say how the methodology, like what is the kit, what is the type of kit you give to the community?
Yeah. So we have two types of kits. One is oral based and then the blood based kits. So in the saliva also we can do the self-testing for HIV as well as for the Hep C. Even syphilis also now self-testing is available. And for the blood based, there are different type of things are available. Solution you have to do or different methodology based on the company's product. That's how. For saliva based, is only one company right now. It's like a monopoly. Vora Quick is having it for Hep C and then HIV. Indian based, there are companies are there for HIV self-testing, not for HCV. That's all.
So you are trying with the other one, the first one you mentioned. And what is the positivity rate like?
Positivity rate is like we have for, when we did for HIV, it was 3%, but for HCV, it is different. For HCV, among the high-risk population, 80%, at-risk population, 3% in Mizoram. In Uttar Pradesh, it is around 10% in high-risk population and almost 1% general populations among the self-testing.
Now I have a very quick question on top of this. Like, what was the reporting mechanism? Like, how you're reporting or notifying, people are notifying it back? Because that's another catch to the self-testing.
Yeah. So for us, since it is a study, we had our own reporting mechanisms. So we had a WhatsApp number, they can click the results and then they can do it. And we had a peer educators who with them, with the assisted and unassisted approach was there. So both the system was there, so they could able to understand and read the results. And for the self-testing is, our IFU is very important, that instruction manual. So that is very colored picture and anybody, even an illiterate can able to understand. And that is how we did it. And then they could able to read and understand, saying that this is a reactive, non-reactive kind of things. And they reported, and then for us, for HIV and Hep C, almost 95% came forward for the confirmatory testing as well. So that's a good time.
Have been registered on the national portal.
Yeah.
Okay,
Thank you. I think the organizers have told us that the time's up, so I think it's a very engaging discussion that we have had, and maybe over coffee you can all discuss at a later point. Thank you so much, and thank you audience for the attention. Thank you.
Thank you so much. We now move on to our next session, Strategy and Scope of Triple Elimination. I'd like to invite our chairs to please take the stage. Starting off with Dr. A. Ilangovan, Scientist G, ICMR, National Institute of Epidemiology. Dr. Ilangovan leads the CIS division with advanced infrastructure for data management, electronic data capture, and scientific computing. He's got expertise in data management, modeling HIV/AIDS, and environmental research with over 50 publications. We welcome Dr. A. Ilangovan. Also joining him on stage is Dr. S. Lokesh, Scientist E, ICMR, National Institute of Epidemiology, who has expertise in emerging and re-emerging infections, neglected tropical diseases, mental health research, and ethics in biomedical research. He has 50 plus publications, multiple book chapters, and is the holder of copyrights and provisional patents. He also leads several intramural and extramural research projects, contributing to advancing public health. Welcome, Dr. Lokesh. Joining them on stage will be Dr. Pallav Bhattacharya to round out this discussion. Welcome, sir, and I hand the stage over to our chairs.
Okay, very good afternoon. Thanks to the Chennai Liver Foundation and also to the other partners for bringing this important summit. So far, we have been discussing with some specific focus on hepatitis. Now, we are moving one step further. Along with the hepatitis, we are going to talk about the HIV as well as the, I think syphilis also is going to be included. That is called triple eliminations. Sometimes this is called EMTCT, elimination of mother to child program. This is the horizontal type of elimination. It is very difficult. We are talking about the hepatitis B. Even eliminating hepatitis B itself very difficult. When it is compared with the HIV and as well as syphilis, then it will becoming more difficult. Very challenging job also. In the globe, Maldives, it is a small country, it has achieved the triple eliminations. Maybe that is because of very small country. If you consider the population is less than that of many of the district of Tamil Nadu. So they could be able to make it. But however, that gives us a hope. How we can also start. We are talking about the pilot study. This Maldives can be considered as the pilot to the globe. I think in the same way, by following the same path, I assume West Bengal also initiated some steps in eliminating the triple infections. Like you, as mentioned in the brochure, I also waiting to learn the lessons, what it has been done in the West Bengal, so that if it is feasible, workable, that can be implemented across the country. Yes. So with this word, I invite my colleague, Dr. Lokesh, to add his remark.
Very good evening, one and all. I take this opportunity to invite and introduce the speaker for this session, Dr. Pallav Bhattacharya, who is advisor for the State Task Force on Triple Elimination of vertical transmission of HIV, syphilis, and hepatitis B in West Bengal. He has got over 35 years of experience in public health and has contributed to national and state level initiatives in NACP, adolescent and school health, communicable diseases and viral hepatitis. He has worked with UNDP on various public health initiatives, and this stage is over to you, sir. You can kindly proceed with your presentation. Thank you.
So, good evening, chairs and all the esteemed delegates here. We are all well aware of the hallowed goal of elimination of HIV, syphilis and hepatitis B, all of these infections, in fact viral hepatitis B and C together by 2030. But perhaps most of us would be harboring lurking thoughts as to the need of shifting the goalpost from 2030 to beyond. So, against this background, when we brainstormed and looked at the scenario, what we could garner is that perhaps we could then reposition the thing into incremental responses and first go for elimination of vertical transmission for these three infections. Of course, the story of elimination of vertical transmission had begun over 2 decades ago with prevention of mother-to-child transmission of HIV. Then it shifted to PPTCT, or prevention of parent-to-child transmission. Syphilis was not in the picture then. Syphilis added up. It became elimination of vertical transmission of HIV and syphilis within NACP. And separately, the youngest program, NVHCP, came up with, not elimination mind you, prevention of mother-to-child transmission of hepatitis B. So, what we then moved is taking all these three together and trying to explore if that was a feasible option. What we could arrive at is that it was feasible as an incremental response, and it could happen by the end of, if not by the end of 2026, at least by mid-2027. So that was enough evidence there garnered to look at it, and as we progress. So what we are aiming at is a mission mode implementation towards elimination of vertical transmission of these three together by mid-2027 at the most. So let's look at the rationale. We understand that the transmission modalities are similar for all three. Again, the population we would be addressing is the mother and the child within the cradle of the maternal and child health program. Long latencies have already been discussed. We have effective test and treat interventions for the mother and the exposed infant, for all three. And of course, if we effectively build up a sound foundation, prevention of lifelong consequences could be averted or aborted. And of course, improved maternal and child health outcomes would definitely follow. And as a public health impact, we could bring down incidences and the burden for all the three infections. So that was the rationale, and this is the rationale for all of us as to why we can go in for triple elimination. These were the pre-existing gaps we could identify because of the fragmented and isolated approaches that were there. Like you see, despite high antenatal care coverage, there was missed opportunities regarding early linkage to care. That was very important. At the earliest, linkage for ANC services,
of course, achievement of universal screening targets. This is, I'm talking of, say, late 2022 to early 2023, when we got onto the drawing board. And again, retention across the care cascade. So this were pre-existing gaps. Again, for the exposed infant, despite 100% of HIV exposed infants receiving prophylaxis, the reported positivity among the cohort of screened infants linked to the program, at 18 months, there was a gap. So again, data across the service care cascade of syphilis exposed infants was missing. There was nothing. Syphilis happened to be the orphan child amongst all the three. So again, there were limited metrics of hepatitis B exposed infants. In fact, the child was never in the picture in a proper manner. From there, we worked towards a health systems approach and a response in totality, not a pound of flesh to each, rather the mother and child together, as was being talked about in the earlier hours. So again, there are about 16 lakh annual pregnancies in West Bengal. Annual pregnancies are 16 lakh. So addressing that, and of course, not to do away with the private sector, it should be a comprehensive integrated approach. That was the initial thought that we had as we sat to plan it out, because West Bengal has around 30% of deliveries in the private sector. It's 70-30, the ratio. And of course, no business as usual, it should be mission mode. That's how we working towards 2027, mid-2027 as the elimination timeline. And all three have been handled differently in silos. We also brought in the MCH, Maternal Child Health Program was the cradle, and all the relevant professional bodies, as you see, from IAP to IADVL, were actively involved. And as you see in the governance structure, we'll see later, all were part of the state task force from the very beginning, so that a sound, collaborative partnership and ownership could be built up. And uniform guidelines could be followed across the state at all levels, whether be it public or private facilities. Of course, that needed a lot of effort. We'll be going into that. As of now, there is no national integrated approach in this particular area. So our effort became a drawing board, because we had to draw in from, and as you understand, as was being pointed out by Dr. Elengovan, that Maldives happens to be a country less than a district. It could be a taluk or tehsil in any of our states. So you can forget about Maldives. That won't work. Presently, 2 other countries are into some serious effort. They are Brazil and China. And of course, both are going into subnational approach. So naturally, you understand, India again needs to go into a subnational approach. So we naturally took up that let the state take up the onus. As has already been mentioned, Dr. Kannan was also mentioning that state has sufficient resources and the ability to work out a path, and then of course we can amplify and replicate all across, contextualize according to the needs of each state, because each state happens to be a country in itself within India. Such happens to be the diversity. So again, national integrated, so again, this perhaps could be a bottoms-up approach. This would again be a novelty in the sense that once states begin to create this program, the country would then be able to build on that and do it. In fact, as someone was mentioning, I wasn't, because of the paucity of time, I wasn't talking. The prison intervention now worked on by the national program, that transporting samples and all, was again begun in West Bengal. So they picked it up, Sandhya and all, they came and sat and worked out as to how it is happening. We even have in 1 or 2 places, very major correctional homes, viral load facility has been put in the prison itself. So that again, it's sort of a reflex POC testing, and then because the prisoners would go off, UTs, the big chunk are the UTs. So that's digressing. But then, importantly, the foundations would have to be, these are the enabling drivers. They are the foundations. Sound ANC coverage, good ANC screening, and that again has to be, I need to emphasize, it has to be early. We should promote very early ANC screening, high institutional deliveries beyond 90 to 95%. Our state, in fact, now has 99% of institutional delivery, and ANC coverage is 99% now. So, immunization coverage again has to be very good, and I am sure, I am not forgetting the data, but I have seen Tamil Nadu already is sound in all these areas. So, because these are the enabling drivers. Once you have a sound foundation, you can build up the edifice. That becomes easier. So, this can happen. So, the opportunities for integration lying in ensuring universal triple screening protocols earliest in the first trimester, at the lowest levels, at the sub-centers. So, that mechanism has to be put in place. Timely prophylaxis availability and coverage for deliveries of known and direct in labor cases. So, that is again important, because there would be direct in labor cases at the higher levels. So, naturally that has to be accounted for. Coordinated governance across different departments, because at least 5 to 6 you will see later that they have been involved. So, and integrated data systems. We have built up it's called STEM, System for Triple Elimination Monitoring. So, an integrated data system has been created, digital version, where a mother, once she comes into the system with pregnancy, from there to the birth and 18 months of the child, all of it is captured, person-centric captured in the data system. And of course, training is very important. Responsibility allocation is important as to who does what. That is again important. And task sharing modules. Because as we went along, we realized that defined responsibilities should come from the A&M upwards, and blocks at BPHN and everybody. So we know that there's an established success of the dual elimination strategy. Some of the countries, quite a few countries have done that. This again would help in optimizing workforce capacities, helping each program. We found that each program was helped through this, and of course, cost effectiveness is brought forward. So, as I was telling you, service delivery, high service coverage rates, integrated diagnostics and commodity availability, logistics, seamless logistics, that is very important. We need to see to it. So, adequate availability of the kits, efficient and functional cold chain point availability till blocks, and that to be monitored regularly for quality. So, that is again an important thing. And of course, well-defined HIV EMTCT cascade already exists. So, services for HBV could be co-linked to that. So, we have a state RCH portal, Matrima, like you have one. So, this, data from that at the first recording is fetched into, for all positive mothers, is fetched into the new portal that I was talking of, STEM portal. So that all positive mothers line list is captured there, and then the whole journey is tracked on that particular portal. And governance again is important. So this has been the journey. There has to be a state level task force that was created somewhere in July 2023. There is a multidisciplinary technical advisory group assisting the whole activity. So a situational assessment was done across 4 districts, and it was a major learning exercise. From there, everything else emerged. So December 2023 onwards, when a whole package was ready, the journey had commenced. Professional bodies, as I had told you, were brought into the loop, and of course district level TOTs, etc. began. As we went along, importantly, in late 2024, we did a under 5 HBsAg prevalence estimation, because that's one of the impact indicators. Importantly, we have clearly defined indicators as to where do we need to reach. Those are the impact indicators, and there are process indicators which help us reach there. Process indicators basically would be 95% and above of screening and treatment for all three. So that's the process indicators, and because of the paucity of time, I won't go into all the impact indicators. Just because this is a hepatitis summit, I can mention that for hepatitis, it would be MTCT rates of below 2% and under 5 HbSAg prevalence of less than 0.1%. So that is one of the indicators we can mention here, that that's just at the early stages of publication. That would be going into the next WHO bulletin also, that we have achieved something like 0.07% of HbSAg prevalence in under 5. So that is one of the indicators is done, at least for hepatitis B. So again, state level TOT and all, and now the whole state is covered. From a pilot for about 5 months, we moved to state level implementation. So these were the key gaps identified through the situational assessment. Despite very high coverage of facilities, gaps in screening for all three in the first trimester. I mean, early screening there was a gap. So now it has been streamlined and strengthened to ensure that all screening happens within the first trimester. So that is an important thing. Again, quality of testing, that I'll be going to later. There were gaps in quality of testing. So understanding, because the first test, over 90% of tests, screening tests would be done by the ANMs. So they need to have sound foundations and understanding of how to test, when to test, how long to keep the kits, when to bring the kits, thawing them and all that, everything. So that clear understanding has to be created. There was limited awareness. The poorest awareness was surrounding syphilis. This is just to mention, we found later that in sync with the global evidences, syphilis prevalence is now on the rise, and syphilis prevalence was found to be well above HIV prevalence amongst even in this cohort. So see around 60% of ASHA or ANMs knew about the nature of the three diseases. So they needed to be strengthened. Again, there was gaps in case finding, lack of defined protocols for syphilis and Hep B, challenges in M&E, and of course, very importantly, siloed governance. The left hand not knowing what the right hand was doing. So through this, this was a declaration where everybody, all concerned stakeholders were there. This was how the intervention package was finally designed. Governance structures, as I had mentioned, up to the block level. So formation of STF, TAG, district nodal officers, specifically for triple elimination identified amongst the district level officers, because this had to be done in the mission mode, and facility EMTCT nodal points. Again, importantly, delivery of HIV and hepatitis B positive women has been decentralized to the BMOC facilities. This was a major shift, and BPG based syphilis treatment has been taken down to the blocks. So for all syphilis reactive mothers, 3 doses of BPG are being given at the level of the blocks, ensuring avoidance of loss to follow-up. Digital EMTCT portal has been brought out, and private sector engagement has been ensured, enabling HIV and HBIG and vaccine supplies from government stocks to privates when in need. So this has been effectively worked out. And of course, the regulatory framework of the Clinical Establishment Act has been specifically strengthened with pointers given to the privates that all this has to be reported, and every case has to be informed and notified. Comprehensive capacity building exercise has been carried out with sufficient materials created and specific materials, specific modules for each of these segments, including job aids, flowcharts, and QR coded videos for testing, so that they could self-learn at the lowest level. And of course, hepatitis B was made notifiable in the state. West Bengal was among the first 2 states to do it. So that again has ensured strengthening of the capacities of the privates. Capacity building again has been done across all tiers and healthcare providers trained. So lots of materials have been developed. So we are open to sharing and contextualization according to needs with the state. And of course, very important is guidelines for seamless logistics management. Syphilis management was hampered seriously because of the lack of commodities in the form of BPG and aqueous CP for the child. BPG for the mother and aqueous CP for the child. Though very inexpensive, the national program also failed to keep up to the supplies. So ultimately, the state has ensured seamless logistics supply. This has to happen if we need to ensure that elimination as per target has to happen. And of course, syphilis registers, because syphilis management has been decentralized to the blocks for the pregnant woman, syphilis registers specific to the mothers in triplicate have been created at the level of the blocks, and for labor room, LR registers have been created because labor room was found to be out of sync of the whole system. And of course, integrated governance and mechanism has been created. Roles, responsibilities categorically defined for various categories of staff. This has been outlined. And as I had mentioned, dedicated block review meetings have been created, and triple elimination included as agenda in all the district level meetings with defined agenda given. Because often we are well aware that in meetings what happens is we come together and talk of all this has to be done, this much has been done without any data or anything around, and then say goodbye. So definite agenda, defined agenda has been created as to how many mothers were there in the last month, what have been the services catered to, and what is going to happen in the next month. So that this has to go down to the district. From the blocks, the district level minutes have to go to the state every month within the next week after the meeting. So this is the standard operating procedure and the framework which was created for triple elimination. Some of the IEC materials developed for the community and for the facilities. So a counseling booklet to aid counseling at for the frontline workers, because they would be the first point of contact. So definite counseling material was created for them. This is just a glimpse that I am giving you. So various job aids were developed. You can see the QR codes there. Those are the training codes out there for dual RDT, for hepatitis B, so that the ANM can, if she is forgetful, she can look at it and then go ahead once more. Of course, some of the snapshots of the IEC posters and job aids developed for private sector. Private sector material was developed separately because they won't be needing all the whole compendium, and for their ease of functioning, this has been created, and in most of the private hospitals now you will see they are being displayed at the service delivery points particularly. This is a glimpse of the labor room form in duplicate created so that one goes with the patient and one remains with the labor room for records as to what is happening. So these are just glimpses. Some of the pointers, importantly what you will just look at the last, syphilis. Overall screening positivity among all pregnant women is 0.09%. So syphilis remain hidden. So now courtesy triple elimination is out in the open. So that is an important learning that we need to understand. And of course, you will see that lot of syphilis cases could be identified. This would be the, I can guarantee you, this would be the picture countrywide. So that is how it is. It's 0.14% for hepatitis B, that's the prevalence now, 0.14 to 0.15. HIV is, here it is mentioned 0.03, but recently we see it's now 0.02 for West Bengal in the latest reports. This is just a glimpse of the dashboard that I was telling you, of the portal that has been created, so that the district functionaries, the state functionaries can get a live picture as to what is the situation, what has happened. So coming to the crux, key takeaways: decentralization effectively combats loss to follow-up and improves timely treatment coverage. So we have decentralized delivery for HIV and hepatitis B positive mothers to the blocks. No mystics, no magics, no keeping them up to the upper tiers. Integrated governance, that is important. So that's how that nodal officer thing for district level triple elimination has been created. One of the deputies for the CMO has been assigned this task. So from silos to synergy would ensure sustainability. That's the basic thing. Otherwise, it would remain nobody's baby. Private sector engagement, it's very essential for good HBIG coverage and data completeness, because a significant section of deliveries would be happening there. So as I mentioned to you, the state enables and cooperates, particularly in far-flung districts and all, where HBIG availability would be a major issue. They get to access HBIG from the state, from the governmental facilities. The district provides them that. And data completeness is an important thing. Digital tools are critical for tracking exposed infants, because that was never in existence. That would also not be in existence here also, because that was never looked at. So person-centric digital tracking for the mother and the child up to 18 months is what is important. Again, continuous training and quality assurance cycles would sustain implementation quality. So we have added NQAS into the whole effort. National Quality Assurance System has been added into the whole effort. And of course, targeted training approach. What happens in many of our trainings is that the same capsule is given to lots of segments. So it's segmented, targeted training approach would be implemented, would be essential. And of course, implementation of universal protocols. Way forward is strengthening community engagement that had come up in one of the earliest sessions with PRIs and SHGs. That's the process that we are into. Stringent quality assurance reviews using triple elimination specific quality assurance tools that have already been developed and are in the process of being applied. And of course, testing also, EQUAS has been put in place for these kits. Ensuring sustainability by embedding EMTCT functions into routine RCH and district reviews. It's not a standalone. In all the meetings, this has been incorporated. And of course, syphilis still remains a bottleneck. Increased focus on syphilis. This is the remaining bottleneck. Now we identify hepatitis B elimination would be possible. Syphilis again needs to be geared up to ensure that triple elimination is achieved. That would be my rejoinder to you also, and focus on consistent screening, BBG and echo CP supply, and infant follow-up. These logistics, seamless logistics supply is very important. You need to ensure that they are available up to the blocks if you go in for decentralization. So let's ensure that each child is born free, remains free, and is forever free. Thank you.
Thank you, sir, for that wonderful presentation. For the want of time, I would request we can take up one question at the most. Madam, please.
First of all, we just want to congratulate you. This is astounding. I mean, those of us sitting here in the audience can't believe this is happening in our own country. One major, how did you get government buy-in to this?
Government buy-in is basically, yeah, that's advocacy. Essentially, the whole pitch was that that hallowed elimination target is hollow. That we clearly defined to the top brass. And then we made a presentation also. Even finally it was again moved to the CM also, that yes, this can be done and this is achievable and this will benefit the mother and child. Because mother and child is a touchy issue all around. MCH happens to be a very, popular program and a precious thing for all governments. So this would impact the mother and child health, and our indicators would improve with this if we can do this. And this is achievable because the soil is fertile. We pointed out that these are the HMIS indicators wherein we have done good immunization coverage. So nobody, they could then not deny that yes, so this will be a feather in the cap. So the government, it will benefit the governance, the political will, and of course everybody. So that way it was pitched.
And how did you manage intersectorial synergy? Sometimes it's all very theoretical, but when we go away from the meeting, people don't really want to stay.
Yeah, exactly. That was a very big challenge. Even at times, some come out with that in their heart of hearts. So, but then, from the very beginning, from the planning stage, we brought all together. It was not because this was a learning from my, if I can share, Dr. Rewari is around or?
He just left.
He's just left. Because from my NACP and NACO days, I learned a lot of things as to how to do. I also learned what not to do. So one thing was not imposing something top down. So that we then again sat across the drawing board, brought all the other program people together, and then jointly developed the strategy. Not that it was developed by a few from one of the programs, no. All the NVHCP, NACP, MCH, RCH, and later on we brought in the quality assurance people that you can do this, so this would help. So all together we did brainstorming. Then the technical advisory group was added up. It was multidisciplinary. So they also sat together. It took about, say, 1.5 to 2 months to, after all that brainstorming and debate and whatnot, to finally crystallize it. And now once the government has finally said yes, so no program can deny it. So that's how it was done. So it needs some painstaking effort to bring all together on table, because in the first presentation I made in Delhi, I mentioned that NACO has been talking from 2016 that yes, we need to converge, but that could happen only in 2022 or something. So from theory to practice, preaching to practice is a very difficult challenge. When we talk a lot of convergence, lot of synergy, but then making it happen is something, but it can happen. So this is an example. That's why I say Tamil Nadu also can do it, because good indicators are here. So thank you.
Thank you so much for that very interesting session. To all of our dignitaries on stage, calling upon Dr. Malarviri to please do the honors and present them with the token of our appreciation. Thank you so much. Let's have a big round of applause. And as we come to the end of this wonderful event, I'd like to call upon Dr. Vivek to please deliver the vote of thanks.
Good evening, and of course, apologies to Dr. Ganesh to stop his session because it is getting late. First, I'd like to thank everyone for coming. Of course, I'd like to thank first the NHM team, because I have to say I was very skeptical, whether people would turn up. I was panicking, but we had a full house today, and so thank to Dr. Jared, Dr. Beulah, Dr. Gracia and team. So thank you very much, sir. I thank the entire panel of faculty, all senior people, Dr. Priya, Dr. Pallab from Calcutta, and the rest of the others for being here. I thank the faculty, thank the hotel management for putting up a good show, and of course, last but not the least, my own team. I have to say I didn't do anything for this meeting. It was all done by my team. predominantly by Vaishnavi, Gomti, Subha, Sneha, Karthik. About 5-6 of us put the whole show together for us. I just created the frame, but then they built everything on top of it. So thanks everyone. I hope you enjoyed the day. This is not the end, this is only the beginning. We're going to do more work together, as the MD NHM was saying this morning. So we're going to need to all put our brains together and work together and work towards hepatitis elimination. Thank you very much and safe travels home. Thank you.